Good morning, everyone. I think a very good morning to all of you here. Let me not waste too much time. I think it's exactly 8 o'clock. I think we'll start the first session, which we start the day with a free paper session. So I request all the postgraduates to come forward and take the seats here. Let me invite the chairperson for this session, Dr. Anil Kumar, Dr. Johnny Joseph, Dr. Jubil Matthew, and Dr. Shivashankaran. I request also Dr. Matthew Ipe also to take the dais. Over to you, Dr. Shivashankaran.
Very good morning to you all, and we will start the scientific feast of the day, and we have a pre-paper session. And the first presenter is Dr. Nilanjan Majumdar, who is talking on the correlation of triglyceride glucose index with angiographic severity of coronary artery disease. Over to you, Dr. Nilanjan Majumdar, please.
Good morning, respected teachers and dear colleagues. The topic of my presentation today is correlation of triglyceride glucose index with angiographic severity of coronary artery disease assessed by Syntax Co in a tertiary care center. And the study setting was my department, the Department of Cardiology, Medical College Trivandrum. I am Dr. Nilanjan Majumdar, finally a resident of the same department. Introduction. The triglyceride glucose index is a novel and scientific marker for identification of glucose, insulin resistance and metabolic syndrome. Higher triglyceride glucose index values have been found to be associated with increased risk of coronary artery disease and poorer outcome in both ACS and CCS. However, there are limited published data on the relationship between this index and the angiographic characteristics of the coronary arterial system in CAD. Aims and objectives. Primary objective to correlate triglyceride glucose index with angiographic severity as assessed by Syntax Co in patients with CCS, and the secondary objective is to compare the correlation of triglyceride glucose index with Syntax Co between diabetic and non-diabetic population. Methodology. Study design is a hospital-based observational and analytical study. Study setting was my own department, Department of Cardiology, Medical College Trivandrum, and study population included patients with coronary artery disease with chronic coronary syndrome treated in the Department of Cardiology after satisfying the inclusion and exclusion criteria, which are these. We included all patients aged 18 with CCS presenting with dyspnea, exertion, palpitation, effort, angina, or fatigue from functional class 2 to 4. And exclusion criteria included patients with ACS, patients with CCS who underwent a revascularization procedure, patients with a valvular heart disease, patients with a congenital heart disease, patients with uncorrected bleeding diathesis. And the study population was 220. Results and discussion. I found in my study that the male is to female ratio was nearly 2.6:1. That means 160 male and 60 female, which was closely related to the ratio that was unveiled by another study conducted by Su et al. In 2022. And the age range was 49 to 81, mean age was 61 plus minus 10, median age was 63 years, and most common age group in both male and females were 61 to 70. And there were multiple risk factors in both male and female, and the most prominent ones were diabetes, hypertension, dyslipidemia, and smoker. And mean HbA1c value was 9.6 plus minus 3.2, mean FBS 143 plus minus 10, mean triglyceride 171 plus minus 6.9. CAG dominance pattern, I found in my study that most of the patients, nearly 81% patients, were having a right dominant coronary system. A codominant coronary system was found in 11% patients, and remaining 8% patients had a left dominant coronary system. Coronary lesions, 33% patients had a single artery disease, single vessel disease. Two vessel disease was noted in 31% patients. LMCA disease was noted in 15% patients, and there were other minor lesions. Gender and coronary lesions, almost all the LMCA lesions, single vessel disease, three vessel disease, these were noted mostly in males. However, normal coronaries, normal epicardial coronaries was noted mostly in females. And non-obstructive coronary, its frequency was almost equal in both male and female. So is the frequency of two vessel disease. Gender, diabetes status, and coronary lesion. I noted that even in this, most of the lesions were associated with diabetic population. triglyceride glucose index. This is the formula I use to calculate triglyceride glucose index. It's the logarithmic value of triglyceride multiplied by fasting blood sugar divided by 2, the normal value of which is less than 4.49. If the value exceeds this limit, it is considered a marker of insulin resistance. In my diabetic population, pre-diabetic and non-diabetic population, these were my mean triglyceride glucose index and Syntex score. And the values of both were higher in diabetic population compared to other two groups. And the correlation between triglyceride glucose index and Syntex score, it was overall 0.53. In non-diabetic population, it was 0.27. In a pre-diabetic population, it was 0.46. However, in the diabetic population, it was staggeringly high. It was 0.699. So, what do we infer from this study? We infer that since we already know that insulin resistance is a marker of a CAD, it's it's a nest upon which the atherogenetic lesions start developing. We can use this for better understanding of the disease pathophysiology. I'll explain it later. Limitations of the study include, it was a single center study. It was a study with a smaller sample size, whilst the studies conducted in China included more than 700 patients. And there were inter-observer variations of coronary artery disease assessment. And conclusion, it was the first ever study conducted in Kerala as well as in the Indian subcontinent to find out the association between triglyceride glucose index and coronary arterial lesion in chronic coronary syndrome. A positive correlation was noted between triglyceride glucose index in diabetics. It provides an alternative approach to assess coronary arterial lesion severity in association with insulin resistance, circumventing the necessity to measure HbA1c.
Thank you. So your study clearly showed that metabolic syndrome could be a predictor of the Syntex score in coronary artery disease, but you mentioned that the male-female ratio is 2.6:1. Male-female ratio is 2.6:1.
Yes, sir.
But you referred some other study from Kausata et al. Which center is that study? 4:1 you mentioned.
I quoted two studies, sir. In one study, it was.
What was that study? Where is it from?
Both are from China, sir.
China. Why can't you show Kerala studies? We have got good data from CREATE registry, Kerala ACS history, male-female ratio.
No,
do you know what is the male-female ratio for ACS in CREATE registry as well as Kerala ACS study?
I think, sir, 8:3.
No, you cannot go by memory because there are important. 8:3 is again, it is much lower, isn't it? Because it has to be, ratio is to 1, isn't it? Why do you want to say 8:3? Don't take anything from your pocket. So make your study more precise because we have got excellent data from Kerala. And what does it mean? Because in women, they don't have risk factors like excessive alcohol use or tobacco use in Kerala at present. Okay, I think this time is over. We'll go to the next paper. It is on STEMI and COVID-19 by Dr. Arya.
Good morning, respected panel and all the other distinguished persons on the stage. I would like to present a study from our medical college. It's a comparative study of acute STEMI PCI outcomes in a prospective cohort during the COVID period versus a retrospective cohort during the equivalent pre-COVID period in a major tertiary care center hospital in South India. So in STEMI, the cornerstone of the management is a timely intervention for reperfusion. COVID-19 pandemic has caused a delay in the delivery of reperfusion therapy for a category of patients, and this is very important in the timely management of STEMI patients. And the study was designed to compare the MACE of the STEMI patients undergoing primary PCI for the 8 months duration time frame in 2021, that is during the COVID period, and comparing it with the equivalent pre-COVID period of 2019, so that we get a real impact, the insight into the real impact of the COVID-19 pandemic on the treatment and outcomes of STEMI from primary PCI. It was a hospital-based comparative prospective observational study done in the Department of Cardiology, Government Medical College, Trivandrum. Study duration for 8 months during the 4th and 5th COVID wave period, and comparing it with the retrospective COVID cohort of the 2019 period. So for this, we have taken, for the COVID cohort, we included all the patients who have been admitted to the cardiology ICCU with the diagnosis of acute STEMI and underwent primary PCI during the time frame. And for the retrospective cohort, we included patients who had satisfied the inclusion criteria and collected their details from the ICCK registry and obtaining additional information from the medical record section of the hospital. And a comparison of the MACE was done between the two groups using appropriate statistical methods. Inclusion criteria was all the patients who were more than 18 years and who were diagnosed as acute STEMI, satisfying the ESC guidelines of 2018 and presented within the window period of 12 hours and undergone primary PCI during these selected time frames. And patients who were excluded were those who came at time period other than the time period mentioned in the inclusion criteria and those who did not give an informed consent. Results. We found out that there was a reduction in the total number of the STEMI admissions undergoing primary PCI during the COVID period. The number was 872, coming down from 1,152. Of this total group, 68.1% underwent primary PCI during the pre-COVID period. And during the COVID period, it came down to 61.6, showing that there was a 6.7 reduction, significant reduction in the total number undergoing primary PCI. The baseline characteristic evaluation showed that during the COVID time, there was a 1 year difference in the population who came with STEMI. And in both the cohorts, we had gender-wise distribution. Men were more affected with ST elevation MI. The risk factor for the ST elevation MI like systemic hypertension, dyslipidemia and smoking were found more during the COVID period than the pre-COVID. And however, type 2 diabetes was found more in the pre-COVID. Distribution of the ST elevation MI we found that anterior wall MI were more common in both the groups. Considering the type of intervention, there was a 3.9% reduction in the number of the primary PCI during the COVID period. And the number of the POBA cases increased from 6.1 to 10.2 during the COVID. And the thrombus aspiration increased from 0.1 to 4.7, which was also significant. On evaluation, we found that emergency door-to-balloon time increased by 9.2. We had 79.5 minutes during the pre-COVID and it increased to 89.17 during the COVID time. The total ischemic time increased from 294.4 to 336.3 during the COVID time. That is, there was an increase of 42 minutes which was significant. However, the in-hospital mortality remained the same in both the cohorts. And with regard to the other MACE events, the stent thrombosis remained the same in both the groups. However, cardiogenic shock, unplanned repeat revascularization, heart failure, and stroke was more during the COVID period than the other. We had a similar observation that 17 of the 872 patients became COVID positive, that is 1.9%, and among them the mortality was increased, that is 11.76%. And which was compared as 8.48 in the non-COVID COVID negative patients, which is non-significant. The further evaluation of this part was taken up in the other study from the college. And from this study, the summary and conclusion was there is a significant reduction of the total number of STEMI admissions undergoing primary PCI during the COVID period. The risk factors for ST elevation MI like systemic hypertension, dyslipidemia and smoking were found more during the COVID period. However, type 2 diabetes mellitus was found more in the pre-COVID period. Emergency door-to-balloon time, total ischemic time was more during the COVID period. However, the in-hospital mortality was not numerically or statistically affected during the COVID and pre-COVID period, so also the stent thrombosis. In-hospital heart failure, cardiogenic shock, in-hospital revascularization were more during the COVID period. The increase in the door-to-balloon time may be due to the COVID screening, intervention donning the PPE, and waiting for the catheterization laboratory for the fumigation. And the increase in total ischemic time can be due to the reluctance to attend the hospital, also as a COVID care hospital, also can be due to the delayed referrals from other senders. We hereby accentuate to ensure the delivery of high-quality medical services related to STEMI systems, especially during similar pandemic situations if it emerges in the future also, so that early revascularization is ensured in STEMI care and a better primary PCI outcome and a reduced mortality is attained. Thank you.
Well presented, nicely presented, good data.
Thank you, sir.
So what do you think, why there is a, despite the increased door-to-balloon time, why do you think there was no reduction in the difference in the mortality? What could be the factors?
Sir, first of all, sir, Difference, door to balloon time was increased probably because of the COVID screening. We did not wait for the results, sir. Once the screening was done, the sample was taken for the COVID evaluation. We took up the patient for the case, sir. And then mortality difference, sir.
Is the COVID helping the patients?
Sorry, sir?
That means is the COVID infection helping the patient, some protective
No,
factor?
sir. No, sir. I cannot.
But I think
Number was
you
reduced.
should have taken the time from the chest pain to the balloon time. That you should have separately assessed.
Understood, sir.
You got it?
Sir. Thank you, sir.
What happened to the STEMI patients coming with COVID
Sir,
positive?
Sir, actually there was an increase in the number of the thrombus load. POBA cases were increased and the thrombus load was, we didn't have any mortality, sir.
No. I mean patients diagnosed as COVID coming with STEMI.
Sir, they were taken up for the primary PCI and angiogram evaluation showed that the number of the patients who were having heavy thrombus was more. That was evaluated in another section, sir, actually.
Couple of points, I think, well done, because we had done a large study on 40,000 patients in the country. In fact, unlike the Western study, we didn't find an excess mortality. And the thrombus also is quite high in this group, which was never seen. And the question that you asked, we did another study called the COSTA, it's just getting published. There, unlike the Western data, we did not see an increase in the mortality. Of course, there was a paradox because Kerala had the best sort of this thing all over the state, whereas the metropolitan cities suffered most. That is a very funny observation which we saw.
Thank you, sir.
Thank you, Arya. We'll go to the next case, predictors of technical success and complications in anti-grade wide escalation technique for CTO intervention. Dr. Prem Shankar, please.
Good morning to all. Myself, Dr. Prem Shankar, final year resident from Trivandrum Medical College. I am here to present my original paper on predictors of technical success and complications in antegrade wire escalation technique for chronic total occlusion percutaneous coronary intervention. So, CTO PCI is a technically challenging and ever-evolving procedure. New techniques and devices have come which are showing higher success rates, but still, antegrade wire escalation remains the most commonly used strategy. Success in antegrade wire escalation depends upon proper lesion selection as well as operator experience and skill. With this background, the aims and objectives of my study were to characterize the CTO lesions encountered, to determine the success and complication rates with antegrade wire escalation technique, to identify predictors of technical success and complications in CTO PCI. Now coming to materials and methods, it was a single-center retrospective observational study of 80 consecutive patients who underwent elective PCI for CTO from October 22 to March 23. All the details were collected from hospital records and wire crossed was considered as technical success. So coming to our observations, the male to female ratio was 5.7:1. The mean age observed of the patients in our study was 57.2 years, with most of them being in 50 to 60 years age group, as evident here. The risk factors commonly seen were type 2 diabetes mellitus, systemic hypertension, tobacco use, and dyslipidemia in this decreasing order. So the most common was type 2 diabetes, about 66%. 95% of our patients had history of acute coronary syndrome, and of them, most of them had STEMI. 32% had STEMI. Median age of lesion in our study was noted to be 10 months, with an interquartile range of 12 months. Most of the patients had a lesion 3 to 6 months of age, while lesion age more than 12 months was associated with higher technical failure of about 78%. On the other hand, lesions with undetermined age were associated with higher complication rate. The ostial to proximal location of CTO was more commonly seen, about 54% of cases, and this also was associated with higher technical failure of about 40%. LAD and RCA were equally involved, but RCA lesions showed a higher technical failure of 51% compared to 20% in LAD, and also a higher complication rate of 31% compared to 20% in LAD. This may be attributed to the fact that most of our RCA lesions in our study were ostial to proximal in location, as we can see here, about 63% of them. And we have previously seen that ostial to proximal location of the lesion was associated with higher technical failure rates. In CTO characteristics, most of the lesions encountered in our study were long and had a blunt proximal cap. Blunt proximal cap and angulated segment was associated with higher technical failure, while intralesional calcification and angulated segment was associated with higher complication rates. JCTO score more than 2 was associated with technical failure of 50% and complication rate of 37.5%. We could see here that about 20% cases were in JCTO score more than 2, and even in them the success rate was about 50%. Progress CTO score of more than 2 was associated with a technical failure of 67% and complication rate of 50%. The collaterals in our study were mostly RENTROP2 and non-interventional in type. 70 of the 80 cases were taken as first attempt, and in 10 patients, second attempt was tried. And the technical failure in first attempt cases was higher, that is 66%, while complications were similar in both. Right radial approach was more commonly used than right femoral approach, and it showed lesser technical failure and lower complication rate as well. The combined approach was used in technically difficult lesions as evident by their higher mean JCTO score. And that's why they also showed higher technical failure and complications. Coming to the wires used, Gaia and Fielder were the commonly used wires. Higher crossability was seen with Gaia wire, which was just closely followed by Fielder wires. Other wires used were Progress and CrossFit series. First wire showed a crossability of 57.5% in our study, while second wire crossed 17.65% of the times. Fielder series were the most commonly used first wires, while Gaia series were the most successful first wires. In the second wires, Gaia was the commonly used and was successful equally to Progress wires. Microcatheter was the most commonly used support techniques, followed by balloon support, and retrograde injections were taken in 37.5% patients. So overall, our technical success was 65%, that is in 52 of 80 patients, and complication rate was 22.5%, that is in 18 of 80 patients. Coming in detail of complications, and the most common intraprocedural complication was coronary dissection, followed by coronary perforation. One patient had cardiac arrest and was revived successfully. In post-procedure complications, there was one in-hospital mortality, which gives us an in-hospital mortality rate of 1.25% only. So mean contrast volume in our study was 167.95 ml, and mean fluoroscopy time noted was 21.67 minutes only. Coming to limitations of our study, it was a retrospective small sample size, and the escalation protocols varied among different operators. Conclusions: antigrade wire escalation technique was shown to be safe and effective in CTO PCI. Gaia and Fielder wires were favored. Progress CTO and JCTO scores correlated well with technical outcome and risk of complications. More importantly, predictors of technical failure and complications included lesion age, RCA lesions, ostial to proximal location, JCTO score of more than 2, Progress CTO score of more than 2, blunt calcified and angulated segment. So what was new in our study? That undetermined lesion age was associated with higher complication rate, and RC lesions were associated with higher technical failure. Thank you.
Just two comments. One is your definition of success via crossing the lesion.
Yes,
Not
sir.
just via crossing the lesion, wire should cross into the true lumen distally.
Yes, yes.
Second, you have mentioned about just Gaia wire.
Yes,
Should mention about Gaia 1, 2, and 3, because 1 and 3 is like comparing lakes with oceans. They are totally different. The
Yes, sir.
strength of the wire. Okay.
Any questions from the audience, please? If there are no questions, thank you so much, Dr. Prem Shankar. Let us go to the next
Thank
session.
you, sir. Thank you, sir.
Next session is 2-year outcome of patients with atrial fibrillation dictated by Trivandrum Atrial Fibrillation Registry, presented by Dr. Ampade.
Good morning, respected chair and respected teachers. I am hereby presenting the outcome of patients with atrial fibrillation enrolled in the Trivandrum atrial fibrillation study, which was a community-based study. Coming to the going to the topic, just giving a brief introduction of how they detected the AF in the community. We had a 12-lead ECG machine, which is called LA-Core Cardia, which can be used to detect the heart rhythm using a simple machine. That's the picture which is shown on the lower side. We have conducted 73 training sessions for ASHAs, and we trained them how to assess the rhythm and how to fill the Google Forms. And we have screened a total of 61,200 patients. And we have conducted 86 community medical camps, and each camp catered for about 50 to 80 patients. Just a brief introduction on atrial fibrillation. It's the most prevalent sustained arrhythmia and the prevalence is increasing with age. The early detection and the proper management is very crucial. The community-based data regarding atrial fibrillation prevalence is scarce. And now we have a community-based data from Trivandrum atrial fibrillation study. And my objective is to study the outcome of those patients with atrial fibrillation enrolled in Trivandrum atrial fibrillation study. Coming to the just a brief introduction on how we enrolled the patients. Total we have screened 61,200 patients from 73 gram panchayats across 175 wards, and we have detected 568 cases of atrial fibrillation. And out of 568, we have 524 people who have completed the follow-up till April 2023. And the methodology, the study design was an ambidextrous cohort study. The inclusion criteria was patients with atrial fibrillation detected in the Trivandrum atrial fibrillation study. The study period was from September 2019 to April 2023. And how we follow up the case. The community follow-up was with the help of PHC and CSC medical offices and with the help of field staff. And the online review response was with the help of WhatsApp groups and telephonic questionnaires and with the help of Google Forms. And we have an arrhythmia clinic at MCH where we did a detailed examination and history, and we have repeated the 12-lead ECG. Coming to the results and discussion, the frequency we found was 568. The prevalent percentage was about 0.92, and we observed that above the age of 40 years, the prevalence was 1.48. And the male-female distribution was 54% is to 46%. Among the AF, we have divided into valvular and non-valvular. Non-valvular contribute the most, 81%, and valvular comes about 18.2%. And the minimum age was 32, maximum was 93, with a mean age of 64. Just a symptom profile among the patients. As you all know, the palpitation was the most common, followed by dyspnea, fatigue, dizziness, chest pain, syncope. But we also found that 18.4% of the patients were completely asymptomatic. We were able to pick up those patients from this community study. This bar graph shows the significance of the relation between the risk factors and the valvular and the non-valvular AF. I have put those risk factors which are positively associated with this AF. Hypertension, diabetes, smoking, coronary artery disease, and thyroid disease was found to be more common in non-valvular AF when compared to valvular AF. Coming to the appropriateness of treatment in atrial fibrillation patients, out of the 522 who have completed follow-up, 74% of the patients were needing oral anticoagulation, and 26 were not treated with oral anticoagulant drugs. And out of this 420 patients, 89.4% patients were completely drug compliant. We have a regular follow-up. And out of this 391, 75% were using vitamin K antagonist, and the other 24.6% was using NOACs. And the INR within therapeutic range who are using VKS was only 20.4, and the rest was not within the therapeutic INR range. Coming to the bleeding events, out of total of 524, only 24 major bleeding events with a BARC score 3 and above was noted. And out of that 24, 18 patients were using vitamin K antagonist, and 6 patients were using NOACs. And we found a significant difference in the bleeding rates between the VKS and the NOACs. And the CHADVA score, we found that most of the maximum percentage was CHADVA score 2 and above, which is very less with 0 and 1. Coming to the total hospital admission and mortality, regarding each complication, as you can see the graph, the most number of admission was due to heart failure and CAD, and the maximum mortality was also contributed by heart failure and CAD, followed by CVA pulmonary embolism. This graph shows the different event rates per year, and we can see that the CVA or TA and CAD and the peripheral and the pulmonary embolism, there is a decreasing trend towards the second and third year of follow-up. Actually, the first 2 years were actually hit by COVID. Even though the number of cases was less, the number of incidents was more. But probably due to the proper treatment, the proper anticoagulation, and the control of risk factors, there is a significant decrease in the complication, especially CVA, CAD, and pulmonary embolism. There was not much difference in the heart failure incidents. Coming to the all-cause mortality, out of 524 patients, we had a mortality of 60 patients, that is 11.4, and the CAD and heart failure contribute 36%. 60% of the total mortality, and CV and pulmonary embolism, it contributed to 40%. The others, it include 10%. And my discussion, the all-cause mortality was significantly lower comparing with hospital-based data, which mine was a community-based data. CAD and heart failure contributes to the most amount of mortality, followed by CV and other embolic events. The frequency of hospitalization mortality was significantly reduced with the increased use and the proper screening and with the use of rate-lowering drugs. The increased use of NOACs has decreased the incidence of major bleeding events, and the INR in the therapeutic range has significantly increased during the course of follow-up, during the median follow-up after the second half. And my suggestions, the screening at PHCs and CHCs through NCD clinic can be where they can use simple ECG device like what I have shown, like the AliveCore Cardia device, smartphones and even smartwatches can be used for early detection of AF and other arrhythmias. The prompt initiation of anticoagulation and rate control drugs at the community level can prevent the complication of AF, and the optimization of anticoagulation has to be ensured. Encouraged use of NOACs can decrease the major bleeding events. Thank you.
A good study, well presented. In fact, it's an immense study from our standards in Kerala, in India, because somebody has gone to the community, collected all the data, followed up for 4 years, isn't it?
Yes,
4
sir.
years.
Awesome.
Okay. You are presenting the data of 2 years.
Actually, sir, the total study was 4 years. My seniors actually initiated the study. They have completed a population of 20,000. The rest screening was done by us, and the follow-up was also done by us. So we have a mean follow-up of almost 2 years, sir.
Okay. Are you continuing the study?
Sir, we are planning to actually continue the studies.
Okay. What do you think the most important finding you have found from the literature, comparing the literature? What is special to Kerala?
Sir, actually, the asymptomatic patients, we were able to identify the asymptomatic patients, and also the biggest problem was to start the anticoagulation, especially from PHC and CS. They are not daring to start the anticoagulation properly, so they will just send the.
No. My question is, this is a study from our own state and our own people.
Yes, sir.
So what do you find stark difference from the standard AF?
Actually, sir, we have a registry that the Kerala atrial fibrillation registry is there, but it is basically a hospital-based study. There is scarcity of community-based study. So we actually, if we concentrate more on this NCD clinics, we can.
My question is something like, is our age distribution earlier or later than what is in the Western or something?
Sir, it's definitely
because we have more of risk factors, more of diabetes. Do you find anything like that?
Yes, sir. Actually, it's almost comparable with the data which is available in Kerala, sir.
Anyway, congratulations. And in fact, it's an immense study. I think we should go forward.
Yes,
and
sir.
these are the studies that should come from institutions like yours.
Okay, definitely, sir. Thank you, sir.
So the morning session, I think the Medical College Trivandrum has done a good scoring. All the papers were very good. Even the first paper also, actually, I need to appreciate because they have found a male-female ratio of 2.6:1, because the first AMI study from Kerala by Dr. Mami showed a male-female ratio of 27:1. So we used to say that any lady coming with chest pain, we say it's not heart disease. So how the parameters have changed is very illuminating. And thank you all the presenters. And now we move on to the next session.
Thank you very much, sir. We move on to the next session immediately, a very much awaited session, the ECG interactive session, from which the PGs might derive a lot. The speakers, Dr. Jagan Mohan Taragan and Dr. Sudai Kumar. Over to you, sir. Good morning,
Good
sir.
morning. Good morning to all. I think the caption is interactive session. I think we have modified it because we knew that there will not be enough people to interact. Our initial aim was to show 1 or 2 ECGs, interact with the postgraduates, all those people. And yesterday itself we knew that interest in ECGs, we anticipated it may not be great. But we are extremely happy that we have more than 10 people to attend that. Because first my IMA presentation, there were only 5, speaker, chairperson, and organizing secretary, and 2 audience. Okay, we have modified it like this. There is 25 minutes, Professor Jagan Mohan will be presenting his data. If there is a scope for discussion, 5 minutes. Next to 25 minutes, I will present the data. Anyway, we'll take maximum 60 minutes, maybe less than that.
Yeah, very good morning. Thanks to Medical College Trivandrum for at least having a few fellows here in front in the audience. And I think this 1 hour time for ECG session is good for the rest of the delegates to join for the more important sessions. So let's get on with the program. It's ECG for interpretation. This is the first ECG. Anybody from the front row, please, can you just tell what do you think about this ECG? Usually when I ask the people to read the ECG, they say, oh, yes, normal sinus rhythm and all that. So tell me. It's a 12-year-old asymptomatic who has come for a routine evaluation. Okay, persistent juvenile pattern, good. Anything else? It's a little horrible ECG, isn't it? It's very difficult to interpret. So when we say sinus rhythm, what are we looking at? Every QRS is preceded by a P wave, so it is sinus rhythm. But is it sinus rhythm? What is the p-axis? So when you say the patient has a sinus rhythm, you look at the p-axis. P-axis should be between 0 and 90. So here it is not between 0 and 90, it is actually 150. So between 90 and 180. So what is your interpretation when the p-axis is between 90 and 180? I thought this is the simplest of ECGs, asymptomatic. It's situs inversus, right? And the chest leads follow like situs inversus dextrocardia with a normal heart. So it only shows you how difficult it is to interpret an ECG of situs inversus dextrocardia when the leads are placed in the appropriate position. So what I would suggest is, see, you as adult cardiologists are unlikely to see a situs inversus dextrocardia with congenital heart disease. As it is, the incidence of congenital heart disease and situs inversus dextrocardia is only 2 to 3%. And that is an overestimation because most of the asymptomatic situs inversus dextrocardias don't come to you, right? So what they come to you is generally like a medical checkup or maybe somebody has Carter-Jenner syndrome or some of these elderly people who have acquired heart disease. That's how situs solitus with dextrocardia is likely to come to you. So when you diagnose or suspect situs inversus dextrocardia, the best thing to evaluate the ECG is you yourself go to the electrocardiography room, take the leads, AVR and AVL, exchange it. AVF and AVR you don't have to exchange. Right, the right leg and the right leg, right leg and left leg, you don't have to exchange because it's far away, it's about the perpendicular to this one. And put the V1 electrode in the V2 position, V2 in the V1 position, and V3 as V3 or V4 or V5 or V6 are in the mirror image position. When you get an ECG, it will look almost normal and it will be much easier for you to read the electrocardiogram. This ECG was very difficult for you to read. So when you get a patient with situs inversus dextrocardia, you go to the electrocardiography room, do a technical correction of that so that you get a normal looking electrocardiogram. So this ECG was just to show you normal heart in situs solitus dextrocardia. Now we'll come to some congenital heart disease. Cyanotic congenital heart disease with RV dominance. That's a very common thing. You see, in congenital heart disease, especially cyanotics, electrocardiogram is never diagnostic. It's only a pointer, right? So let's read this electrocardiogram. It's a 6-month-old cyanotic baby with a history of hypoxic spells. Every QRS is preceded by a P, so it's sinus rhythm. Why do you say it's a sinus rhythm? With situs solitus, the P-axis is normal. It's around plus 60, right? Okay. The PR interval is normal. The P is a little spiked. In lead 2, the P wave is a little spiked. So the morphology of P wave is also important for assessing whether there is right or left atrial abnormality. Not only the height of the P being more than 2.5 or 3. So if it is a little spiked, it is suggestive of right atrial enlargement. If it is bifid with the two bifida separated by for around 40 milliseconds, it is left atrial enlargement and so on. So this may be a right atrial enlargement. Now coming to the QRS. What is it's a clockwise loop. You have good Q waves in 2, 3 AVF. It's a clockwise loop in the frontal plane. The QRS axis is around little more than plus 120, maybe around 130. So it is right axis deviation. Coming to the voltages in the precordial leads, obviously there is a monophasic R in V1, it's a RVH, isn't it? But what is surprising is from V1 to V2, there is a sudden transition from a predominantly or monophasic R to an RS complex. Now, this is fairly typical for tetralogy of Fallot. Now, we say it is typical for tetralogy of Fallot because the commonest congenital heart disease cyanotic that you see is tetralogy of Fallot. But this can happen in any large VSD with outflow obstruction like a DORV also. That I'll show you in some of the subsequent lectures. So, this transition from V1 to V2, from a monophasic R to an RS pattern in V2 is not truly a diagnostic of tetralogy, but it does suggest tetralogy. What else would you look for? The STT changes. There are no STT changes. And why I'm telling you each of this is important. And look at the V5 and V6. Even V5, V6 have some Q and an R wave. So in the presence of such RVH, if you have good Q waves in V5 and a good R in V5 and V6, it does suggest adequate left ventricle. See, in tetralogy, the problem is there is a decreased pulmonary blood flow. There is a decreased flow into the left atrium and into the left ventricle. So left ventricle is generally not hyperplastic, but it is smaller. Some of the surgeons even say, oh no, the left ventricle is not too good for a biventricular repair. So you always look at the V5, V6 for the V5, V6 for the left ventricular size, isn't it? And the Q waves also tell you the septal orientation of the ventricle is normal, right? Whenever you get a good Q wave in V5, V6, you know the left ventricle is on the left side and the septum is normal. So this is how you read a ECG of, now this is being a tetralogy fellow. Of course, this is, I think I told all these things. The only thing I did not tell you is the T upright in V1. Now this will come to later, but T upright in V1 with a monophasic R or a dominant R in the V1 is indicative of right ventricular hypertrophy in children, especially in the infants. Now in contrast, this is a 2-year-old child with mild cyanosis, prominent elevated JVP with very prominent A waves. Now look at the electrocardiogram. Every QRS is preceded by a P wave. The P wave axis is around plus 30, 35 or 40. So it's a little leftward, you can say. But marked increase in the voltage, it is half standard. So the voltages are much higher, right? So it's a P right atrial enlargement. But when right atrial enlargement is there with a little of leftward shift of the P, it's called a P congenital. There's nothing very different between congenital and P pulmonale. But if the axis is little leftward, here it is around plus 45. Now look at the QRS, it's a counterclockwise loop. Monophasic R in V1, very tall R in V1. But we don't see the transition in V2, right? The monophasic R pattern is actually persisting from V1, V2, V3, V4. That means there is significant right ventricular hypertrophy. Now, in spite of this significant right ventricular hypertrophy, there is a Q wave in V5 and V6, suggesting that despite this severe right ventricular hypertrophy, the left ventricle is also adequate, right? Not only that, and the septal orientation is normal, so you know that left ventricle is on the left side. So, compared to a tetralogy of Fallot, what are the differences here? You get P pulmonale, very large P waves, very large voltages. People even compute the right ventricular pressures from the voltages of the R wave in V1 as the millivolts into 5. So here it will be 50, here will be actually 50 millimeters. 50 millimeters into 5 will be 250. That will be predicted RV pressures. STT changes. In tetralogy, you never see STT changes in the precordial leads, except in the elderly or beyond the adolescents where there can be right ventricular dysfunction or some cardiomyopathic features of tetralogy. Otherwise, STT changes are not seen. When you see STT changes in a tetralogy, you should suspect a non-tetralogy diagnosis or a tetralogy with a restrictive VSD where the right ventricular pressure can be suprasystemic. So now, this is just the explanation of the scene. This is another 2-year-old mildly cyanotic child with a history of heart failure in infancy. Again, sinus rhythm, because every QRS is preceded by a P. The P axis is around plus 45. It's a little peaked in lead 2, suggests that it may be right atrial enlargement. The QRS is counterclockwise loop. Very good Q. All this we are saying clockwise loop. Here is a counterclockwise loop. Very deep Q in V and lead 1 and AVL. And the axis The QRS axis is now almost more than minus 90, it's around minus 100. So extreme left axis, counterclockwise loop. But you look at the precordial leads, there is right atrial enlargement as well as right ventricular hypertrophy. Again, I think there is a interchange between V2 and V1. I think better to read V2 as V1 and V1 as V2. Then you know that there is a transition from V1 to V2. And you look at the V6, severe right ventricular hypertrophy. So here there is a patient with severe right ventricular hypertrophy, but the limb leads suggest counterclockwise loop with left axis deviation. This is typically seen in congenital heart disease with AV canal defect. Now, AV canal defect can be in isolation. If it is cyanotic, it means what? An AV canal defect being cyanotic means what? At the age of 2? AV canal defect is by itself not cyanotic. Cyanotic means it's an Eisenmenger syndrome, right? Or a patient can have AV canal defect with tetralogy or a DORV. However, we have seen that this type of electrocardiogram is also possible with DORV with subaortic VSD, with PS or without PS. So the differential diagnosis when you get a counterclockwise loop, left axis deviation, and RVH is AV septal defect with pulmonary vascular disease, or it can be AV septal defect in association with tetralogy or DORV, or in the absence of AV septal defect also you can get such an ECG in DORV with or without PS. Now this is the next ECG of a 12-year-old cyanotic from early infancy, but no history of heart failure. Again, it's sinus rhythm. P-axis is almost normal. It's around plus, maybe plus 45. Right? The P pulmonale, it's not very clear. Now look at the QRS. The QRS shows a QRS in V lead 1 and AVL. That means it's a counterclockwise loop. But the axis is extremely rightward. It's more than plus 150. So you have a counterclockwise loop with now right axis deviation. And the precordial leads show significant right ventricular hypertrophy. V1 is monophasic R. There is a transition from V1 to V2. And despite all this right ventricular hypertrophy, there is a small Q in V5, VC. So you know the orientation of the ventricles. The left ventricle is on the left side. The septum is normal. There is significant right ventricular hypertrophy, but it's a counterclockwise loop. Not a usually right ventricular hypertrophy, right axis deviation, you see clockwise loop. Here it's a counterclockwise loop. This is typically seen in a DORV with VSD, PS or without PS, right? So DORV, VSD, PS should always come to your mind when there is a counterclockwise loop with left or right axis deviation. So I think I have probably completed the cyanotic with right ventricular hypertrophy. Now I'm coming to cyanotic with LV dominance. Now this is a 2 weeks old child, neonate. It looks almost like a normal ECG, right? Except for the tall P in lead 2 that suggests a right atrial enlargement. So what is it? You find it's all left ventricular dominant. There isn't any right ventricular force at all. It's a normal axis. It's around plus 75 axis. And you look at the precordial leads, it's all left ventricular forces. Now, what is important is at the age of 2 weeks, most of the infant neonates will have a right ventricular dominance. Right ventricular dominance is the rule. If you have an ECG with the left ventricular dominance, it's abnormal. It takes almost a year for a right ventricular dominance of a newborn or an early neonate to become a normal adult-like left ventricular pattern. It takes up to 1 year, right? And still you might get what is called the juvenile pattern of T inversion from V1 to V3, which takes up to 10 years to revert. So when you have a left ventricular dominance with right atrial enlargement with normal axis, there is of course a hypoplasia of the right ventricle. Most possibly it is a pulmonary atresia, intact septum with right to left shunt at the atrial level, right? So this is right atrial enlargement, LV dominance, absent right ventricular forces, normal QRS axis, typically pulmonary atresia with intact interference. So just a word about what is normal ECG pattern in a neonate. Normal pattern is RV dominance. Transition to adulthood takes up to 1 year. Dominant R with upright T wave in V1 beyond the age of 6 days is an indication of right ventricular hypertrophy. So right axis deviation, dominant R in V1 are not indicator of right ventricular hypertrophy in a newborn. But if the T is upright in V1 with a dominant R, then it is an indicator of right ventricular hypertrophy because the neonates usually have a right ventricular dominance. The left ventricular dominant pattern takes about a year. This is another electrocardiogram. Just to complete it, it's again normal sinus rhythm, normal P axis, P pulmonale or P right atrial enlargement. The QRS axis is leftward. It's almost around minus 45, right? And left ventricular forces. It's a 6-month-old child, cyanotic. No history of heart failure. This is a typical ECG of a tricuspid atresia, VSD with PS, or a tricuspid atresia with restrictive VSD, right? Because again here the right ventricle is hypoplastic. Only thing is the difference between a pulmonary atresia, intact septum, and a tricuspid atresia is LV dominance. Here usually you get a leftward axis. Tricuspid atresia, VSD with normally related great vessels, PS or PAH, usually you get a leftward axis. If there is a tricuspid atresia with transposition of the great vessels, then usually there is left axis deviation, left ventricular dominance, but left ventricular dominance, but the axis will be normal. Now coming to the next set, we will discuss about group beating. Now you look at only the rhythm strip. The rhythm strips, lower down you can see the group beating of 3 beats, right? 3 beats. Now the beat in between the 2 normal beats is almost a narrow QRS, but the axis is a little different. So it must be an atrial or a junctional beat. So what is this called? A junctional or an atrial ectopic between 2 sinus beats. It's called a interpolated. Correct? Now why is it called interpolated? That's because you see, for your reference, I have drawn those 2 red lines for the PP interval. The PP intervals are constant, right? The PP intervals are constant. So the atrial ectopic has not altered the sinus rhythm, right? It has not altered the sinus rhythm. So it has got blocked in the perisinus nodal region. But the RR intervals are different. The RR interval containing that extra beat is longer. Why? Because the second P wave finds the AV junction partially refracted, right? So there is a little slower conduction. That PR is a little longer. So generally you will find this interpolated beats. The sinus node, the RR PP interval should be normal. It should not affect the sinus node. But the RR interval can vary. And what is varying is the one which contains the ectopic beat will be longer than the one which doesn't. Okay. So this is just to show you the zone of collision where the atrial ectopic has actually collided with the normal sinus beat. So the compensatory pause is complete, double. The zone of reset where the atrial ectopic actually discharges the sinus node and then the sinus node again goes back to its usual rhythm, right? So that's a reset where the compensatory pause is less than twice the sinus rate. What we showed is the zone of interpolation, right? The atrial ectopic is actually blocked in the perisinus nodal region. So the sinus node is not affected. It comes on its expected time. The fourth is zone of re-entry. Not exactly the next one, but you can have a look at this. Again, group of 3 beats. The first is a sinus beat. The second, of course, here is a ventricular ectopic. It's a broad QRS. Now, what is the third beat? Is it the next sinus beat? I put a clue there. Those P waves are inverted in 2,3 AVF, isn't it? Now, inverted P waves in 2,3 AVF means it's probably a retrograde conduction from the junction. So, this ventricular ectopic has actually conducted retrogradely and then re-entered into the ventricle. Yeah, thank you. Oh, yeah. It has re-entered the ventricle. So, the expected P wave is here. The expected sinus P wave is here, but then it is blocked. So here it's basically an echo beat. So now what happens in the echo beat? The RR interval is shorter with the echo beat than the other RR interval, right? Okay. Now this is a little more difficult, group beating. It's a background sinus rhythm. It's only a clue I'll give you. I think it's very difficult to immediately diagnose what this problem is. So I have gone a step further to show you all the P waves. All the P waves. So now you know, for every P wave, what is happening? There are 2 QRS, right? Do you know a condition where you can have 2 QRS for every P wave? It's called 1 to 2 AV conduction. A single P wave can conduct.
What about parasystole?
Sorry,
Parasystole?
I can't hear you.
Parasystole, sir. What about parasystole?
Anyway, I'll just tell you. See, there is a pattern. Basically, we are looking at pattern, not diagnosing something just out of the blue. Here, the sinus node, sinus P wave, it's conducted. Then there is a delay, and it's again conducted. Now, this PR interval is a little increase, isn't it? It's around 280 milliseconds. The other one is extremely long. It's almost 400 milliseconds. Look at this P wave, conducted through the fast pathway, again conducted through the slow pathway. Now look at this P wave. It is not conducted through the fast pathway, right? Not conducted through the fast pathway. It is only conducted through the slow pathway with a PR interval of 400 milliseconds. Now this pattern is continuing. So it's a pattern which you have to recognize, that a single P wave is coming very regularly. Is alternately sometimes coming with 2 ventricular conductions, sometimes only 1 through the slow pathway. To make it understand a little better, this ladder diagram, P wave conducted through the fast pathway, through the slow pathway, fast pathway, slow pathway, blocked in the fast pathway, conducts through the slow. So this is a dual AV nodal physiology shown on a sinus rhythm ECG. Now we'll show you some variations here. This is a 35-year-old man who has repeated episodes of palpitation. By the time he comes to the emergency, the palpitation is stopped. But we have been able to pick up this ECG. I already marked for you that this beginning, the PR intervals are 280. Then for some reason, the PR interval suddenly changed to around 210, right? So there's a sudden change of a stable PR interval from 280 to another stable PR interval of 220. Why has it happened? So you can look here, there is an ectopic here. Actually, it is blocked, but it is really not blocked. It is blocked in the fast pathway because fast pathway has a longer refractory period. The slow pathway has a longer refractory period, shorter refractory period, so it allows conduction. So it gets partly discharged, and hence it modifies the slow pathway and facilitates the fast pathway conduction, right? So this ECG itself tells you that this patient has dual AV nodal physiology and liable to be having a AV nodal reentrant tachycardia. So to continue the same discussion, here is an ECG. I have taken this ECG specifically because there is a tachycardia, there is a termination of the tachycardia, and there is a sinus wave. But during this tachycardia, it's very difficult to see whether there is a P wave. There is a suggestion there is a P wave or here now on the terminal part of the V1, right? Now the tachycardia has terminated, and you look at the QRS here. QRS does not have a P wave in the terminal part. So obviously you mean that this is a P wave, is it not? A P wave very close to the QRS is likely to be a AV nodal reentrant tachycardia. AV reentrant tachycardia, the V to A interval is at least 80 to 120 milliseconds or more. So it will go into the ST segment. And this is very clearly shown that here, clearly here. So this is probably AV nodal reentrant tachycardia. And you also know that it is stopping with a P wave, correct? After this, the tachycardia has stopped. A reentrant tachycardia usually stops with a P wave. An atrial tachycardia usually stops with a QRS. That means the P tends to conduct to the ventricle in an atrial tachycardia. In a reentrant tachycardia, the antegrade pathway through the AV node is the weak path, right? So often it gets blocked. So AV reentrant or AV nodal reentrant tachycardia will block in the antegrade pathway and get a blocked PVLBCL. Other one will be a pure. With this, I will stop and I will request Dr. Sudhir Kumar to continue his talk.
I think we can have a 2 or 3 minutes discussion, because if Nate doubts the great nostalgia he has created, taking me back to 1983 when I was learning from him in PG Chandigarh when he was my senior resident. And now again, learned a lot from you, especially congenital heart disease, a lot of things. Now, left axis deviation with LV dominance, tricuspid atresia, but we have to add that there is normally related great arteries and a restrictive VSD, because there is no right ventricle. Great. I think I learned a lot. I still have some doubts. Any doubts, any points? Postgraduates, cardiologists, not electrophysiologists. Okay.
No, I just showed those congenital heart disease. Today, if you go to see a congenital heart disease referred to you in the outpatient, they will come with 2 or 3 echoes and 1 X-ray. No ECG, right? No ECG. So it was just to reiterate that ECG is good. It's maybe a little entertainment to stimulate your brain rather than clinically very impactful. So that was the reason I just stressed on those. Any comments or any? Yeah. I may not be able to hear you. There is a lot of echoing. So.
So pulmonary atresia with intact IVS versus tricuspid atresia, is there any difference in the loop? Counterclockwise loop is common in
Oh no, I don't think so. I don't think so. Because there is a good left ventricle dominance and when septum is intact. Only in septum intact doesn't mean that there is a VSD, doesn't mean septum is not intact. Septum is not there only in single ventricle physiologies. Not in tricuspid atresia is a form of single ventricle functionally. But otherwise, the left ventricular septum is there. While the common AV valve with single ventricle and all that, the septum is actually deficient. So you don't get the Q waves in V5, V6 in single ventricle of even LV morphology. Right? But in tricuspid atresia, it's not like that. The VSD is only sometimes very small only. Most of the septum is well formed. But in tricuspid atresia with VSD, with PS, normal rated Griffiths, the axis is leftward, counterclockwise loop. While if there is a transposition, the axis may be normal. In pulmonary atresia, the axis is always normal. It's not, there's no left axis.
I think Jayagopal is impatient. Further beeping sound. Shall I start?
Oh, please.
Okay.
I didn't want to talk at all.
No. Okay, hope you can see me, because Jayan Mohan was very tall. All of you could see him. So, this is an ECG which I was asked to interpret. I found it extremely difficult. Okay. Now, you may easily diagnose this, but I thought I will approach like this. An electrocardiogram for arrhythmias. I think as Professor Jagan has said, there are 3 segments: the atrial segment, the ventricular segment, and the ladder, which is the AV conduction. So first I will ask, can you see the P waves? Yes or no? Now if it is not seen, you may not be seeing because of your inexperience, or it may be masked, or it may be absent. If it is seen, then look at what is the rate of that atrial activity, because whenever you diagnose atrial arrhythmia, it should be based on atrial activity, not on irregular ventricular QRS, irregular QRS to diagnose AF, which is an atrial arrhythmia. What is the rate of the atrial activity? What is the rhythm? Is it regular or irregular? And what is the morphology of the atrial activity? Is it normal or abnormal? If the atrial activity is abnormal, does it have a constant pattern as its usual retrograde atrial activation, or it's a totally varying pattern? That's about the atrial activity. Similarly, the ventricular activity, obviously it has to be present. What is the rate? What is the regularity? What is the morphology? Is it narrow or wide? If it is wide, if it is monomorphic or polymorphic? If it is monomorphic, does it conform to RBB, LBB, or otherwise? And what is the atrioventricular relation? Is it normal? That is P followed by QRS with a normal or a constant PR interval. If it is an abnormal, is that abnormality constant? Like 2 to 1, 3 to 1, like that? Or is it varying? If it is varying, does it have a specific pattern like progressive prolongation? Or is it totally varying as in atrioventricular dissociation? So I think because there are certain postgraduates who are appearing for examination getting ECGs, atrial activity analyzed, ventricular activity analyzed, the atrioventricular relation analyzed. So now we go back. Anybody want to take up this? I will not stretch it beyond 9:30. That's very clear. Anybody? Postgraduates? First, what is atrial activity? Can you see the atrial activity? In lead 1, V1, you can see, this is my collection, V1. So what are you seeing the atrial activity? Okay, you can see the atrial activity 1, 2. So the rate is something like 300 per minute. Is it regular? It is not regular. Is the morphology constant? Not constant. So it is a fast, irregular atrial activity. That is the clue to say that it is atrial fibrillation. Okay, so it is atrial fibrillation. Now what is the ventricular activity? It is fast. Is it regular or irregular? It is irregular. Is the morphology normal or abnormal? It is normal plus abnormal. So that is the thing. What is the atrioventricular relation? There is an AV block. And what is the degree of AV block? It is varying. So there is an atrial fibrillation, varying AV conduction, relatively fast ventricular response. Now you have to assess what is the morphology, why it is changing. What is the cause for intermittent widening of the QRS? Is it related to bundle branch block, or is it related to a myocardial problem, or is it related to an accessory conduction? Myocardial problem, usually it will remain like that. It doesn't become intermittent. So it doesn't conform to RBB or LBB classical. So you look for the pre-excitation. Okay, then it's very clear, because in lead 2 it is very clear there is a delta wave. It is very clear in lead 2. And in V1 there is a delta wave which has a polarity which is positive. That is, so you can even localize that, because you have the delta vector which is positive in V1 to V6 and negative in lead 2. Okay. This is a 30-year-old male with 3 episodes of syncope and a family history of sudden cardiac death in his elder brother at the age of 35 years, clinically normal heart. So what is the approach? All those things you can do, but here it is not difficult, so we need not go into the difficult pattern. It is a regular broad QRS tachycardia, which is relatively fast. So there is no doubt. And the QRS morphology, I think we need not debate too much about ventricular versus supraventricular aberrancy. It is ventricular. So that part is very clear. Now the next step for the postgraduate, not electrophysiology, do it. From where is it arising? That's the next thing. What is the type? It's a monomorphic ventricular tachycardia with concordance, that is precordial concordance. And it is negative in V1, so I think it is arising. Anybody can contribute and correct. This is my approach. I may not be right. It is arising from the right ventricle. And look at the axis. The axis is something strictly superior. So it's around minus 90. So it is arising from the right ventricle going up. So you can say it is not an RVOT tachycardia. So what is the likely possibility? The clue is in this electrocardiogram after conversion. So what is the clinical diagnosis when you get a young person, family history, right ventricular tachycardia, which is very fast, episodes of syncope? ARVD. So what is the clue in this electrocardiogram? You can see the epsilon wave. You can see the epsilon wave and right ventricular T wave changes. You can see that the right ventricle is abnormal in this. So this is my approach to a wide QRS tachycardia mechanism. It could be ventricular or supraventricular. If it is supraventricular with wide QRS, is it abnormal conduction through the normal pathway? That is bundle branch block. It could be pre-existing or tachycardia related. Or is it a conduction through the anomalous pathway? Or is it an abnormal conduction? It is reaching the myocardium through the normal pathway, but the myocardium is not transmitting it normally. Which could be intrinsic problem like myocarditis, myocardial infarction or myocardial diseases, or extrinsic like drugs and hyperkalemia. Okay? Now, a second case, 40-year-old diabetic lady, mitral valve disease, heart failure on medication, and improved from NYHA 3 to NYHA 2 on fairly strict medication. The first part, top part, atrial activity is there, it is fast and irregular, so it is atrial fibrillation. The ventricular activity is roughly 55 per minute, it is regular. So the diagnosis is straightforward. Whenever you get atrial fibrillation with regular slow QRS, it is atrial fibrillation with complete heart block. What is the cause of that complete heart block? What is the cause of that? The first part for postgraduate, I expect them to answer, no doubt. What is the cause of the complete heart block? Pardon? It is drug related. Contributed by hypokalemia. You can see very prominent U waves. You can see very prominent U waves in V4, V5, V6. The prominent U wave can be induced by digoxin, but seldom it goes to this level. That's why I said aggressive medication. Okay. And this is another ECG exercise for the postgraduates. Okay, start from LKG, UKG like that. Start from the first cycle and then proceed. So the first cycle shows that obviously this is an abnormal P wave. So obviously this is an ectopic atrial rhythm. So what is happening? So look at that. What is happening here? What is happening here? What is happening here? There is a progressive prolongation of the PR interval, and you can see that it is blocked here. The cycle is being repeated. So what is the diagnosis? Atrial tachycardia with a relatively lower grade of Wenckebach block. What is the likely possibility? Again, tachycardia with block, atrial tachycardia with block, you have to think of digitalis again. Okay, the patient was cardioverted, and this is the electrocardiogram. Concentrate only on one lead, maybe the lower lead, trace. Irregular, this is the complex, narrow or broad? Broad complex. Monomorphic, polymorphic, bimorphic. So what is it? It is the bidirectional ventricular tachycardia. So 3 cases demonstrating digitoxicity and oral dose of digoxin. After oral dose, 70 to 80% absorption, albumin binding in 20%, and mainly excreted through kidneys. There is a high concentration in skeletal muscles, heart and kidneys. Half-life 1 to 2 days in normal renal function. And the last is the important thing. Therapeutic level is 0.5 to 1.5 nanogram per ml, and it's half in presence of heart failure. That's why we should be careful when you use digoxin in patients with heart failure selected cases, 1/2 the dose. Second, many patients will have renal impairment also. So that's why we don't encourage too much digoxin, but I am not against digoxin. In selected cases, chronic systolic heart failure with left ventricular enlargement, where the patient is in sinus rhythm or in atrial fibrillation. AF definitely, even in sinus rhythm, you can try because that's the only positive inotropic agent available for long-term use. Okay, this is a 10-year-old boy with palpitation and mild cyanosis. What is the likely diagnosis? He has come with palpitation, and this is the ECG documented. Okay, there is a regular broad QRS tachycardia. Is it likely to be ventricular or supraventricular? Most likely supraventricular because it follows a classical RBB pattern. And this child has mild cyanosis. So what is the likely diagnosis? Likely diagnosis? Look at the QRS in V1, V2. Cyanotic having palpitation is Epstein's anomaly. That's the first thing you have to tell in your examination. Okay. And you find that when they develop tachycardia, even though there is an accessory pathway, it still could be the androgenic conduction through the usual system. So the QRS morphology can be same. This is after conversion to sinus rhythm, where you can see the pre-excitation. and that pre-excitation is intermittent. I should thank Professor Nadarajan et al. For giving me the ECG from Amrita Institute. So after conversion, you have sinus rhythm with accessory pathway conduction and sinus rhythm through the usual normal pathway showing the classical QRS morphology of Epstein's anomaly, and that pattern was maintained during tachycardia. So here again, it is the antidromic supraventricular tachycardia. Okay, antidromic supraventricular atrioventricular tachycardia. Okay, is it clear? Okay, this is a 12-year-old. I am taking a few broad QRS tachycardias. The classical ventricular tachycardia. Then we have discussed about this tachycardia, reentrant, atrioventricular, in a cyanotic analysis. And here a 12-year-old boy, class 2 dyspnea on exertion, a postgraduate level of clues, muscle weakness, abnormal behavior, visual problems. Episodes of arrhythmic palpitation with an episode of occasional syncope. And obviously the ECG, all of you will diagnose. Okay, atrial activity you can't see. The ventricular activity you are seeing, is it regular? It is fast. Is it regular or irregular? It is irregular. Morphology of the QRS, narrow or broad? Broad. Is the morphology same or different? Different. So obviously you will diagnose. It is atrial ablation with a very fast ventricular response. And whenever you get a very wide QRS in an atrial ablation, the common thing is it Wonderbrand block, otherwise you go for pre-excitation. And pre-excitation you can see very well in V5, V6, the delta V polarity also you can see in V5, so you may be asked to localize the pathway. And in between you have the normally conducted QRS also. So this is the classical thing, because depending on the cycle length, occasionally the conduction can take place through the normal pathway. Okay? And this is the post-conversion ECG, which shows the typical pre-excitation and echo showing gross left ventricular hypertrophy. So what is the diagnosis? Okay, the clinical clue. Rare disease. So when you talk about that hypertrophy, you think in terms of hypertrophic cardiomyopathy. Yesterday we had discussions. You diagnose only hypertrophic cardiomyopathy, which is a broad group. HCM and HCM phenotypes. Pombe's disease, okay, but it is classically Danon disease. Danon disease, which is a sex-linked dominant, I missed that sex. It's a deficient function of lysosome-associated membrane protein for the postgraduates. There is a difference in young people, difference between male and female. Age relatively younger in male. LVH is more striking in boys. Pre-excitation is more in boys. But the frequency of AF is almost the same. The mortality is higher for females. Okay? This is a 6-year-old lady with multiple non-cardiac symptoms for 3 years on strict medication. Developed rapidly progressive dyspnea. Evaluation revealed features of stress cardiomyopathy, severe LV dysfunction, aggressive medication improving. Episodes of near syncope, self-limiting, and this is the Holter monitoring. Obvious diagnosis in the Holter is? Pardon?
Torsades.
Polymorphic ventricular tachycardia, probably torsade, because at least somewhere it is, there is a controversy whether basic ECG needs QT prolongation to say it is torsade. Because there are so many causes for this polymorphic ventricular tachycardia. Okay. So this is polymorphic, but so simple. But what is the cause for that? 35-year-old with multiple non-cardiac symptoms on aggressive medication. And developed cardiac decompensation, severe reduction, aggressive medication and improving. Okay, she is on 2 drugs. One is bicyclic antidepressants and hypokalemia. Aggressive medication. This is a real case which I saw when I was in Calicut Medical College in 1993. Okay? Now, okay, I am not talking about QT prolongation, you can read. A question I asked Professor Jagan also. If I got a polymorphic tachycardia or like this, it looks almost similar. How to know whether it is pre-excitation or tossate? So if you get this ECG, it's almost same, okay? You look at the lower and upper, it's almost the same. How to know whether it is pre-excitation or tossate? Okay, I will tell few things. Total irregularity is less likely in tossate. It can be corrected by senior people who are sitting. If it will be totally irregular. If you can see normal QRS in between, it is unlikely to be tossate. It is likely to be. Then you look at the initial vector. In the same lead, the initial vector will be same in atrial fibrillation when it is a white QRS. Whereas in tossate, the initial vector changes. So that's the clue. The initial vector, you look at the lower channel. So that's why it is going like this. The initial vector is changing in tossate. Whereas in atrial fibrillation, when it is going, I'm not talking about multiple pathways, single pathway, you find that the initial vector will be same. Okay? I asked this doubt myself. I interacted with Professor Jagan also, and then I thought these are my points to differentiate this. Okay? 45-year-old diabetic hypertensive lady admitted in CCU with sepsis, 3-day develops hypotension and tachycardia. The diagnosis is straightforward. Yes? This in the postgraduates, when you are called to critical care, you have to straight away diagnose. You cannot take time. It's a critical care. Sepsis.
Hyperkalemia,
So it should not take more than 5 seconds.
Hyperkalemia.
It's now already 15 seconds. Hyperkalemia has to be managed immediately. Okay. My point is it is so straightforward, but what is the likely serum potassium level? It has been
8.
converted with the classical hyperkalemic pattern, and this is the serum potassium. I think it is for your examination. You less likely remember, but this is a useful slide I have got. That is, when it comes between 5 and 6, it will be tended T waves. Then you find the P wave become flat and absent. Then the QRS starts widening, going to the broad QRS with a sine wave pattern. 30-year-old lady with acute, 3 people with acute chest discomfort and dyspnea, not ACS. There are 3 types of electrocardiograms, not from the same patient. There are 3 patients. The first one, second one, third one. Commonly you see this problem when you are taking. Consultants do not face because they are at home. The postgraduates are seeing these cases. And you have to discuss with the consultant. Am I right, Dr. Koshi? We can only criticize them. We can make mistakes. But we have time to sort out the case because we get the feedback from the residents. Or next day we can criticize them. Okay, the first top electrocardiogram, what does it show?
Brugada.
Pardon? No, acute chest discomfort with dyspnea.
The Brugada pattern.
Pardon? The first one, there is sinus tachycardia. What is the axis? It is plus 60 or a little more than plus 60. I'll finish it in 1 minute. Okay, there is T wave inversion in right chest leads and Q with T inversion in lead 3, suspect pulmonary embolism. Q with T inversion is very non-specific. That means there is a right axis, right ventricular strain. Right ventricle is under strain in pulmonary embolism. Okay, so it will be right-sided chest leads, right-ward axis and serial ECGs. Shift in the axis is the most important. Left second one. Okay. Gross ST elevation, sinus tachycardia mimics acute MI, but the ST elevation is seen in almost all the leads except AVR and V1. And you look at the PR segment, the PR segment is depressed. So that is pericarditis. And here there is a diffuse ST elevation indicating a myocardial injury, subepicardial myocardial injury. So it could be pericarditis, it could be myocarditis or stress cardiomyopathy or an acute myocardial injury, or it could be pulmonary embolism. And after that, this is the final ECG. I'll take only 5 or 10 seconds. That is, patient developed ventricular tachycardia and was reverted to sinus rhythm. The third patient developed ventricular tachycardia and reverted to sinus rhythm.
Long QT syndrome.
Pardon?
Long QT syndrome.
Not clear. Concentrate on the lower panel, lead 2. Okay, look at the T waves. Look at the T waves.
T alternance.
T alternance. Thank you so much for the active participation.
Thank you, Sudhir Kumar, for an excellent presentation. Master teacher, so let's see if any comments or queries from the audience. Otherwise, we will close the session. Any queries, any questions? Okay, if there aren't any, then we'll close this session. Thanks, Jay Gopal. I think we are on time.
Thank you, sir.
Thank you.
A big round of applause for Professor Jagmohan Tarakan sir, Professor Sudhir Kumar sir. I think it is indeed a great learning. Even after so many years of our DM days, I think it is really a very engaging session. And thank you so much, sir, once again. I'm sure all the postgraduates benefited. So right on time, so hand it over to him.
Thank you so much, sir. Indeed, a journey of teaching and learning. We move on to the next session immediately, and may I please invite the chairpersons, Dr. Deepak Nandan, Dr. Arun Gobi, Dr. K. Chako, and Dr. Ravindran, please, to chair the session. The first speaker for this session, Dr. Deepu Rajendran. May I hand over the proceedings now to our esteemed chairpersons. Speakers are kindly requested to stick to your stipulated time. Thank you.
Good morning. I request Dr. Deepu Rajendran to speak on the new drug as inclisiran. Over to you.
Respected chairpersons, teachers, and dear friends, good morning to all. As we all know, elevated LDL cholesterol has been established unequivocally as a causative factor for atherosclerotic cardiovascular disease. And from the large data that is available so far from the statin trials as well as population data, we know that an absolute reduction of LDL cholesterol level of more than 1 millimole per liter is associated with a 22% cardiovascular risk reduction, irrespective of all other risk factors. The management of LDL cholesterol has many challenges, of which the most important is the ever decreasing targets of the LDL cholesterol. If you look at the latest guidelines from the European and American Society, you can see that the highest risk group has an LDL cholesterol target of less than 55. And from the latest Lipid Association of India guidelines has taken the target down to less than 30 in the highest risk group. The other challenges including the variability of LDL cholesterol levels, that is, there is a significant inter-individual variability in the responsiveness of LDL cholesterol levels to statins, and even in the same individuals with longer duration of statin therapy, the LDL cholesterol levels tend to increase. And also one of the major problems is the treatment adherence because of the need for daily intake of statins as well as the asymptomatic nature of the condition. A few words about the LDL cholesterol metabolism. The LDL receptors on the surface of hepatocytes control the LDL cholesterol level by binding to the circulating LDL cholesterol and the subsequent degradation of LDL cholesterol in the lysosomes. And as a result, the LDL receptors decrease the LDL cholesterol levels. Now, what is the role of PCSK9? The circulating PCSK9 binds to the LDL receptors on the hepatocyte surface and forms a PCSK9 LDL receptor complex. This then is internalized and the LDL receptor is degraded in the lysosomes. So, PCSK9 leads to decreased LDL receptors on hepatocytes and in turn increases the plasma LDL cholesterol level. Now, the PCSK9 monoclonal antibodies, what does they do? They are directed against the catalytic site of PCSK9, thereby blocking the interaction between the LDL receptors and PCSK9. This in turn leads to increase in the LDL receptors level, and there's an increased longevity of the LDL receptors, leading to decrease in LDL cholesterol levels. We have two molecules available right now, that is alirocumab and evolocumab. Both are given as subcutaneous injections every 2 to 4 weeks. And from the data available so far, they produce a 50 to 60% reduction in LDL cholesterol level and a 15 to 20% cardiovascular outcome reduction. But one of the major advantages of this over statins is that they do not have any other major side effects other than the injection site reactions. Now coming to inclisiran. Inclisiran is a short chain synthetic small interfering RNA. This inhibits the translation of PCSK9 by binding to the mRNA precursor of the PCSK9, thereby decrease the production of PCSK9. As a result, the PCSK9s are lower, so the LDL cholesterol levels are in turn lower. Like the antibodies, this is also administered as a subcutaneous injection with an initial 300 milligram dose, followed by dosing at 3 months and then every 6 months thereafter. These were evaluated in the Orion trial, and the pooled Orion data showed that again they produce a mean LDL cholesterol reduction by 50% from baseline, which is well sustained for a long duration. And the safety data also shows that they had no other major side adverse effects other than the injection site reaction. Now, when to use this PCSK9 inhibition? Based on the 2022 ACC consensus data for non-statin therapy, failure to attain the target levels with a maximal tolerated statin therapy, the first line agents are ezetimibe and PCSK9 antibodies, and the second line is inclisiran or bempedoic acid. And even in primary prevention, when the baseline LDL cholesterol is more than 190, these two agents are used as first line and second line agents when the statin therapy fails to attain the target. And here the inclisiran is so far second line agent only because of the absence of outcome data. Now, just to highlight the challenges in the management of LDL cholesterol, the statins therapy, the main issues are one, the poor adherence and the large variability and the failure to attain the target level. These are corrected to a large extent by PCSK9 antibodies as well as inclisiran. But PCSK9 again has got a poor adherence issue because of the requirement of multiple injections, monthly injections. And if it is a monthly injection, the volume of injection is also big, so it is really painful, as well as the high cost. Inclisiran, by and large, corrects all these issues except for the cost concern, because it has only a once a year or even twice a year injections, so the adherence issue is taken care. But the cost is, of course, a major concern. Now, the inclisiran has come into the highlight in primordial prevention as well by the comments of our great Eugene Braunwald in the ESC Congress News 2018, where he said that given that the inhibition of PCSK9 production by inclisiran will be able to actually prevent CAD if begun early enough in a person's life, I would propose that such a drug be administered on a regularly once or twice yearly basis to everyone over the age of 30 years. He has again said this based on some genetic data and theoretically. Now, theory apart, what are the challenges with inclisiran? As I said, there is clinical outcome data is not available. And so far, the Orion study is only with the use of statin. So concomitant, without statin use, we don't know the data. And there, as I already mentioned, there is no significant adverse effects, but only 3-year data is available. And since it is a long-acting molecule, so the adverse reactions, if it develops, we don't know how long it will last. And the small interfering RNA technology is in its nascent stage. Only a few drugs are available so far. And among them, inclisiran has a maximum long-term data. So the future adverse effects, we don't know. The availability is an issue and cost is the biggest issue. It costs around 2.5 to 3 lakhs per injection. Now, is it the end of the road for PCSK9? No. They have got a good outcome data. The monoclonal antibody technique is tried and tested technology. And more developments are coming with oral PCSK9 inhibitors showing promising initial results. So to conclude, PCSK9 inhibition in the form of monoclonal antibodies, inclisiran and oral peptides are here to stay. And both these have got advantages and disadvantages, and with the completion of ongoing outcome cardiovascular trial data, inclisiran is expected to have a more wider role, including population-wide CVD protection. Thank you.
Deepu, good talk. Just to understand, is inclisiran, when is it going to be available in our country? And when you say for primary prevention, so you mean to say statin, and this started off very early in life?
No,
because there is no data without statins?
No, we have no data as of now for inclisiran without statins. Actually, they are starting a trial with this primary prevention in the 30-year-old age group. They are starting a trial only. It is not yet available in India as of my knowledge, but they are importing it, costs around 3 lakh rupees per injection.
And any data in ACS, because if you look at PCSK9, irrespective of the LDL reduction, for acute coronary syndromes, there's a tremendous reduction LDL in the beginning part, which stabilizes the plaque. So for ACS, as even a single dose, they give it during the ACS time. Like that for inclisiran, any benefit in acute coronary syndromes?
I am not aware of the data. Theoretically, it should be the same because they produce similar, the profile of LDL reduction is similar to PCSK9 inhibition. So it should be the PCSK9 antibody. So theoretically, it should be the same. I am not aware of any data in ACS as such. And like the PCSK9 antibodies and the inclisiran reduce lipoprotein little a also. In ACS, there is a guideline. Actually, the Lipid Association of India has given a guideline that if in an ACS patient, if the lipoprotein A is more than 50, then you can start PCSK9 inhibition. Maybe inclisiran will also come up with that.
Any comments or questions from the audience?
We don't know, madam.
Yeah. So I think, thank you, Dr. Deepu. So I will call upon Dr. Anil Robbie to discuss about the new oral PCSK9 inhibitors.
Good morning, respected chairs. My topic is on oral. So, lipoprotein particles carrying apolipoprotein B, most notably LDL, initiate atherosclerotic cardiovascular disease by entering the subendothelial space and triggering a local inflammatory response. VLDL is the chief carrier of triglycerides, and VLDL cholesterol is also atherogenic. Chylomicrons transport dietary fat, but its atherogenicity is uncertain. The combination of LDL and VLDL is called non-HDL cholesterol, and it is more atherogenic than either lipoprotein alone. The main protein embedded in LDL and VLDL is apoprotein B, and like non-HDL, apoprotein B is a stronger indicator of atherogenicity than LDL alone. Management of cholesterol, particularly LDL reduction, has been cited as one of the most reliable and achievable modifiable risk factors to reduce the morbidity and mortality related to cardiovascular disease. Administration of statins to lower the elevated LDL is a cornerstone of contemporary therapy to reduce the risk of major adverse cardiovascular events in patients for whom primary and secondary prevention is clinically indicated. Statins lower the relative risk of major atherosclerotic events by 22% per 38.7 milligram reduction in LDL. Lower the LDL, better it is, and the earlier it is lowered, greater is the benefit. Withdrawal from statin therapy is associated with the great increased risk of adverse cardiovascular events. The discovery of the relationship between lipids, cholesterol, and atherosclerosis was made in early 1960s by the Framingham trial initiated by Dr. Paul Dudley White and William Campbell, and later with the discovery of LDL receptors by Michael Brown and Joseph Goldstein, paved the way for the identification of PCSK9 and its gene in chromosome 1 by Nabil group from Montreal. gain of function of mutation in that gene was responsible for familial hypercholesteremia in a French family, and loss of function in the mutation of PCSK gene in a subset of Afro-Americans were associated with very low cholesterol level and markedly reduced incidence of CVD. As in the, that's a duplication of the previous speaker, as per the European Society of Cardiology, 4 groups are there for the risk stratification: very high, high, and moderate and low. In European Society, they have clubbed the primary prevention and secondary prevention group in the same pool, whereas in American Society of Cardiology, there are 4 groups: 1 secondary prevention and 3 primary prevention. And in the secondary prevention, they have divided into 2: very high risk and non-very high risk. Very high risk is a patient who is having multiple major ASCVD or 1 major ASCVD and 2 or more high risk condition, which is mentioned here. And need for non-statin therapy. About 50% of treated patients and even 80% of the population at very high risk do not achieve the recommended cholesterol value, which may be partly explained by the rule of 6, which means even doubling the statin dose causes only a 6% additional decrease in LDL level. 7 to 29% of patients report adverse musculoskeletal events that prevent them from using statins or limit their ability to receive guideline recommended doses. Statin intolerance is an inability to tolerate at least 2 different statins, one at the lowest starting average daily dose and other at any dose, because of their adverse effects like myopathy, rhabdomyolysis, statin autoimmune myopathies. So we are having so many non-statin therapies, which is available in the market, and my topic is on oral PCSK. These are the various targets for the anti-cholesterol drugs. This is for the bombedic acid. This is for statin. This is for ezetimibe, and this is directly the inclisiran, which is earlier described, and this is a PCSK monoclonal antibodies. And intensity of lipid-lowering treatment: moderate intensity statin, the average LDL reduction is 30%, high intensity statin 50%, statin plus ezetimibe 65%, PCSK inhibitor as a monotherapy 60%, PCSK plus high intensity statin 75%, PCSK plus high intensity statin plus ezetimibe 85%, ezetimibe monotherapy only 19%, and bombedoc acid 24%. So indication for non-statin therapy is secondary prevention options for patients with very high risk. As in USC, they have combined both primary and secondary, and Europe in SCC, the secondary prevention, they have divided into very high and non-very high risk. Then statin intolerance patients and patients in whom statin alone does not lower LDL sufficiently, less than 70%. This already, it has been shown later, the dose of various non-statin drugs. And these are the landmark trials from 1994 to 2023. The last published cardiovascular outcome trial is on bombedoc acid, clear outcome, which was published last week. And now coming to PCSK, is a protein that plays an important role in LDL regulation by binding to LDL receptors on hepatocytes. The main function of LDL receptors is to remove the LDL from the circulation and prevent LDL deposits in the peripheral tissues. The binding of PCSK to LDL receptors causes degradation of the receptors through intracellular pathways. Typically, LDL receptors would be recycled via endosomes. However, excess PCSK downregulates these receptors, resulting in high levels of circulating LDL. PCSK monoclonal antibodies, now they prefer to tell monoclonal antibodies because instead of telling PCSK inhibitors, because inclisiran is also a PCSK inhibitor. So for PCSK monoclonal antibodies binds to PCSK protein and prevents these proteins from binding to LDL receptors, increasing receptors recycling, permitting the uptake of circulating LDL. These are the diagrammatic representation of this thing, and the PCSK, if there is more PCSK, the recycling of LDL receptor will be affected. And as told earlier, these are the evidence-based cardiovascular outcome trials of evolocumab in the 4-year trial, and for the alirocumab in the Odyssey outcome trials. Both outcome trials are better than placebo, and inclisiran outcome trials are less we are waiting for the outcome trials. These are Orient trial and Orient 9. And now coming to the last part, the oral PCSK is a orally bioavailable macrocyclic peptide that binds to PCSK. And in a phase 2B randomized trial on oral PCSK inhibitor, the 381 adult participants with a wide range of atherosclerotic cardiovascular disease were divided into 4 groups with the 4 doses of oral PCSK, 6 milligram, 12 milligram, 18 and 30 milligram, and followed for 8 weeks and another follow-up for 8 weeks to see the adverse effects. The final outcomes, all doses demonstrate a statistically different significant reduction in LDL from baseline to 8 weeks. Like for 6 milligram, it is 41.2, 12 milligram 55.7, 18 milligram it is 59, and 30 milligram 60%. And adverse effects were similar to the placebo. These are the various adverse effects reported: arthralgia, diarrhea, dyspepsia, etc. All those things. And these are the other applications of PCSK inhibitors, like for other than atherosclerosis, treating sepsis, tumors, some viral infections, etc. To summarize, PCSK inhibitors are a new addition to the available treatments for hyperlipidemia in patients not at goal for LDL levels with statins or who are statin intolerant, and for those with very high risk cardiovascular events. PCSK offers a valuable addition to the existing treatments. Limitations include the expense of these approved drugs and lack of availability of the oral forms. However, 2 trials of oral PCSK inhibitor have shown it is a powerful oral cholesterol lowering drug for the treatment of hypercholesterolemia and coronary disease, and shows superior LDL reduction and is well tolerated. Future development, the phase 3 trial is going to be started this year. Future development of orally available formulation and additional clinical trials with long-term follow-up will hopefully enhance utilization of this new class of drugs in the fight against atherosclerosis and cardiovascular disease. Thank you.
Thank you, Dr. Anil. I think it's a wonderful presentation. I think the oral drugs are still experimental. And I think the dosage they recommend is once daily.
Once daily.
So, I think.
Among all the drugs that we have, non-statin drugs, one of the most common indication is familial hypercholesteremia. So what is the lower stage group in which all these non-statin drugs have been tried? It's like familial hypercholesteremia, if suppose a young kid, less than 10 years, presents to you with very high LDL levels, what are the approved drugs that can be given in a pediatric familial hypercholesteremia?
I think
which was the inclusion criteria? What is the age cutoff?
About 10 years, I think the Arlacumab is approved. Other things I'm not sure.
Any questions or comments?
Thank you very much. Next session is on hypertriglyceridemia by Sandeep Unnikrishnan, Dr. Sandeep Unnikrishnan.
Respected chairpersons, my senior teachers, and my dear colleagues, good morning to all. I will be talking about hypertriglyceridemia in ACS. So hypertriglyceridemia, as you know, is the most common form of dyslipidemia observed in the general population. There are 2 principal triglyceride-rich lipoproteins. as you know, there is a chylomicrons from the intestine and the VLDL from the liver. And the ApoB is a primary apolipoprotein in both triglyceride lipoproteins, with chylomicrons carrying the B48 and VLDL carrying the larger ApoB 100. And the lipoprotein lipase is a critical enzyme mediating the hydrolysis of triglycerides, releasing the free fatty acids and remnant lipoproteins. The South Asian and Indian population, as you know, they are prone to develop ASCD at a very younger age, owing to an increase in the atherogenic dyslipidemia consisting of the elevated triglycerides with low HDL, borderline elevated LDL. If you see the LDL value, it will be in the borderline level. And there is small dense LDL particles which causes the more amount of ACS in younger individuals. And elevated TGs in turn will lead to increase in the reminiscent cholesterol, which will decrease the HDL and increase the LDL particles, thereby becoming an enhancing risk factor. So usually in any case of any cases, the primary target should be, as already told, should be the non-HDL cholesterol or measuring all the ApoB containing lipoproteins. So the CV burden is determined by the concentration of ApoB particles or the non-HDL cholesterol. So what values of triglycerides are significant? So if you see the fasting triglyceride levels, it should be more than 150 and a non-fasting level more than 175. And if you take the latest studies, it says that the postprandial triglyceride levels are also very much important. So the persistent triglyceridemia is diagnosed if the fasting TG remains above the 150 milligram with minimum 4 to 12 weeks of lifestyle interventions. Desirable levels of triglycerides should be less than 150 milligram per deciliter, and moderate elevation 150 to 400, moderate to severe more than 500 to 1000, and severe more than 1000. So when you find a patient with hypertriglyceridemia, what you should look for is the primary causes that are very, very rare and genetic. They are the familial chylomicronemia syndrome, familial hypertriglyceridemia syndrome, familial combined hyperlipidemia, familial type 3 dyspepsia lipoproteinemia, and inherited lipodystrophy syndromes. And so in the secondary causes, as you all know, the lifestyle causes like the alcohol, high saturated fat intake, sugar intake, excess calorie intake, and decreased physical activity and smoking are one of the risk factors. And among the medical things, the obesity, metabolic syndrome, uncontrolled diabetes, hypothyroidism, nephrotic syndrome, Cushing's, and HIV-associated lipodystrophy. Some drugs are known to cause hypertriglyceridemia, like the thiazide and non-selective beta blockers, atypical antipsychotics, and more amount of triglyceride release can be caused by glucocorticoids, estrogen, tamoxifen, and other drugs. So once you find a patient with hypertriglyceridemia, the first thing should be pharmacological method to reduce the triglyceride. The HR recommendation is for class 1 for finding out the cause and for the diet. So the weight loss should be promoted for the patient, loss of at least 5%, 5 to 10%, 5% decrease will decrease the triglyceride by 10%, and dietary, that is moderate to high fat with more amount of MUFAs are found to decrease the levels of triglycerides. Every 1% replacement from carb to fat will decrease the triglyceride by at least 1 to 2%. Always the complex carbs are better than the simple sugars. There is a pretty much study where they tried the Mediterranean diet on the patients with triglyceridemia. They found that patients who were put on the Mediterranean diet had a lower triglyceride levels. So if you take the diet, it should be at least 50 to 60% carbohydrate sources, usually complex carbohydrates such as whole grains and fruits, vegetables, and it should be rich in fibers, saturated fat should be restricted to less than 7% of total energy intake, and increase the amount of MUFA by nuts and other olive oils, etc., and to increase the omega-3 polyunsaturated fatty acids, oily fish. The HR recommends at least 2 servings of dark, deep, brown, oily fishes. And exercise, at least 45 minutes a day in a moderate intensity exercise, 5 days a week, and total combined at least around 150 minutes per week. So after the dietary modifications and lifestyle modifications, how to go about it? So you have to, the first drug to be started in triglyceridemia is always a statin, and statin reduces triglycerides by at least 10 to 30% in a dose-dependent fashion. If you take a low-intensity statin, it reduces around 5 to 10% of the triglycerides. If you take a high-intensity statin, it reduces by 25 to 30%. Among the statins, rosustatin is a preferred agent in the mixed triglyceridemia because the efficacy of the triglyceride lowering is more when compared to atorvastatin. And in patients who have a lower level of triglycerides, that is less than 200, the statins have a better efficacy. And if the level goes above 200, the effect of reducing triglyceride is lesser. The second group of drugs is the fibrates. They reduce triglyceride by at least by 50 to 70% and elevates the HDL by around 5 to 20%. So, but the reduction of the cardiovascular events or the mortality benefit for the cardiovascular events are only found in subset of patients who have a high triglycerides. Or you have the meta-analysis of many trials, also the older trials. The older trials, the Helsinki Heart Study and the Veterans trial actually showed a relative risk reduction in the non-fatal myocardial infarctions with gemfibrozil. Whereas the newer field in the ACCORD trial did not show any reduction in the total CV outcomes. So the agents are the fenofibrate, gemfibrozil, and benzofibrate. And the side effects of the drug is myopathy, which is more common with gemfibrozil, and liver toxicity and nephrotoxicity. The other group of drug is omega-3 fatty acid. They reduce triglyceride at least by 20 to 50%. The reduced trial was there, which actually decreased the triglyceride levels with 2 grams of EPA, eicosapentaenoic acid, versus mineral oil, and related that there was a relative risk reduction of at least 25%. Similar benefit was not found in the Strunk trial because they used a DPA plus EPA mixture. The efficacy was also proven in the JELIS trial. So the agent is eicosapentadyl ethyl, that is 2 gram BID, and adverse effect is GI, and small amount of AF were seen in the reduced trial. Niacin is not recommended because of the there is no demonstrated benefit. So the latest one, which is the Indian molecule released by the CIDES, is Saraglitazar. There is a press trial. There is 45% reduction in triglyceride levels, along with significant reduction in the HbA1c levels, because the PPR gamma improves the pancreatic function, insulin sensitivity, and there is an anti-inflammatory effect. So there is an additional advantage of diabetic control. This is a pipeline drug. There is a volanesorsen, that is antisense oligonucleotide inhibitor of ApoC3. It has been studied in monogenic chylomicronemia approach trial, and the adverse effect is injection site reaction at thrombocytopenia. There are some other pipeline drugs like the angiopoietin-like protein 3 inhibitor, evinacumab, which is under investigation, and gene therapy also. So how do you go with the practical guide for initial treatment? Any patient can be divided into 4 things. I will discuss about 1 and 4 alone because that is the topic of discussion today. That is ASCVD risk with fasting triglyceride more than 150 to 500, and any patient with more than 20 years with triglyceride more than 500. So this is the one which you should follow. Any ASCVD, that is any myocardial infarction or any ACS, patient having 175 to 500, first thing is to rule out secondary causes. Do not jump into starting the fibrates or any other drug. First is to rule out secondary causes, optimize the diet and lifestyle first, optimize the glycemic control, then maximize the statin therapy, preferably high intensity statin. Then if still the levels are higher, then a triglyceride reducing drug can be given. And among patients more than 20 years with triglyceride more than 500, first thing is rule out secondary causes, optimize diet and lifestyle, optimize glycemic control, and then start on fibrate or an omega-3 fatty acid. To summarize, statin should be considered in all levels of triglyceride. It has significant value in reducing triglyceride level. And for high TG levels, omega-3 fatty acid followed by fibrate can be given. That's a class 2A recommendation. Dietary recommendations, finding secondary causes, regular exercise, that has got a prime importance and is a class 1 indication. Thank you.
Do we have any reliable study that showed that reducing triglycerides by drugs results in reduction in coronary artery problem? No, what I was asking is there any reliable study that showed that reducing triglycerides by drugs results in coronary artery disease?
No, sir. Actually, as my knowledge, the significant reduction in triglyceride, the studies are not there, sir. Reduces the triglycerides. But it's non-HDL cholesterol is there, sir. Non-HDL cholesterol, when it is decreased, then
even if when we are giving statins, if the patient has got a low triglyceride, it's very important that they follow the secondary prevention methods, because we don't know whether that reduction has resulted in a clinically important region.
Yes, sir. Yes, sir. That is why there is unmet need of statin, because even after starting the statin, patient because triglycerides are important usually in recurrent ACS. So patient, even with the LDL cholesterol being normal, patients are developing a recurrent ACS. The reason for that is because of, it is postulated that is because of the triglycerides.
Is addition of omega-3 acids, is it routinely recommended, or addition of omega-3 fatty acids along with statin?
Yes, sir.
It is routinely recommended, or?
Yes, sir. It has been tried. It has been studied in the eicosapentaenoic acid was studied, and both the Docaso and Ecoso was studied in the Strunk trial. But Strunk trial didn't show much benefit because of it was not a purified form. It was DHA plus EPA. But EPA alone was proven in 2 trials that reduces the mortality.
I think in some trials it has been shown that there is a slight increase in the LDL with
yes, sir.
omega-3 acid.
Yes, sir.
We look at 2 substrates like stable CAD and patients with ACS. How is the approach different to management of hypertriglyceridemia? In a person who has come with ACS, if you do the LDL, you do the FLP and you find that the TG is somewhere like 500. A person comes with ACS. And your other subset, you have a person with stable CAD, you find a TG which is more than 500. That's what you have alluded to in most of the guidelines. In the context of ACS, if you find a first lipid value, triglyceride more than 500, what would your management strategy be?
Sir, first thing is to give the anyway the patient is already on statin, high dose statin therapy is definitely there. See for any secondary cause of hypertriglyceridemia. If it is a diabetes, something or another will be there definitely. So if it is a diabetes, try to control the diabetes. Maybe he is an alcoholic, try to then reassess the lipid levels after some time. If still the lipid levels, the triglyceride levels are higher, then only add the second drug.
And one more word of question is when you combine statin with fibrates, there's a higher incidence of myopathies.
Yes, sir.
And saroglitazar, is there any cardiovascular data in especially ACS? Because
ACS it is not there, sir. ACS actually tried, it is an Indian molecule, so the number of trials are very less. Only
Okay, thank you, Dr. Sandeep.
Thank you, sir.
Thank you very much, sir. May we close the session? Thank you, sir. Thank you to the chairpersons. Thank you to all the presenters of the session. May I please invite to chair the next session, the Best Paper Award session, Dr. Ajit Kumar, Dr. P.P. Mohanan, Dr. Rajan Joseph Vanyuran, and Dr. Sajeev CG, please. May I request all the presenters to kindly maintain your time limit. It's 6 minutes plus 4 minutes. May I hand over the proceedings to our esteemed chairpersons. Professor Manyuran, sir.
Good morning, everybody. Now we are going, next session is a very interesting session because it is a competition and a prize has to be won. Before I start the program, I would like to know whether all the presenters are there or not. Vijay Nagi, Bijoy, Radish, Sudipta, Anup, and Simna. Wish you all the best. All cannot win the prize, but wish all of you the best.
Should stick to time.
Stick to time, and the time for your presentation is 6 minutes and 4 minutes for discussion. And the organizers have given us a very elaborate plan of marking the presentation, the type of study, whether it is prospective, retrospective, there is a new study and all. Impact factor, whether this study has got an impact on our regular practice. Abstract quality, how is the quality of the abstract, is background, justification, all those points. Methodology, the results and discussion and conclusions. Quality and accuracy of slides, sticking to time, and answering questions. So all these are important. You have to present well, your slides should be good, you should stick to time, and your answering should be prompt and good. So I wish all of you the best. And I request my colleague to give his comments and call the first person.
Let the best person win. Let us begin, and may I have the pleasure of inviting Vinay Negi, who will present the observational study on outcome of primary PCI in octogenarians.
Slides.
Who is keeping the time? At 5 minutes there should be a warning, and 6 minutes second warning.
Yeah.
Who is keeping the time? Okay, right, yes. Can you start? Yes. Don't waste your time.
Good morning, respected chairpersons, teachers and colleagues. Today I am presenting my paper on an observational study on the outcomes of primary percutaneous coronary intervention in octogenarians, presenting with acute ST segment elevation myocardial infarction. Patients with acute STEMI are currently treated predominantly with primary PCI. However, there is paucity of data about the safety and effectiveness of primary PCI in octogenarians, that is more than or equal to 80 years, higher rates of comorbidities, fragility, increased risk of bleeding and impaired cardiac function puts them at a higher risk of procedural complications during PCI. It is unclear if octogenarians have a reduced primary PCI success rate. While some studies do not, there are studies which show a greater risk of short and long-term mortality as well as complications. Hence, this study was undertaken to evaluate the in-hospital acute and short-term outcomes of primary PCI in octogenarians. Objectives were to study the outcome of primary PCI in octogenarians presenting with acute STEMI and to study the clinical and angiographic profiles in octogenarian group. It was a prospective observational study conducted between February 2022 to January 2023. Study population consisted of patients hospitalized in cardiology department ICCU, Medical College Trivandrum, and who are undergoing primary PCI. Inclusion criteria: age more than or equal to 80 years with informed written consent, and those who are fulfilling the SCCHA guidelines. In the results, there was a total of 122 patients, of which the most common age group was 80 to 84, that is 78.7%. Males predominated the study, 64.8%, and the most common risk factor which was seen was hypertension in 59.8% of the patients, followed by diabetes, smoking, and dyslipidemia. The most common comorbidity seen was COPD in 15.6% of the patients, whereas 79.5% didn't have any comorbidities. Most common presentation in ECG was sinus rhythm, 86%, followed by complete heart block in 6.6%, atrial fibrillation 3.3%, and VT in 2 patients, that is 1.6%. The most common KLIP class was KLIP class 1 in 74.6%, whereas only 4 patients presented in KLIP class 4, that is 3.3%. The total ischemic period was more than 6 hours in around 57.4% of the patients, and the most common type of STEMI was inferior wall MI, followed by anterior wall MI in 35%. AKI was seen in 10.7% and contrast-induced encephalopathy in 3.3%. Mean duration of hospitalization in days was 5.2 plus minus 1.8. An important finding of this study was that ticagrelor was used in 92.6% of the patients as loading drug, and also right radial approach was used in 84.4% of the patients. The most common vessel affected was single vessel disease, followed by 2 vessel disease in 33.6%. Most common infarct-related artery seen was RCA, followed by LAD in 40%. Calcification was seen in 21.3%, diffuse disease in 48.4%, and CTO in 4.92% of the patients. Culprit vessel PCI was done in 92.6% of the patients. Post-procedural TIMI-3 was achieved in 91.8%, and exercise complications in the form of mild foramen and groin hematoma was seen in 7.4% and 21% each. The predictors of angiographic success in our study, that is post-procedural TIMI-3 flow, was seen in those patients without diabetes, without AKI, TIP less than 6 hours, inferior wall MI, presenting with KLIP plus 1 or 2, RCA as the infarct-related artery, and without thrombus. And these were all statistically significant. And likewise, the predictors of in-hospital mortality were diabetes mellitus, systemic hypertension, AKI, anterior wall MI, QRBB, thrombus-laden lesions, TIP more than or equal to 6 hours, and KLIP plus 3 and 4, which were all statistically significant. Ejection fraction less than 50%, LM-associated lesions, post-TIMI-3, not attending post-TIMI-3, and slow flow or resolution less than 70%. The adverse events during index hospitalization where heart failure was seen in 38.5%, and at follow-up it was 5.7%. No episodes of major bleeding. Minor bleeding was seen in 12.3% during hospitalization. Mortality was 6.6% during hospitalization, follow-up 4.9%. The Kaplan-Meier estimate at the time of discharge was 93.4%, and during follow-up was 88.5%. To summarize, a total of 122 octogenarian patients were included in this study. The oldest patient was 92 years. The proportion of patients presenting as stent thrombosis was found to be low. That is 3.3%, contributed by almost universal use of ticagrelor as loading drug, and perhaps by improved technical aspects. The all-cause in-hospital mortality was 6.6%, that is 8 patients, all of whom expired within 48 hours after primary PCI. At the end of 3 months, the mortality was 4.9%. Angiographic success was achieved in 91.8% of the patients. And cardiogenic shock continues to have high mortality despite primary PCI, with an in-hospital mortality of 100% in our study. To conclude, primary PCI in octogenarian is feasible and relatively safe. There is favorable immediate and short-term outcomes of primary PCI in octogenarians based on our findings. Ticagrelor is safe in octogenarians. Right radial access is feasible in majority. In-hospital mortality is 6.6%, which is comparable to the young. And immediate revascularization therapy should be routinely considered as the first-line treatment for STEMI, even in octogenarian patients. And finally, advanced age is inappropriate to be utilized alone as a primary PCI exclusion criteria. Thank you.
Thank you. We needed this data because Kerala has a lot of octogenarians and all that. One thing possibly, what is the percentage of primary PCI done in this age group? Do you have a percentage or just you took the primary PCI group alone? That is number one. Number two, basically your 30-day mortality looks very impressive because when I was going through the data, it said 30-day mortality in the large registry is something like 30%.
Yes,
So
sir.
what do you think your excellent 30-day survival rate?
Sir, firstly, this study was conducted because there is no specific study on PCI in more than 80 years age group, especially in India. There is no specific Indian study. And so there's success, the success rate may be because most of the patients in the study were having single vessel disease. In most of the other major studies which they have done, they have shown that it was associated with triple vessel disease, multi-vessel disease, and complex lesions. But those type of lesions were very few in our study. So that may be also a factor which has affected it.
Percentage of STEMI patients? How many percentage of STEMI patients in the non-Nigerian group underwent primary PCI? You did not mention that.
So we actually included all the patients, yes.
You have said that there is a higher incidence of inferior wall myocardial infarction in the elderly in this group.
So according to
Usually
our
we
study,
get that anterior wall and inferior
Yes,
wall
sir. Yes,
are
sir.
practically the same.
Yes, sir.
But here you have projected that inferior wall myocardial infarction is much
Yes, sir.
more frequent. What may be the explanation?
So maybe anterior wall MI, they couldn't have made to the hospital because anterior wall MI, they are usually associated with more severe LV systolic dysfunction, more adverse events. So maybe before they present to the hospital, maybe they have, they couldn't make it to the hospital, maybe they have expired, and only those inferior wall MI patients could make it.
Is it based on any finding or you are making a guesswork?
Sir?
You said that some of the patients with anterior wall myocardial infarction may not be reaching the hospital. They may be dying on the way. Is it based on some information that you have collected or you are making a guesswork?
So no specific information as well.
Then
as
don't
like
make
that.
statements. You can say you do not know.
Yes, sir.
And I would like to know why the calcification in these patients was only 21%. I would
Yes,
have
sir.
expected extensive calcification in an octogenarian. What may be the explanation for a low calcium in the coronaries in these patients, in your patients?
Sir, in my patient, sir.
Calcification, you have mentioned 21%.
Yes, sir.
That is, I would have expected it to be more than 50%. What
sir.
may be? Is there an explanation?
So a possible explanation can be those patients with more extensive calcification disease, they may not have come up to this age of 80 years. Maybe they might have expired during that.
Is another guesswork or there are some data?
Sir, this is
I
just
think
an
your
assumption.
answer should be based on your findings.
Yes, sir.
If you feel that you are not able to answer, you can say, sir, I do not know.
Yes, sir.
That should be the answer.
Access site was radial.
Exercise was radial approach in most of the patients, 84%.
Because most of the complications in octogenarians were problems with the access site. You didn't find any difference in your study.
Yes, sir.
Then have you compared, maybe it would have been better if you had compared with the less than 8 years and more than 8 years your results, because that would have given a better understanding.
Yes, sir.
Was this a consecutive series or was it choice by whichever the way it came? Was it consecutive by selection? Were the cases consecutive?
Yes, sir. Sir.
It
Consecutive,
was.
sir. Yes, sir.
That means all the cases 1, 2, 1, 4 were selected?
Sir, all those over that 1 year study period, all those patients were included in this study. all those patients being admitted.
Why did you have only 3 months of follow-up? 3 months of follow-up to have a follow-up mortality is not accurate. Why did you not take a longer, 1 year follow-up?
Yes, sir. That is one limitation of the study, sir. We couldn't.
But
take
that
up,
would
sir.
not clearly show what is the mortality, because
Yes, sir.
mortality has to be decided at 1 year. And what happened to the non-culprit vessels? You
Yes,
have
sir.
not mentioned that.
Yes, stage PCI, around 21% underwent stage PCI at a later date. And around 7% underwent non-culprit vessel PCI at the same setting. Around 7%.
Okay. Now, do you realize that octogenarian's definition is basically what?
Pardon, sir?
Octogenarian definition is?
So more than or equal to 80 years.
It's only 80 to 90.
80 to 90, yes.
So, 90 plus, so if you put it's not accurate absolutely.
Yes,
Okay.
sir. Okay, sir. Thank you, sir.
Thank you. Let us give him a big hand, please. We'll go to the next presenter. Clinical profile and predictors of poor prognosis in infective endocarditis. Bijoy Elias.
Good morning, everyone. Respected chairpersons, teachers, colleagues, and dear friends, today I am here to present clinical profile and predictors of poor prognosis in infective endocarditis. Infective endocarditis is a continuously evolving disease with a persistently high morbidity and mortality despite several advances in diagnostic techniques, antimicrobial therapy, and surgical management. Annual incidence in worldwide is 3 to 10 per 1 lakh people, and overall mortality accounts for 25%. And the objectives were to determine the clinical profile and outcome of patients with infective endocarditis treated in Government Medical College, Kottayam over a period of 12 months. And second objective was to determine the predictors of poor prognosis in patients with infective endocarditis. Methodology and procedure. This was a prospective study conducted among 75 consecutive infective endocarditis patients who attended Department of Cardiology, Government Medical College, Kottayam over a period of 12 months. Patient underwent complete clinical evaluation, laboratory investigations, echocardiography as a part of study at the time of admission. Patients were reassessed at the time of discharge to determine the prognosis as if when required. Final outcome were measured in terms of primary outcome, that is mortality, and secondary outcome, need for surgery, and complications that occurred as a sequelae of infective endocarditis. Analysis. Categorical variables were expressed as a frequency and continuous variables were expressed in mean and standard deviation. The comparison of mean values across the different outcome groups were done using one-way ANOVA test, and pairwise comparison was further done using Tukey's test. Association between the categorical independent variables with the outcome was evaluated using Pearson chi-square test. Coming to the results. Total number of patients included in the study was 75. The male is to female ratio was 1.5:1, that is males 45 patients and females 30 patients. Mean age was 47.29 plus or minus 12.86 years. The minimum age was 17 years and the maximum age of the patient was 71 years. 53 patients had a history of underlying cardiac illness in the study. 12 patients had a history of undergoing dental procedure 1 month before diagnosing infective endocarditis. The most common symptom was fever. 58 patients had history of fever, that accounted to 77%. 31 patients presented with features of cardiac failure. And in our study, mortality was 32%, that is 24 patients. Coming to the interesting findings, blood culture findings. The most common organism that we isolated was Staphylococcus aureus, which accounted for 28%. The second was Streptococcus viridans, which accounted for 23%. And 15 patients had actually culture negative, that is 20%. And 2 organisms that we got was Candida, which accounted for 13%, and Enterococcus 7%. Coming to cardiac valve involvement, most common valve involved was mitral valve, which were in 30 patients, and most common underlying cardiac etiology was rheumatic in our study, and mitral valve prolapse accounted for 12 patients, and among congenital 17 cases, 9 cases were bicuspid aortic valve associated with aortic regurgitation with or without aortic stenosis. Coming to the results, primary outcome,
as we said earlier, mortality, it was 24 patients, that is 32%. Secondary outcome was noted in 28 patients, that is 37.4%. Patients with complications, 11 patients, that is embolic phenomenon, cardiac failure, and need for surgery. 17 patients were taken off for surgery, which accounted for 22.67%. Coming to mortality predictors, thrombocytopenia, platelet count less than 1 lakh, had a p-value of less than 0.001. And inflammatory markers, we took neutrophil to lymphocyte ratio and platelet to lymphocyte ratio. Both of them were statistically significant predictors of mortality with a p-value of less than 0.001, a mean value of 11.45 NLR and 163.96 platelet lymphocyte ratio was significantly associated with mortality. Then coming to C-reactive protein, a mean value of 88.29 was associated with mortality. A mean ESR of 74.42 was significantly associated with mortality. A mean procalcitonin level of 1.45 and a mean D-dimer value of 909.7 was associated with mortality. And the D-dimer value was significantly higher we got in patients who were discharged with complications. And according to the microorganisms from our study, Staphylococcus aureus and Candida infective endocarditis patients had a higher mortality. Then valve involvement, when we compare different types of valves which were involved in infective endocarditis, prosthetic valve endocarditis was more commonly associated with mortality. And according to vegetation size, as the size of the vegetation increased, with a mean vegetation size of 1.27 centimeter, it was more significantly associated with mortality. Conclusion, number of infective endocarditis patients attending the hospital was high. Mortality among the infective endocarditis patient remains high. In our present study, it was 32%. Laboratory parameters such as thrombocytopenia, elevated NLR, PLR, elevated inflammatory markers such as CRP, ESR, procalcitonin at the time of admission, blood culture sensitivity positive for Staphylococcus aureus and Candida species, and presence of large vegetation in size and prosthetic valve endocarditis are associated with poor prognosis. Early recognition of high-risk patients may help in reducing the morbidity and mortality associated with infective endocarditis. Limitations. The sample size for our study was very small, and the study was conducted in a tertiary care center where mostly referral cases were treated, and patients were sometimes referred late, which might have increased the incidence of morbidities and mortality. Hence, the sample is not a true representative of general population. Thank you. Thank you.
Thank you. Bijoy, did you have a group of patients where there is an indication for surgery and the patient did not undergo surgery?
Actually, 17 cases we referred for surgery. Out of them, only 11 were taken up. 3 patients were not willing. They went home.
Do you have a follow-up of those patients who were not operated but there was an indication for surgery?
Sir, they are attending our OP. They are coming to our OP. Only one patient has returned.
Oh, so they are still alive and there are... Okay. Then I would like to know whether the patient, you had about 25% of patients had culture negative.
Culture negative, sir.
Was there a difference in mortality between culture negative and positive?
Yes, sir.
Was there a difference in mortality?
Yes, sir. Mortality was different.
In culture positive and culture negative patients?
Yes, sir. Mortality was more in culture positive cases. For culture negative, actually, the mortality associated was less.
Oh, that is a strange finding.
Yeah.
Because usually the culture negativity is associated with more mortality because you cannot use the most appropriate antibiotic. Embolic episodes, did you look at the embolic episodes and was it related to mortality because cerebrovascular embolism or hemorrhage into the brain or complications which are also, you are not mentioned about complication and the risk of mortality?
Sir, it is actually we consider as secondary outcome. The cause of death, actually we got embolic phenomenon also as a cause of death, but the secondary outcome as complications, there were the patients who were discharged were taken for calculation of it.
So I want to know whether when the patients had embolic episodes, that obviously means that their antibiotic is not, antibiotic coverage may not be adequate.
Yes, sir. Yes,
and
sir.
In those patients were there a higher mortality?
Yes, sir. Mortality was higher.
I also would like to know when a patient who had initiated on an antibiotic and patient did not respond and then you change the antibiotic, was it associated with higher mortality?
That those patients who were not responding to treatment, even with 2 weeks, 2 weeks, actually the patient, the mortality was very high. And after 2 weeks, some patients were also referred for surgery for further management.
The organisms identified was Staph aureus in larger number. Is it seen in nowadays?
Sir, almost all the studies, Staphylococcus aureus is being considered as the most common organism nowadays, sir.
So why do you think that, what is the reason for this change? Any particular?
Sir, hospital acquired infections.
Another thing is you have done calcitonin, procalcitonin levels.
Yes, sir.
Is there any difference between the organism and the procalcitonin level?
Staphylococcus or aureus infections had a more value of procalcitonin level, sir.
And mortality?
It was higher in, as the procalcitonin value increased, mortality was higher, sir.
You have acute endocarditis following surgery or some?
Sir?
Any patients with acute endocarditis?
No, sir. No, sir.
What are your surgical results of patients who were referred for surgery? Because one thing that you are looking at is the mortality, isn't it?
Yes, sir. Yes, sir.
Patients who were referred for surgery, what is the mortality in those patients?
Patients who were referred for
Surgery or who underwent surgery?
After surgery, actually, we didn't get a follow-up, sir.
No, but that is very important, isn't it? Because these, if the mortality, surgical mortality is usually high, and that will have an impact on your mortality.
Yes, sir. Yes, sir.
And in your mortality predictors, have you done a univariate and a multivariate analysis?
Sir, multivariate analysis was not done, sir. Actually, so many factors were there, clinical, laboratory, echocardiogram. So actually, multivariate regression was not done.
But that is important.
Bijoy, excellent study. You know, one of the time-tested predictors was albumin. I don't know whether you have tasted you have looked for hypoalbuminemia, because that is one of the most well-validated predictors. Number two is, did you compare it with the standardized predictable scores like a Euroscore?
No, sir.
These are the two things possibly maybe you may be able to do and make it much more better.
Let's give him a big hand.
Next presenter, please. Dr. Ratish Kumar.
Respected teachers, respected chairperson, and dear friends. Today I am going to present the outcomes of patients with heart failure enrolled in Trivandrum Heart Failure Survey. People living with heart failure are on continuous rise due to population aging and increase in prevalence of risk factors. The data available is about heart failure is only limited. Available data is largely hospital-based or projected. In Trivandrum Heart Failure Survey, a community-based survey, we got community-based data regarding heart failure prevalence. My objectives was to study the outcomes of patients with heart failure enrolled in Trivandrum Heart Failure Survey, and to study the treatment and interventional effects, and to study the progression or regression of symptoms. Actually, Trivandrum Heart Failure Survey, it consists of we screened 61,200 patients in 73 Grama Panchayats, out of which 52% were male and 48% were female, and we got 1,034 patients with heart failure. On that patients, 960 patients completed the follow-up. Methodology was different training sections to the ASHA workers, and with the help of field workers, we conducted screening section as well as 120 community medical camps, and each camp attained around 100 patients. My methodology, it is a study, is actually an ambidirectional cohort study. Study period was from September 2019 to April 2023. Inclusion criteria, all the patients with heart failure detected in Trivandrum Heart Failure Survey were included. And the methodology, community follow with ASHA workers, and with the help of PHC medical officers, we retrieved data from the community And we have a heart failure clinic in our hospital. We reviewed patients there also. Our results were, we got 38% patients with heart failure with reduced ejection fraction, and 18% of patients with mid-range ejection fraction, and 44% of patients with the preserved ejection fraction from the community. And age was, minimum age was 18 and maximum age was 92, and the mean age was 47. Urban and rural almost equal, and gender female were more than male. And risk factor for prevalence in patients with the preserved ejection fraction, hypertension was the major risk factor. Then comes the diabetes, and coronary artery disease consists of 18%. But in mid-range and preserved ejection fraction, coronary artery diseases consist the major risk factor. And diabetes and hypertension almost 48 and 41%. And from the study, we find out that in heart failure with reduced ejection fraction, only 75% patients got RAS inhibitors, and 57% patients got beta blockers, and 15% only got MRA, and SGLT2 inhibitors, very minimal number, 12%. Non-availability of free drugs and financial constraints limit the patients from GDMT, and we find out that GDMT optimization was very poor. And only 12% in heart failure with reduced ejection fraction group has got all the 4 pillar drugs. And while analyzing the symptom, we find that heart failure with the preserved ejection fraction groups shows non-significant improvement in symptoms, where other 2 groups have some symptom improvement during the course of follow-up. And hospitalization, in heart failure with reduced ejection fraction groups, 36% of patients underwent hospitalization, and rehospitalization also more in heart failure with reduced ejection fraction group. Hospitalization and rehospitalization are significantly more in reduced ejection fraction and mid-range ejection fraction groups, and 46% of patients with heart failure with reduced ejection fraction, rehospitalizations are mostly due to non-compliance of treatment. And another factor is that out of the 92% of deaths in heart failure with reduced ejection fraction, that patients have multiple hospital admissions. And all-cause mortality, we find a total mortality of 19.27. Actually, this study, 4 years we studied, but during the early part, COVID was there. So in the later part, mean mortality of around 1.5 years we got. That is 19.27%. And in reserved ejection fraction, heart failure with reduced ejection fraction group, it is 23%, and mid-range it is 14, and preserved ejection fraction it is 18. And mortality primarily due to heart failure, it is 71%. Total 84 patient death in heart failure with reduced ejection fraction group. Out of that, 46 were due to heart failure worsening, and 14 due to sudden cardiac death. MACE events, we can find that there is a significant increase in non-fatal stroke and non-fatal MI in heart failure with the preserved ejection fraction group. And atrial fibrillation almost comparable. Correlation parameters in mortality and hospitalization, there is a significant positive correlation of age and mortality and hospitalization, and male gender had a significant positive correlation with the mortality and hospitalization, and there was a significant association of symptom. Increasing symptom increases the mortality and hospitalization, and guideline directed medical therapy showed a negative correlation, which suggests that GDMT will help in preventing mortality and hospitalization for reduced ejection fraction group. What next? We can ensure more emphasis on heart failure detection in the periphery, and take measures to increase the drug availability in the peripheral centers, and to ensure drug compliance, and more training regarding drug initiation and optimization, and there should be a heart failure team in all major centers. Thank you.
Thank you for your presentation. All these patients had echocardiographic examination?
Yes, sir.
Did they have a serial examination also?
6 months and 12 months, sir.
12 months. And what was
that serial examination is not for all, sir. That's why I didn't include the echo details. First echo we done for that 1030. Actually, we screened 7,000 patients in our camps. Around 120 camps, and we had done screening echo for all of them. Echo, ECG, and in patients with diastole dysfunction, we taken NT-proBNP also.
Did any of these patients with preserved ejection fraction over a period of follow-up 1 year, did they go to reduced ejection fraction?
Yes, sir, but that is not statistically significant. We
No,
had
how many percentage?
the percentage I have, sir. But
Okay.
Now you assess the one-step improvement in the functional class. What was the questionnaire that or the assay you used? The functional improvement in the. Now you also have shown that. What was the questionnaire that used in the functional improvement?
their daily activities.
Is it a prescribed format that you used, or just asked about them the just activity?
Activity only, sir. Ordinary activity and.
You didn't stick to any of those time-tested assessment in the improvement.
Yes, we actually assess the improvement in quality of life and all, but not in a questionnaire manner. We didn't use that questionnaire.
What is again surprising is that your HFpEF mortality seems to be something unbelievably better than the HFrEF mortality. 4% versus 27 or 28%.
Yes, sir.
Do you think there is any specific reason for that?
No.
Continuing on that, what is the expected mortality, 2-year mortality in heart failure or preserved ejection fraction?
Almost comparable with reduced rejection fraction, sir. In all other studies, it is comparable with reduced rejection fraction. In heart failure registries, it is that is for acute heart failure registries. In hospitalized patients, it is almost comparable for reduced and preserved ejection fraction. But in my study, in our study, it is less.
Do you have any reason for that? No.
Maybe more detection. Actually, in other studies, heart failure with reduced rejection fraction is less in hospital-based cohorts. More patients are in reduced rejection fraction group. But in our study, preserved ejection fraction group is more. That may be one reason. More detection may be one reason.
What is the criteria for diagnosis of heart failure with preserved ejection fraction?
Then there is lots of functional criteria. Patient with symptoms first, then echocardiographic criteria, and then the biomarkers and all. Now they are using LA strain, and also in previous ESC, we actually used the previous ESC guideline. In that, NT-proBNP was actually higher. They set higher value, but recently they reduced the NT-proBNP value also.
No, we want to know what was the criteria that you used, because
Previous
you have
criteria,
a very
sir.
high incidence of heart failure with preserved ejection fraction.
Sir, we used the previous criteria with NT-proBNP more than 200 and 600 value AF patient.
You have not given BNP values in your study. That's a very important part of the...
Yes, sir, because of the...
Why? You have not done that.
We have data, sir, but time frame... 6 minutes.
What is ambidirectional? You said the
Sir,
study is
actually,
ambidirectional.
Actually, 2020 in September, we started the study. From the starting itself, we got heart failure and atrial fibrillation patients. So that
No,
patient...
I'm asking, what is ambidirectional?
It is prospective and retrospective.
That's what you meant.
Yes.
Okay.
Thanks.
Thank you, and let's give him a big hand.
I said, I'm telling you, architect has
Yeah, Sudipto.
so he said he will get permission. Let him do it. Then he said, but you, I have to evidence.
Good morning, respected chairperson, my respected teachers, seniors, and dear friends. Today I shall present our thesis of presence of myocardial fibrosis on cardiac MRI and its impact on short-term outcomes in a cohort of HFpEF. This study was an ambidirectional observational study, and study period was 2018 to 2022 with 25 months mean duration. The background of the study was, as we know, HFpEF is associated with diastolic dysfunction, and stiffness is mainly causing the heart failure with ejection fraction. And mainly it is caused by fibrosis, hypertrophy, and microvascular inflammation. And that is mainly causing the pathogenesis. So our hypothesis was patients with HFpEF have subclinical or overt myocardial fibrosis manifested by increased T1 value or LG respectively in cardiac MRI. So objective of our study was to evaluate clinico-demographic parameters of HFpEF and to evaluate the presence and prognostic significance of myocardial fibrosis in cardiac MRI. So we classified event group as hospitalization for heart failure, cardiovascular mortality and stroke. So we have taken 3 consecutive patients of HFpEF in our OPD or IPD, and controls were taken 3 consecutive patients who underwent CMRI as part of their investigation other than heart failure and reported to be normal MRI. And statistical analysis were done by STATA version 14. So our inclusion criteria was classical criteria for HFpEF, and that is LV ejection fraction of more than 50% and any objective evidence of heart failure, either symptomatically along with increased pro-BNP. We took the cutoff of 125 in sinus rhythm and 365 for atrial fibrillation. The important exclusion criteria was age less than 18 years and severe valvular heart disease, congenital heart disease, and in HFpEF patient population, hypertrophic cardiomyopathy and significant coronary artery disease either requiring revascularization or indication for revascularization were excluded. So coming to the demographic profile, mean age of our patient population was 63, and most of the patients were female. 87% of the patients were female, and most of the patients were either diabetic, hypertensive, or the patients were significantly obese in our patient population group. So saturation was slightly lower, but is statistically significant in patient population compared to the control group. So we took the HFpEF criteria that more than 5 cutoff was used, and that was 73% patient met the criteria. And the medication wise, 87% patients were on more than 2 antihypertensive agent, and along with 87% of the patient were on loop-diuretic. And only 27% were on SGLT2 inhibitor, which is approved for class 1 indication for HFpEF. So also we have seen that cardiothoracic ratio and cranial angle in X-ray were significantly higher in cases group. And as we have assessed by echocardiography, diastolic dysfunction were grade 3 diastolic dysfunction were present in 13% of the patient, and grade 1 was 34%. And in hypertrophy pattern in echocardiography, we have seen only 20% of the patient in case group were normal, but others were either eccentric hypertrophy, concentric remodeling, or concentric hypertrophy compared to that is significantly different between the case and control group. So ecocardiographically, as you can see, almost all parameters are significantly, statistically significant difference were noted between case and control. In MRI parameters also, there is significant, other than left ventricular ejection fraction, there is interventricular septal thickness in systole, diastole, RVIT, all are significantly higher in cases group compared to control. So we went ahead with the T1 and T2 MRI sequences. This is the sequences that blue indicates the lower value of, and red indicates the higher value of T1 sequences. So to T1 sequence we have done that showed that upper 3 parameters shows basal, mid, and apical segment. The 18 segment model, classical 18 segment model we analyzed. So as you can see, that T1 value compared to the case control group, they are significant different, and the lower value is showing this lower value is showing the total average T1 value compared to the patient group. That is significantly different. But T2 we assessed that is not significantly different between case and control group. In univariate analysis, you can see that RV cardiac output by MRI, posterior wall thickness, increased posterior wall and IVS thickness in diastole. In echocardiography, the increased RVSP, increased LA volume index, and LV mass by Ticho's formula were significantly associated with HFpEF in patients. And odds ratio of T1 value is significantly higher. As you can see, there is no crossing in the 1 value, and odds ratio of T2 values are not significant. So coming to the event group, as you can see, the events, cumulative events were 67% in our patient population. As we can see that age was comparable, and the significantly higher NT-proBNP were associated with event group compared to the non-event group. And as also cranial angle and CTR ratio was also higher in event group compared to the non-event group. And we can see that echocardiographic parameters are not significantly different between the event and non-event group. And GLS also, there is no difference between the event group and non-event group. And MRI, only the interventricular septum thickness were significantly different between the event and non-event group. So LG parameters we have seen that only there is no difference between event and non-event group, but there is case control group, there was significant difference. As we compared with T1 value, that was not significantly associated with LG, although numerically higher value were noted of T1 in LG positive groups. And we compared that event versus non-event group, that is significantly different T1 value, that is around 1100 in those patients. So IVS diameter thickness were significantly correlated with T1 value, and other value by echo parameters did not significantly correlated with the T1 values. So we found out that there is significant overestimation of interventricular septal thickness and LV mass index in echocardiography compared to the gold standard MRI population. So already we know that HEPP is associated with fibrosis, and my conclusion of the study is higher T1 value, but not T2 was associated with HEPP group compared to age and sex matched control population. Among HEPP patient, high T1 myocardial value were associated with higher rate of all-cause mortality, death and stroke and hospitalization in short-term follow-up. And IVS thickness by MRI but not echocardiography had good correlation with T1 values. And IVS thickness and LV mass were significantly overestimated in TT compared to MRI. And higher NT-proBNP, higher diuretic requirements, and increased cardiothoracic ratio and coronal angle in chest X-ray, and presence of pericardial effusion were associated with event groups. So limitation of the study was single central study, and this was non-blinded study, and selection and referral bias could not be ruled out. And control group was assumed to have normal myocardium. Thank you.
The control group had MRI, they were referred for cardiac disease?
Yes, sir. They were either referred for some arrhythmia, suspected arrhythmia, like AVNRT, or suspected ASD, small ASD that was not noted in echocardiography. Those patients underwent MRI, and that was reported normal. Those patients we have taken for
So they didn't have any hemodynamically significant?
No, there was no heart failure, sir.
This, so you, from your study, the fibrosis is the most important thing?
Yes, sir, yes.
And how do you explain the GLS and all, which is not correlating with your events and mortality?
Yes, sir. And in the event group, sir, the T1 actually estimates the subclinical fibrosis, myocardial edema. That is not very evident. In the later part of the disease progression, the GLS will manifest. So before GLS, T1 value actually expresses by T1 value.
Your conclusion is that GLS will be just will manifest only after
yes, yes,
MRI.
This is very subclinical myocardial fibrosis that is detected, and that has been already proven by one study that with myocardial biopsy, that subtle amount of fibrosis can be is correlating with the T1 value of the patients.
What is the minimum and maximum percentage of LGE in your study?
Pardon me, sir?
What is the minimum and maximum percentage of gadolinium enhancement in your study?
Yes, sir. LG myocardial involvement was all patients had less than 5% myocardial involvement.
Okay.
And subepicardial myocardial fibrosis was not detected by LG. All were 50% were mid myocardial and 50% were subendocardial enhancement, and all were less than 5% only.
And what is the cutoff mark for you to say that beyond this LGE there is a higher risk of bad outcome?
Sir, it was 1050, sir. 1050 T1 value, relaxation time.
In percentage, what would it be? In percentage of myocardium, fibrosis in the in percentage related to the myocardial thickness?
It is detecting the diffuse myocardial fibrosis, not a particular area of fibrosis. Diffuse myocardial fibrosis is depicted by T1 values, sir.
LG is basically heterogeneous, so you said that. But what is the calculated threshold for your T1 thing? This
1050, sir, for our study, sir.
I mean, do you think, do you will, based on whatever information you have given, do you want every patient with HFpEF to undergo an MRI?
The evidence is not still now in evolving area, sir. So we can't recommend as of now, but larger studies are needed to, because I have shown that there is no difference in echocardiographic parameter, including GLS. There is no difference in event and non-event groups. So further parameters are needed to stratify those risk factors. So probably in future, myocardial T1 mapping might be needed to risk stratify patients of HFpEF.
One correction to whatever you said the SGLT2 is a class 1 indication in HFpEF. No, it's class 2A.
2A, sir. It's class 2A, sir. Pardon me, sir.
Thank you. We will have Dr. Anoop KR, aortic valve stress and GLS in bicuspid aortic valve.
Comparison of aortic valve stress and strain assessment in patients with bicuspid aortic valve and trileaflet aortic valve by an echocardiographic study. It is unclear whether ascending aortic dilatation in patients with bicuspid aortic valve is caused by abnormal hemodynamics or by a common developmental defect of the aortic valve and aortic valve. We compared the aortic valve stress and strain parameters among patients with bicuspid and trileaflet aortic valve, and we assessed the aortic valve stress and strain parameters in bicuspid aortic valve group based on normal, mild, moderate, and severe aortic stenosis. Patients with bicuspid aortic valve was diagnosed by ECG-gated cardiac CT findings, such as the valve morphology, root dimensions are measured, and the patients with bicuspid aortic valve is in turn divided based on the severity of aortic stenosis. The other group consisted of tricuspid aortic valve. Echo details are measured, such as assessment of severity of AX using Vmax, mean gradient, and aortic valve area. 2D echo images are recorded. TDI pulse wave Doppler and 2D speckle tracking imaging was done. A total of 70 patients are included. A cross-sectional study, observational over 1 year, with equal age and sex distributions around, and aortic dimensions are measured, which was higher in the bicuspid aortic valve, 43 plus or minus 0.4 millimeters. Study excluded patients with root dimensions more than 45 millimeters. This is because the aim of our study was to generate a set of values and variables which can predict the risk for root dilatation or dissection in the future. Hence, we excluded root dimensions more than 45 millimeters. Also, the aortic root dimensions more than 45 millimeters means that distensibility is less and stiffness index and elastic modulus are more, which can affect our study parameters. The age distributions are around 61 to 65 years of age. Anterolateral aorta and posteromedial aorta stress values are recorded in bicuspid aortic valve patients which are statistically significant and higher. Stress parameters are measured in the parasternal long axis view, 3 centimeters on the sinotubular junction, in the anterolateral and the posteromedial wall of the aorta by TDA pulse wave Doppler recording, and the highest systolic velocity was recorded. Posteromedial wall stress also showed significant variations in subgroup analysis according to varying aortic stenosis severity, where normal or mild versus severe aortic stenosis showed significant p-values. Aortic distensibility, stiffness index, and elastic modulus were similar in both the groups. This was in keeping with the study population, which was root dimensions less than 45 millimeters. Strain parameters are measured in the plaques view of the aorta. Here we did the 2D, 2-chamber LV strain curve, which was utilized for this purpose and adjusted according to the thickness of the aortic wall, and the apical area was excluded for analysis, and we got a set of strain curves. From the strain parameters, the anterior and posterior sinus strain values were significantly increased in bicuspid aortic valve patients compared to that of trileaflet aortic valve. Furthermore, subgroup analysis of posterior sinus strain values showed statistical significance in that normal or mild versus severe aortic stenosis showed significant p-values. Study showed that longitudinal displacement in the anterior and posterior aortic sinuses and the anterior ascending aorta in bicuspid aortic valve patients was statistically significant. Transverse displacement showed the posterior wall transverse displacement and aortic anterior sinus transverse displacement was statistically significant. Study showed that 4 regions of proximal aorta moved differently, and the largest longitudinal and transverse displacement was noted in the anterior aortic sinuses. So we assume that the ascending aorta at the beginning of the dilatation process, up to 45 millimeters, compensates for the stretching during systole, and the biomechanical 2D speckle tracking findings were correlating with the displacement parameters, which was higher in the bicuspid group compared to that of the controls. ROC curve analysis was done to predict the set of parameters predict the bicuspid aortic valve. And based on the ROC curve analysis of the area under curve, the anterolateral aorta pulse wave Doppler, posterior ascending aorta longitudinal velocity, posterior sinus longitudinal velocity, and aortic anterior sinus longitudinal strain percentage found to have significant area under curve. Further analysis revealed that the anterior lateral aorta pulse wave Doppler more than 8.9 centimeter per second, anterior sinus longitudinal strain percentage more than 10.4, aortic posterior sinus longitudinal velocity less than 6.7 centimeters per second found to a statistical significance with high sensitivity and predictive values. And the study thus generated a set of values which can predict the risk for the root dilatation, aortic root dilatation and aortic dissection in future in these patients even before it has happened. In the present study, it was found that the longitudinal strain, longitudinal and transverse displacement in aortic wall and sinuses in bicuspid aortic wall disease patients, that is right-left coronary cuspal fusion, was statistically significant. Strain imaging of the aorta has demonstrated heterogeneous systolic strain distributions in all aortic segments in bicuspid aortic wall disease group. The study showed that stress parameters are significantly increased in the anterolateral and the posteromedial wall of the aorta in bicuspid aortic wall patients. It is already known that the bicuspid aortic valve is associated with a heritable aortopathy component. However, the hemodynamic part is still under investigation, and our study found that the posteromedial wall stress and posterior sinus strain percentage varied according to the severity of aortic stenosis. Thus, the hemodynamic component of aortopathy is proven in the study. Now, the importance of the study lies in the fact that the patients who are posted for aortic valve replacement, there is a risk for root dilatation and aortic dissection in the future. So the study detects a set of parameters, a set of values which can predict the root dilatation in the future, and these patients can be posted for composite valve graft, the valve grafts, or these patients can also be posted for root replacement. So the previous study which was conducted was based on 4D cardiac magnetic resonance. They assessed the eccentricity of the flow jet which impinged on the right anterior wall of the aorta and caused wall shear stress. However, that is a more capitally intensive study. Our study is more of a bedside echocardiographic measure which can detect the root dilatation in future. Also, the eccentricity, the flow eccentricity of the aortic root jet cannot be assessed in echocardiographic method. That is a limitation of the study. However, the patients need to be followed up for longer period regarding the risk for root dilatation in the future also. That is also a limitation of the study. Thank you.
Yeah, interesting study. But were there any methodological issues in finding out what is a normal aortic valve strains? What is a normal aortic valve strain?
Aortic, we did aortic wall strain.
Yeah,
this is not a standardized method like the previous study, which was we have taken the LV strain curve for the.
No, I'm asking you, what is a normal aortic wall strain? Normal value.
Normal value, actually, not much studies are done in this regard. The one study they have predicted 9 to 15%, but that is just a prediction. The ascending aortic wall strain, there is no standardized value available.
So if there are no normal values, then you will have a methodological issue, isn't it? And have you sort of standardized it with the blood pressure, because depending upon the blood pressure, the strain values will change.
Yes, sir.
And have you standardized along with both male, female? Females are different significantly with BMI. So have you standardized with these?
Sir, actually, what we have done is that we have excluded the patients with hypertension. We have only taken the patients with normal blood pressure because of two reasons. One is that hypertension increases the aortic wall stiffness and reduces the strain parameters in return. So we have excluded them. Otherwise, what could have been done is the logistical regression analysis where we include the hypertension, BMI, and various other parameters. But that part we have not done. So,
and here have you compared, you said compared with aortic stenosis patients. That's not
Yes.
seen in your data.
yes, I
So-
have projected the data regarding the mild, moderate, severe aortic stenosis.
So were they different between the
Yes, sir.
strains in patients with bicuspid aortic valve without any aortic stenosis versus severe aortic stenosis?
Yes, sir. Yes, sir.
They were different.
Yes, sir. I have put the data. That is normal versus severe aortic stenosis. There was significance, but there was no difference between moderate versus normal or moderate versus severe aortic stenosis.
The thing is, we don't agree with you on your last part of your conclusion, saying that patients who go to surgery, depending upon the strain, that you're going to advise composite grafts. You cannot
Yes, sir.
make such drastic recommendations when
Yes, sir.
you do not even methodological errors are there. Okay.
Yes, sir. This study needs more follow-up and risk for dilatation in the future, where we can assess the.
The strain calculation is as you do for ventricle.
Yes, sir.
Is it validated?
It is not a well-standardized procedure because the LV is more of a myocardium. This is more of an elastic tissue elongation from the sinotubular junction up to the origin of the brachiocephalic. So this is not fully standardized.
Okay, as also the bicuspid valve, the fusion will determine the direction of the jet.
Yes, sir. Yes, sir.
You have not evaluated.
Yes, sir, we have. Because we have only included patients with the right and left coronary cuspal fusions. We have excluded patients with right non-coronary and the other variety because the eccentricity of the jet was more, in one of the previous study, was more pronounced in right-left coronary cuspal fusion patients. And this was also the majority of the patient population, around 80% is around right and left coronary cuspal fusion patients. The only thing is that the eccentricity of the jet cannot be determined by echocardiography. It can only be done by a flow-directed cardiac magnetic resonance.
Do you think that you should have included a normal group also as control?
Yes, we included a normal trileaflet group as a control, and we compared it with bicuspid aortic valve patients. Among the bicuspid aortic valve, we took a subgroup based on severity of aortic stenosis. We have done a normal versus bicuspid comparison. In that, it was found that stress and strain parameters were significantly increased in bicuspid compared to normal.
Your normal, was it the patients with aortic stenosis or without aortic stenosis?
Without aortic stenosis, normal valve.
Do you think that there can be a age effect also on aortic wall stress? Age and aortic wall stress?
Yes, sir. Because age increases the aortic root stiffness and atherosclerosis also contributes to it. There is a previous study on this matter. So our patient population is around 61 to 65 years of age group. We didn't take 2 elderly patients where the atherosclerosis has got an effect on the aortic root stiffness.
As a corollary to what Professor Ajit said, I have some, again, your methodological issues.
Yes.
When you talk about aortic distensibility and aortopathy, here is something which we will be able to predict for an aortic dissection or aortic aneurysm. I don't think this is very important. We have better markers to assess the aortic severity of aortic stenosis. You have even, did you compare a 3D echo with this?
No, we didn't do a 3D echo. We did only a strain and stress assessment based on 2D echo.
So I'm not very much convinced about the importance of it in the assessment of aortic stenosis. We always talk about aortopathy in terms of predicting the aneurysm formation or an aortic dissection, which you have not mentioned at all.
Our study is an attempt to predict the aortopathy in the future based on the wall strain and stress assessment. Strain is more of a reliable method because it doesn't have the limitations associated with stress assessment. Stress assessment is more limitation oriented. That is, there is a tethering motion, the translational motion, and all those things are limitations in stress assessment. But strain assessment is more comparable, more better tool. For,
Thank you. Thank you very
assessment.
much. We'll have the last presentation by Simna, correlation between GLS and syntax score in chronic CCS.
Good morning, chairpersons and my dear friends. Thank you for allowing me to present the study. Correlation between global longitudinal strain and syntax score in patients with chronic coronary syndrome. In patients with chronic coronary syndrome, left ventricular ejection fraction assessment using traditional echocardiography may remain within normal range. Using an alternative resting module for diagnosing and predicting coronary artery disease severity would be beneficial. Myocardial strain is a precise tool for evaluation of early subclinical systolic dysfunction in a number of cardiac pathologies. So the objective of the study, the primary objective, was to determine the correlation between global longitudinal strain and syntax score in patients with CCS. The secondary objectives were to determine a cutoff value for GLS for predicting high syntax score and also to determine the sensitivity and specificity of GLS for prediction of severity of CAD among these subjects. This was a hospital-based observational single-center study which happened at the Department of Cardiology, Medical College Trivandrum. The study duration was 1 year. Subjects aged 18 to 80 years with symptoms suggestive of CCS who were referred by primary or secondary care physicians to the cardiology department were included. And patients with suspected CCS who had exertional angina or dyspnea who gave informed consent to be part of the study were included. And the major exclusion criteria were patients with acute myocardial infarction or high-risk unstable angina, a history of previous myocardial infarction or previous recent coronary revascularization, then patients who had resting regional or global wall motion abnormalities in the echo, Then patients with structural heart disease, example significant left LVH, or patient with more than mild valvular lesions, then suboptimal echogenic window, and with persistent arrhythmia or frequent extrasystoles. These patients were excluded. Now, so 124 patients underwent both echocardiogram and coronary angiography within 15 days, that is over a period of 1 year. All patients had normal global and regional ball motion on resting echocardiogram. GLS was calculated using 2D speckle tracking echo. We used a Philips EPIC 7 machine. Then syntax score was calculated for each group of patients based on the presence and the severity of coronary artery disease. So they were classified as no CAD on angiogram, then low syntax score, which is less than 22, intermediate syntax score 22 to 32, and high syntax score, that is more than 32. The results were analyzed by using an SPSS 20 software. Now these were the baseline characteristics. The majority patients were males, almost 63%. The highest risk factor was diabetes followed by hypertension. There were not much difference in the baseline characteristics except the LV ejection fraction, which is reduced in the high syntax score group. The p-value was less than 0.001. Then this is the baseline values. The GLS was mean was 18 plus or minus 1.5, and the syntax score was 16.9 plus or minus 11.2. Now this is the comparison between GLS and the syntax score. You can see that there is a definite reduction in the GLS, mainly in the high syntax score, significant p-value, and then LV ejection fraction, like I mentioned earlier, was also reduced. Now, next we did Pearson correlation, and we checked the correlation between GLS and syntax score, and we can see that the R value is minus 0.78. There is significant inverse correlation. Then we decided to do the correlation between each category of syntax score. In the low syntax score group, again, the R value is minus 0.67. That is, there was significant inverse correlation. But as we moved up, in the intermediate syntax score, that is between 22 to 32, the R value was only minus 0.8. So there was poor correlation. In the high syntax score, it was even lesser. The R value was only minus 0.12. That there was almost no correlation. Now, we did, we used the ROC curve to find out a cutoff for predicting higher syntax score, that is more than 22, and the value which we got was 17.5 with sensitivity of 78.3% and specificity of 77.6%. We also tried to find a cutoff for obstructive CAD, that is syntax 0 and more than 0. So syntax 0 had the normal coronary patient and also patient with non-obstructive coronaries. They were compared with syntax score more than 0, and the cutoff which we got was 18.6 with a sensitivity of 78.5% and specificity of 98%. So the limitations of the study, it is that it is a single center study, and the hemodynamic parameters, LV mass, technical factors, they're all factors that can influence the strain and the strain rate. Because of these various factors, they could be considered as possible confounding variables in the analysis. Next thing is the myocardial fibrosis, which could explain reduced strain values in some of the patients was not ruled out. We also did not do a functional evaluation of the coronary lesions. Then conclusion, even if the left LV wall motion appears normal at rest, it does not necessarily rule out the presence of significant coronary artery disease. Then our findings suggest that there is a negative association between resting GLS and the syntax score. GLS could be a useful tool for identifying patients with high syntax score on coronary angiogram. And by utilizing the identified cutoff values for GLS, it is possible to identify patients who have most severe CID and may benefit from early invasive coronary angiography. It's especially relevant in our hospital where we have a 6 months waiting list for coronary angiograms. So by doing this GLS, we can identify who are more at risk, and they can be posted for early angiography and revascularization. Thank you, sir.
A good one. So, which syntax score did you utilize?
Yes, sir.
Which syntax score did you utilize, and why did you not utilize the other syntax scores?
So we only did the anatomy of syntax score 1, sir, was utilized.
Why? I mean, what was the reason?
It's more easier. The rest of the
more easier.
Yes, it's more easier, and since this was a patient.
What was your hypothesis? Did you imply behind doing the study? What was it?
The hypothesis is that patients with higher syntax score will have a reduced GLS at rest. Yeah.
No, but in which way? Is it going to affect the LV systolic function or diastolic function and then thereby affect the GLS?
I think it is. This is mainly subclinical systolic functions, systolic dysfunction mainly.
Now, did you compare with ejection fraction, BNP, treadmill testing?
So
Did you do
BNP
this?
was not done, sir. BNP was not done. But
Treadmill testing.
Yes, sir.
Treadmill, TMT.
Pro-
Treadmill, TMT.
Yes, yes. So out of this 124 patients, 82 patients were TMT positive, and 26 patients TMT inconclusive, and the rest of the patients, almost 16 patients, could not do TMT because of their other factors, mechanical issues, knee issues, and all that.
GLS is influenced by so many factors.
Yes,
so
sir.
how do you assess this to assess a resting myocardial perfusion?
Again, sir, that is a limitation of the study. The hemodynamic variables, those things were not really taken into account. And the medication part also were not. Patients were on multiple drugs, and those, like especially ACARBs, those things can also influence GLS, but those were not taken into the initial
Because
evaluation.
these
So-
patients have so much comorbidities and myocardial hypertrophy is very common.
Yes.
So is it practically useful to do GLS to assess perfusion? Because myocardial hypertrophy, other are
Yeah.
very common in other
Yeah, those
responders.
patients were excluded, sir, the cardiomyopathy.
So you have a high amount of
Yes.
exclusion.
Yes.
Your average syntax score was very low. So what is the reason? Because it is only 16.
Yes, sir.
That's extremely low.
Yeah. So we had more of the low syntax score. Almost 71 patients had a low syntax score.
there
Only
a-
13 belonged to the high syntax score, more than 32.
And did the syntax scoring was done by somebody who
So it
did
was-
not know GLS?
Yeah. Same person. That's me, sir.
Both GLS and syntax scoring was done by the
Done
same
by the
person.
same person, me.
Do you think that it would have been better
Yeah, yeah.
if syntax
Yes.
scoring was done by a
Yeah.
different person?
Yes, it would have been better.
You did not estimate the GLS less than 17, I gather from the information, because the best specificity and sensitivity of GLS is supposed to be around 16.5. Why did you not calculate less than 17?
Sensitive, yes, sir?
Why do you know? Because 17, if you take 17, the sensitivity becomes much lesser.
Yeah.
The best sensitivity and the specificity is reported to be around 16.5.
Okay.
You did not calculate
I didn't go
anything
there.
less than 17.
17, yeah, yes.
So I think we should, when we estimate GLS, try to go for the best specificity and the sensitivity one.
Okay, sir.
And another observation is your correlation with diabetes, smoking. This is again something which is surprising, because all the data has shown there is a positive correlation of both with the syntax and the syntax.
Yes, sir.
Thank you.
Okay. Thank you, sir.
Thank you.
Thank you.
We will be naming the winners, and the award will be given during the inaugural ceremony. Give us.
Thank you very much, sir. Please kindly note that the prelims will be at 12 noon. The timing has been changed from 11 a.m. to 12 noon. Thank you. We have the inaugural session next. Ladies and gentlemen, we have the inaugural session next. May I request you all to kindly get your coffee cups and be seated for the inaugural session, please. We begin with the inaugural session now. It is my privilege to invite onto the dais Dr. Prabhanini Gupta, President CSI, Dr. D.S. Chadha, Commander, our guest speaker, and our guest for today, Dr. Jay Gopal. May I request you, sir, to kindly accompany our guest speaker onto the dais. Dr. Jay Gopal, Vice President, Scientific Committee Chairman of the Summer Conference CSI 2023. Dr. Stigi Joseph, Secretary CSI. Dr. Deepak Davidson, Organizing Chairman, Summer Conference CSI 2023. Dr. Jittu Samarajan, Organizing Secretary, Summer Conference CSI 2023. And Dr. James Thomas, Treasurer CSI. May I please invite Dr. Deepak Davidson now, our Organizing Chairman, to deliver the welcome address, please.
Good morning to all of you. It's indeed my pleasant privilege to welcome you all during this summer conference of CSI State Chapter. Well, I would want to mention three names. Prabha ma'am for the tremendous support she has given to the organizing team during this last 3-4 months. Then Dr. Jay Gopal for the power-packed academic sessions, and Dr. Jittu. Dr. Jittu, he'd been having sleepless nights over the last 6 months and paid off. We had a wonderful conference in a wonderful venue like this, and we had a lot of youngsters presenting cases as well as the talks yesterday. And now let me take this opportunity to welcome you all. To start off, let me welcome President Prabha ma'am, Vice President Jay Gopal sir, Dr. Stigi, the Secretary, Dr. Jittu, the Organizing Secretary, Dr. James, all the senior professors who has come over here to be with us, all our friends, colleagues, and last but not the least, Dr. Chadha sir, who is presently the heartthrob of Bangalore CSI, the most favorite interventional cardiologist over there in Karnataka. So thank you for being with us. We look forward to listen to your presentation. I sincerely pray and hope that the rest of the sessions also turns to be fruitful for all of us. Thank you so much.
Thank you very much, sir. We'll have the lighting of the lamp, the official inauguration. May I request our President, Dr. Prabha ma'am, and also our Chief Guest, Dr. D.S. Chadha, to kindly do the honors. May I request all the dignitaries on the dais to kindly join them. The inauguration of the Summer Conference of the CSI.
teachers, dear colleagues, and my beloved students. Actually, we have had a very fruitful conference and we are continuing to have it. Kerala is actually having two major problems right now. One is that the young population is still continuing to smoke, and we have a new problem that there's a lot of drug addiction, and the persons affected are mostly young women and girls. In fact, the arrests in the last 3 years have mostly been women between the age of 18 years and 30 years. So that is a very big problem. All cardiologists should counsel anyone they meet about these two problems. Now, but we, on the other side, we have a very good thing. We have a large elderly population. I have recently moved to a private hospital, Sri Ramakrishna Mission Hospital. There I see many 90-year-old patients who are in very good health, and I'm happy to say many of them have had coronary stenting 10 years back. So I'm sure our cardiologists in the state who are very active, even juniors, seniors, everyone, are very active in stenting these elderly patients and prolonging their life. And I hope that this shows that no cardiologist will unnecessarily use a stent. I hope. And with these words, I'd like to say that our conference is extremely useful for these problems, because in our conference we are talking about new life-saving drugs. One or two of them even I had not heard of, even though I read a lot. Then we are talking about techniques to deal with calcium and abnormal coronary arteries. Now, the information obtained from these talks will help the cardiologist who's alone in a center at night make decisions. So this is a very important conference, and I'm happy to say that our guest lecturer is an interventional cardiologist who will enhance our learning tremendously. Thank you.
Thank you very much, ma'am. May I please invite Dr. Jayagopal now to offer his felicitations on the occasion, the Vice President of CSI.
Chief guest of the day, Professor Chadha, our President, Secretary, the Organizing Chairman, Dr. Deepak, Dr. Jithu, my senior teachers and dear friends. It's indeed an honor to be part of this scientific program. As a scientific committee chair, this year, what I really wanted to do was involve as many youngsters as possible. And in fact, if you go into the last few years, what we have been seeing is a little lesser involvement of the younger generation post-DM. So I wanted to make sure that all the younger people get an opportunity. And so that was one of the reasons. So I know some of my friends were complaining that it was a really jam-packed sort of a scientific program. But the idea was, the two terminologies today is being inclusive and equity. These are the two things. So I think with that in mind, I wanted to involve as many youngsters as possible. And I'm happy to tell you that there's not been a single dropout as far as the speakers were concerned in this particular meeting. So thanks to all the speakers and my friends, colleagues, teachers, in fact, so many of our senior faculty from the medical college and also from senior people have taken the trouble to come all the way to guide the youngsters, and we had a very fruitful session, and I'm glad to inform you that this time the registration has touched 160, which perhaps is one of the largest that we have had in recent years. So also the idea was to promote the youngsters, the postgraduate students really, and I'm fairly clear that these meetings are probably mostly useful to the postgraduate than anyone else. And so there was an overwhelming response this year. We had about 28 papers which was given, and I made sure that everything was accommodated. We had about 14 presentations, and the award session was given the prime slot between 10 a.m. and 11 a.m. and we just witnessed what was happening in the award session. And there were the remaining, actually, for the first time we introduced this poster session, and we also had an award for the best poster present as well. So I think, we have had a fairly decent crowd, and I'm sure most of you who have come here would have enjoyed this, and if there are any shortcomings in terms of the scientific program, or let's say on behalf of the organizing team also, I think I take up all the responsibility and wish you all good times ahead. Thank you.
Thank you very much, sir. May I now invite Dr. Stigi Joseph, Secretary CSI, to offer felicitations on the occasion.
Respected President Dr. Nini Gupta, guest speaker Dr. D.S. Chadha, respected teachers and dear colleagues. First of all, let me give the appreciation and thanks to the organizing team and scientific committee for such a wonderful conference. We have some leftover work from the last GBM because one of the agenda was appreciation of the CSAK members for the last who have significant achievements over the last 6 months. We have 8 persons who should be appreciated and recognized, starting from Ramakrishna Pilla sir, who was awarded the Lifetime Achievement Award by the King's Hospital. In the absence of sir, we will send the memento to sir by courier. Second is George Tayil sir, for the great achievement of being selected for the UCMA Literary Award for his autobiography. I invite sir to the stage to be appreciated by Madam President.
Ladies and gentlemen, a round of applause, please. Congratulations, sir.
Third is Tiny Nair sir, again for the literary work, the great achievement for being selected as the World Book Day Poetry winner for his poem. In his absence also, we will give the memento by courier. Fourth is Dr. Ronnie Matthew Kadavil for the great achievement for being selected as the Director of India Life from Kerala. Again, sir is absent. Fifth is Dr. Bijimon PR for being awarded for the Best Super Specialty Doctor 2022 from KGMOA. Dr. Bijimon is here. All the award winners are not here. Again, Dr. Joe Joseph for the great achievement for being selected as the official Indian team doctor for the World Transplant Games held at Perth, Australia. Now we have one of our associate member who has great academic achievement, is none other than Dr. Narayanan Nambudiri from Sri Chitra, who has been an author of 2 international guidelines. One is 2022 Heart Rhythm Society APHRS Expert Consensus Statement, and second is the European Heart Rhythm Association Consensus Statement on the Management of Clustered Ventricular Arrhythmias and Electrical Storm. And he is also the editorial board member of the PACE Journal. Now it is our turn to repay our gratitude to one of our senior members. We all know for the last few months or for 1 year, there was a controversy regarding the building construction at Arur in Kochi. Though there were no personal allegations against our senior member, the one who was most insulted and hurt was none other than our senior member, Dr. K.A. Chako. Now it is our turn to show gratitude to his service as building committee chairman. I always wondered how somebody can remain so cool and graceful during these turbulent days. Yesterday only I understood the reason. It is his pedigree. He is the only son of the most respected as the honest and ethical politician who was the former governor of Andhra Pradesh, Sri K.C. Abraham Master. Probably the elders might know much more than me. I invite Dr. K. Chako to the stage to be honored by our Madam President on behalf of entire CSI Kerala chapter. Thank you once again. Congratulations to the entire team for the wonderful conference. Thank you.
Thank you very much, sir. It's now the turn of Dr. Jitu Samrajan to propose the vote of thanks. May I welcome you, sir, the organizing secretary of this conference.
Honorable President, CSI Kerala Chapter, Dr. Prabha Nini Gupta, Vice President and Scientific Committee Chairperson, Dr. Jayagopal PV, Secretary, CSI Kerala, Dr. Stiji Joseph, Organizing Secretary, Dr. Deepak Davidson, Guest Speaker, Dr. D.S. Chata, Senior members, teachers and dear friends, I feel honored and privileged to be part of the organizing team of the summer conference of the CSI Kerala Chapter and also to propose the vote of thanks in this solemn function. First of all, on behalf of the organizing committee, I convey our deep regards and gratitude to our Honorable President, Dr. Prabha Nini Gupta, Madam. I thank you for all the support you have provided me since very early in the preparation of this conference. Along with Madam, I would like to thank Dr. C.G. Joseph, sir, for entrusting me with this task and being a constant help and guide during the planning of this conference. An event of this dimension cannot happen overnight. The wheels start rolling months in advance. I was especially lucky and fortunate to have two eminent personalities in the organizing committee. I thank Dr. Jayagopal sir for having prepared such an outstanding scientific session, which has included all aspects of cardiology. Sir was a call away any time and showed great interest in involving more young cardiologists and students in this scientific program. I also thank Dr. Deepak Davidson sir, the organizing chairman of this conference. Sir was there with me at every step of the organizing, taking time from his busy schedule. Because of his contacts both in industry and the community, he contributed most to the happening of this conference. I'm indebted to sir for the long, late hours of phone discussions and planning, always guiding, supporting, and helping me all the way. Next, I express my sincere thanks to the treasurer, Dr. James Thomas, sir, for various help we received towards this conference, although in his absence. A special thanks to Dr. Davinder Singh Chadda for accepting our invitation to be the guest speaker and his willingness to spare his valuable time. We will ever remain grateful to you and we thank you for being with us today, sir. I thank Dr. Shivashankaran, sir, for agreeing to give the annual oration in the summer conference. We look forward to being inspired by your talk, sir. At this juncture, I would also like to thank all the office bearers and the executive committee members who have always supported us and also gave permission to conduct a postgraduate training session last Friday. I thank all the cardiologists at Kottayam who labored along with Deepak sir and me as a team to make this conference happen and to especially coordinate the PG track. We express our sincere gratitude to all the faculty, associate faculty and delegates who are attending this conference. We had an overwhelming response to interventional cases, research paper and e-posters, call requests. We had very limited cancellations and all sessions till now could be done on time because of all your cooperation. We thank all the teaching faculty who equipped and allowed the postgraduate students to join us here as well. Next, I would like to thank our audiovisual team headed by Dr. Arun Moses for doing the job entrusted to them in the most flawless and perfect way. I thank our PR team Drumbeats headed by Mrs. Smita Menon who helped us to get coverage in various print and online media. I thank the travel agency Lay Race headed by Mr. Jibu for perfectly arranging and coordinating the travel. I thank our MC, Mrs. Thangam Ramakrishnan, for comparing the event. I like to thank the photographer, Mr. Balan, and Mr. Swami for all this and all the support staff for helping us out with registration. I like to thank Mr. Asif, our graphic designer, and Mr. Sandeep, the event management head, I thank the staff of both the resorts, Suri and Lake Song, for helping us for a present stay at Kumaragam. I now express my sincere gratitude to all the pharma and device industry personnel who generously sponsored and helped us to arrange such a conference. Last but not the least, I would like to thank Mr. Anish Lawrence, the executive in charge of the CSA Kerala chapter. He was the call-to person for anything at any time. All this was possible because of his hard work. His dedication is evidenced by his presence here today, even with an injured leg. Thank you so much from the bottom of my heart. I request you all to forgive me if I have missed out on anyone, and I plead that it was not intentional. Thanking you once again. Thank you.
Thank you, sir. We now,
As usual, I always forget when I give my speech. So as usual, I'm thanking Deepak Davidson and Jiddu for their wonderful organization and all my team members for making it a grand success. And I thank Dr. Chadda for coming. I always forget to thank everyone and I might have missed out some people. I also thank the pharma and the faculty and all the delegates who have come. Thank you.
thank you, ma'am. Thank you very much. We come to the end of the inaugural session now. It's time for our guest lecture. Ladies and gentlemen, once again, may I request you all to kindly grab your coffee or tea and please be seated. A most honorable occasion for all of us. May I please invite the esteemed chairpersons for our guest lecture. Dr. George Koshi, Dr. Bahuleyan, Dr. Jayagopal, and Dr. Prabhanini Gupta, please, to kindly chair the session. We are much honored, sir, by the presence of our guest lecturer, Dr. D.S. Chadda. Ladies and gentlemen, please put your phones on silent or on vibratory mode. Thank you. Over to our chairpersons now.
Shall I introduce, sir? It is in, dear senior members and friends, it's indeed my great pleasure to invite Dr. Chadda to be come out of the dais to give his presentation. So it's customary that the guest lecturer be introduced. But I'm sure all of you sitting here are aware of Dr. Chadda's achievements. He is currently the head of cath lab at Manipal Hospital and a visiting professor at Jayadeva Institute of Cardiology, Bangalore. He had his graduation from AFMC Pune and was the best outgoing student there. Subsequently did his postgraduate training in medicine as well. Again came out with a gold medal there as well. And then finally passed out of All India Institute of Medical Science in 2002 and has been in the service for close to about 30 years, 18 years of work in the services, where his last assignment was as a professor of cardiology and air commodore at Command Hospital, Bangalore. In fact, most of us who know about Dr. Chadda is about his skills, interventional skills. He's done more than 500 root ablation. Has been a pioneer in the field of OCT. If I'm correct, I think the first OCT machine came to the Command Hospital and he's probably had the largest number of OCTs done in the country. And not only that, I think he's also an expert in structural interventions. He has been a proctor in most of the places in southern India, not only in structural intervention, but also in leadless pacemaker, where he has probably done more than 70 cases so far. He has been a friend, a helping guide to almost all the cardiologists in and around Bangalore and southern India, and has a lot of publications to his credit. if I have to continue talking, I think it will take a long time to finish off his credentials. But I would like to say that he is at present one of the senior most respected interventional cardiologists, most sought after interventional cardiologists in Bangalore. He has two children, two sons. One has already finished his MBBS, and the second son is at NUS doing his graduation. With this brief introduction, I present to you Professor Davinder Singh Chanda. Over to you, sir.
Professor Chanda, it's our great honor to have you with us as guest speaker for CSIK this year, 2023. Dr. Chanda is known to many of us as a friend. This is not the first time he is coming to Kerala. He had been a regular faculty, a speaker to Society for Coronary Imaging and Physiology ever since it has started in 2015 onwards. And is deeply interested in the frontier of intervention, that is use of imaging and functional assessment of modern PCI. So we look forward to hear his lecture today. Thank you once again, Chanda, for taking the pains to come over here. Chanda, please.
Thank you, sir. Thank you, one and all. Thank you, organizers. It's indeed an honor to be here. If you permit, I would call it CCSI. It's the most cerebral cardiology society of India. I think all the great minds are here. I haven't seen such an academic platform and such an accomplished crowd. It is indeed my pleasure to be here, and I thank the organizers, one and all, who have invited me here. So without much ado, I'll go on to my talk, which is intracoronary imaging, what is in the pipeline. We all fear stent failure, and the next question which is asked is, does imaging help? So this slide kind of shows you from the bioscience study, the average stent failure rate at the end of 5 years is about 18 to 19%. Can we improve upon it by adding imaging? Well, a 3-year follow-up of the ultimate registry where IVUS was used shows that yes, if you add imaging, it does make a difference and your stent failure rates come down. Does OCT also fall in this category? The opinion study showed that OCT is kind of equivalent to IVUS, but this was a very brief follow-up of 1 year. About a month and a half back, we had a paper come out from Korea, which used both OCT and IVUS to see if it makes a difference. And what did this study show us? At a median follow-up about 2 years, this noticed that it does bring about deaths from cardiac causes, target vessel failure, and target vessel related MI. So what I'm trying to tell you is that addition of OCT or IVUS in your practice leads to better clinical outcomes. Now these are the timelines. IVUS was the first one to come out, and the first IVUS was used in the year of 1988, and in about 2006, ACC gave it a class 2A approval. Well, after that, there have been some clinical outcome data which is there with IVUS, and we have some landmark papers which have been showing that if you add IVUS, things are better. OCT came a little late in the practice. The first in man was only in around 2008, but thereafter it has kind of marched ahead, marched in terms of adoption as a therapy in our clinical practice. There have been some trials which have shown equivalence, and now we have, as I mentioned, the opinion trial and the Renovate PCI, which are the clinical outcome trials, and these trials have shown that yes, it makes a difference in terms of clinical outcomes. Now, very often we end up comparing these two modalities on a head-to-head basis, saying that which one is better and which one should select. So if you see the comparison, this slide briefly gives you a comparison between OCT and IVUS. One is a light-based, the other is a sound-based. OCT requires clearance of the blood column because it uses very small wavelength of light which interferes, wherein the RBCs interfere in the image acquisition. So you have to flush out the RBCs. OCT has a much greater speed and a higher resolution compared to IVUS, whereas IVUS gives you the depth. So if I have to summarize, what I'm saying is that OCT offers 10 times higher resolution and is about 20 to 30 or 40 times faster acquisition. There's a lot of automation in OCT. It gives you a lot of surface details. And in the phantom models, they notice that the sizing is much more accurate with OCT than with IVUS. Well, imaging is always used pre and post, and how these two modalities compare with each other. If you see that IVUS has the virtue of greater depth, so it can show you the EL much better, which is used for sizing. It does not give you the kind of surface details which you need in the post PCI imaging. So there OCT scores over the IVUS. It shows you much greater quantity of close-up structures. That means dissections, plug prolapse, or your under expansion or malapposition. These are much better appreciated with OCT compared to IVUS. Now, what are the situations where I prefer IVUS? You know, there are certain clinical situations, like if you have LV dysfunction, renal failure, patients with large vessels or left mains, if you're doing aortoosteal, in amongst the lesion subsets, aortoosteal disease. Here is a case example where the left main ostium was diseased. And in these situations, IVUS is preferred because it not only shows you the plaque burden, it gives you the dimensions, it also tells you whether your stent is optimally covering or not. In the osteal lesions, OCT does not work very well because you are not able to clear the blood column, and hence you will not be able to see whether you optimize the stent well or not. Well, in CTO, IVUS is of great help because it not only identifies the proximal cap, it also tells you the extent and distribution of calcium. You know, calcium is a very important thing in CTO segments wherein you can't get to neither get the feel or get to know whether you're on the true lumen or not. It also picks up the dissections and the side branches. And it makes sure that you are going from true to true and you're not stenting into the false lumen. So here, if you see in this case example, the wire is moving away from the subintimal plane and coming directly into the true lumen. So it kind of identifies these segments. And here again, in yet another example where the IVUS has been put in one of the RV branches, the wire was closer to the intima, to the EL. If the wire is close to the EL or the external layer, it keeps tracking and it does not come back to the true lumen. And then once the guide wire is taken out and reshaped, the wire gets back into the true lumen. So this is how the final result appears. And IVUS is kind of irreplaceable. You cannot use OCT in this segment because you need to clear the blood column. And if you're doing a CTO, you create dissection flaps. And when you create dissection flaps and you inject, that can lead to further propagation of the dissection. What are the situations where we prefer OCT over IVUS? Well, in bifurcation, I told you this is one modality which gives you 3D images. It tells you whether your wires have crossed to the proximal or distal struts because it's very important to know that. It also helps you evaluate the neocarina by giving automated sizes and images of the neocarina. Calcium. OCT is the only modality which gives you the thickness of the calcific plate, whereas IVUS just reflects the waves away from the calcific plate. Post-stent assessment, you can have multiple things happening and OCT is of great help. In bifurcation, as I already mentioned, it measures the MLAs, it tells you plaque burden, it tells you whether you are going to lose the side branch or not, it tells you the wire recross. Couple of images, this is pre-side branch dilatation and post-side branch dilatation. As you can see, the wire has kind of fallen back, the struts are removed, the ostium is absolutely free of metal. And in yet another example, you have struts in the distal LM plasty. The struts are covering the neocarina. Once you've done the dilatation, there are no struts and you have a metal-free neocarina. You can generate these stent-rendered images which tell you whether there is a metal load or not. And if you see the stent-rendered images on the right of your screen, what you notice is that the side branch ostia have been completely cleared off the metal struts. Well, in the follow-up, you can see in detail certain changes which only OCT tell you. You can see neoatherosclerosis happening. It is a lipidic neoantioma. You can see a calcific neoantioma. You can see uncovered stent struts. You can see neoantimal hyperplasia. You can see positive remodeling of the vessel. And you can see a ruptured neoatherosclerotic plaque. So it has got tremendous magnification and it gives you a lot of close-up images. Well, a one case example of a stent failure which summarizes all what you need to see in this LAD run on OCT. You see a distal end of ISR, very thickened intima. You see overlapping stent struts. You see a lipidic neoatherosclerotic plaque. You see calcific neoatherosclerosis, white arrow showing you calcium formation in the neoantioma. And you also see a calcium plate behind the stent. That means the stent was implanted in a calcific bed. And you see a very well endothelized proximal part of the stent. So one run shows you all what you need to see in a neoatherosclerosis. That means there is lipidic and calcific neoantioma, there are calcium within and outside the stent struts, and there are overlapping struts. Well, there are certain limitations with these two modalities. The limitation with the OCT is that the penetration is very poor, so large vessels, it's a problem. You can't assess the plaque burden, you can't assess the ostia of the vessels. Need to clear the blood, so hence you cannot use it in chronic total occlusions. You have to be extremely careful in patients with LV dysfunction and those who've got renal dysfunction. With the IVUS, the pullback speed is low. There is no 3D available with the IVUS. I mean, 3D is available. It's not 3D reconstruct is not as good as that of OCT. It has very low magnification, so close-up details of the stented segment are not available. You cannot assess the thickness of the calcific plate. And one of the most important which I've highlighted is that the learning curve of IVUS is a little long. You need to be a little patient and you need to interpret the images. What if we have a hybrid system which basically takes both the IVUS and OCT together and generates images so that we are able to overcome the limitations of each of these two modalities? Well, the hybrid system is now going to be marketed. It's already in market in Canada and US, and very soon it will be launched by a very good company from Japan. I'll just tell you about this. So what hybrid system does is that it uses a single catheter with two transducer. One is going to work as IVUS, the second is going to work as OCT. And now on this slide, what you see is the strengths of IVUS and OCT. On the blue is the strength of the OCT, which tells you that it can pick up the calcium and the thickness of the calcific plate and all the close-up details, which has been marked as dark blue. And the IVUS, which picks up the lipid pool, it picks up the EL and everything. And you combine these two modalities, you have a fusion image which tells you everything what you need to know. Well, the development of this took quite some time because you had to miniaturize the transducers, you had to have a catheter which would get into the coronary segment. It all started in the larger arteries and then they moved on to the coronary segment. The basic issue was also to arrange the IVUS and the OCT catheters, and the two arrangements which have worked out well is one is a sequential arrangement. That means the IVUS and the OCT catheters have been sequentially arranged, and the other is a co-planar arrangement. That means both of them are in the same line because you need to have a very strict co-registration of both the images so that they are representative of the sample collected from the same spot. Otherwise, it's not going to work. If one catheter looks 1 millimeter or 2 millimeter proximal or distal compared to the other, the job is absolutely not done. So this is what took time. And we have two systems. One is from the Canada, which is called the Conavi Novacyte Hybrid Imaging System. You have a console, as you can see. The console looks like this. You have a device interface. You have the catheter, and this is how the transducer looks like. Now, this device is already Health Canada and US FDA approved, and they have already done some small studies with great results. The images appear like this. On the left is the IVUS, and on the right is the OCT image coming out of this hybrid catheter. The second system comes from Thermo, which is also PMDA approved. This is the device interface, and this is the catheter. Mind you, both the catheter systems are akin to the catheters which we are using in our clinical practice without much difference. And the images from the Thermo are as shown on your screen. The upper image showing an image of thrombus and calcium, a comparator between the IVUS and the OCT images. You have some spectral, and you also have a fusion image coming out of this system. So if you compare head to head both these machines, as I told you, there's not much significant difference between the catheters which we are using now for imaging and the hybrid catheter, which is soon going to be launched in US, and probably in times to come we'll also get it in our country. The usable length is almost similar. The profile, it uses 40 megahertz IVUS system, and there's not much difference in the OCT transducer which is there. Well, the image acquisition is at a similar speed or as with the current systems. The only variable which is different is that the IVUS speed is slightly higher. You will have the capabilities of acquiring IVUS images at the speed of nearly 5 millimeters per second. In the Konavi, you cannot acquire OCT alone, whereas in Thermo, you have the choice of acquiring OCT alone. Well, the advantages of the hybrid system are that it's going to be a complete and accurate assessment. It will overcome all the limitations which are there. As you can see in this slide, you can see the green and red mixed with the IVUS and the OCT, but the hybrid system, which is down below, is all green. So it at pre-PCI level, it looks like this, and at post-PCI level, it again looks like this. So everything turns green. That means all the virtues which you want an imaging catheter to provide you come with a single catheter system, and this will lead to optimal planning and superior procedural results than the standalone imaging catheter. Well, what are the other things which are in the pipeline where IVUS is concerned? We have the IVUS nurse system, which is already in use, and there are multiple trials which have been done. I am told that in a month or two, the same catheter through Nepro will be launched in our country. Now this gives you, in addition to looking at the vessel and giving you the IVUS, it does a spectroscopic analysis and tells you where the lipid pools are located. Now it's very important, as you can see here, in this given case example, RC had a lipid pool which really blocked off the vessel in times to come. There's a lot of work which has been done. Name a few studies, which one of the landmark studies was the Prospect using bioabsorbable platform. So it showed a very good results. That means a combination of IVUS with near infrared spectroscopy is going to be way forward. Now what's happening in the OCT is that we have the evolution of OCT which happened from the time of its launch to the most recent model, which is the Optis Mobile, which is going to come into the country. That Optis Mobile gives you the liberty of angiocore registration in multiple labs. So if there are 4 functional labs in a given hospital, all of them can be co-registered with one single machine. Now, the new software which has been added is the Ultron software. This is AI enabled. What does it do? It tells you the thickness and also the arc of distribution of calcium. It also picks up the EL very well and marks the EL for you. The major advantage of this being that you will have an automatic quantification of calcium, and with the EL identification you will have sizing which will happen much more accurately. Now once you've sized, it will enable you to put the stent in place, and once you put the stent in place, you will have a comparator which will come out. That means you will be able to compare automatically the pre and post images, and it will tell you whether you've done the job well or not. We know that stent expansion is very important, and one needs to expand the stent well, because this is the only predictor of good long-term outcome. Well, the other things which are happening in the field of OCT are that new flushing media are being tested, which are going to be more nephro-friendly. That means there will be no nephrotoxicity, which we'll get to see with this. There is also work on fast acquisition of images. So on the animal studies, they've got a single heartbeat image acquisition. That means in 1 second, the 70 millimeters of the vessel can be interrogated. There is also work on to increase the spatial resolution to as low as 2 microns, so that you'll be able to identify the cells and as well as the extracellular matrix as to what is happening in the vessel. You also have work on to increase the depth of penetration. OCT is also coming clubbed with autofluorescence. Now this helps you identify the site of plaque rupture, and you have near infrared spectroscopy also coming in combination with OCT. Now these are things which are in the pipeline, and they will certainly come at some day to our country as well. Well, physiology is something we all believe in, and integration of imaging and physiology is very, very important, because if majority of the time physiology is not adopted because one feels there is wastage of time. At one stage they were thinking that you will unnecessarily be putting more metal in the vessel, or you will be denied of stenting. Now the advantages of having a single run of imaging which tells you more, gives you more information in terms of physiology, is that you have both the functional and the anatomical assessment happening together. You can derive the MLAs, you have accurate assessment of patients, even those who've had myocardial infarction where pure physiology does not work, and it's more reproducible and saves you time. So it happens with the ultrasound, that means with the IVUS it's called the UFR. You have a 3D reconstruct outlining all the side branches, and you can get a value of FFR. It can happen with the OCT, it's called OFR, it's called optical flow ratio. You get the 3D reconstruct and the vessels. And this is how it looks pre and post. You can get the in-segment stent as well as pre and post values of this thing. To summarize, what I've said is that selection of imaging modality, we have IVUS and OCT, should be based on the clinical setting, the disease segment, the previous angiographic images and the lesion characteristic, and most importantly, the operator's familiarity. You should not ape others. IVUS and OCT complement each other. One shows you surface detail, the other depth, and the future will see further refinement in this direction, and which will make it more user-friendly. To conclude, I would say that good imaging modality is the hinge on which the correct decision making is based, and benefit of imaging is tremendous in high-risk patients, and one must use imaging in these patients. Both IVUS and OCT improve the outcomes. We have a lot of clinical outcome trials which have come. And the future will see a single catheter with IVUS, OCT, spectroscopic analysis, flow ratio assessment, and this will help us in a great way to optimize our stenting. Thank you.
Thank you, Dr. Chadda, for your very informative talk, especially regarding the newer advances in imaging, the hybrid technique, and all that. Thank you very much. Thank you very much.
Thank you, sir. Thank you.
If anyone has any questions, we can have them. But before that, can I make a small comment? Intracoronary imaging has become so complicated. Now I understand why Dr. Bahule started the SKIP in Kerala. Any questions? I'm totally floored. I mean, I thought I know OCT and IVUS, but it's going beyond that.
I think just one information, not about the talk. Dr. Chadda is organizing the next SKIP meeting, first time outside Kerala in Bangalore in November. I think I take this opportunity to request all of our help and guidance and coordination to Dr. Chadda for a successful, great meeting in the coming November.
I thank the organizers of SKIP for giving me this opportunity, and in particular Dr. George Koshi, who's on the podium. I will try my best to make it a nice meeting, and I expect all of you all to be there. I will be very, very happy to host you all in Bangalore.
Thank you. Thank you.
Thank you. Thank you.
So let us conclude this guest lecture. Thank you once again, Dr. Chadda from CSIK this year. Thank you.
So may I request you to kindly hand over a memento to Dr. Chadda, sir. Thank you very much to all the dignitaries on the dais. Move on to the next session. This is the annual oration. And it's my pleasure now to invite the chairpersons, Dr. Kunyali, Dr. Shashi Kumar, Dr. Johnny Joseph.
May I take this opportunity to hand over the mic to Professor Rajan Manyuran. I think the Best Paper Award presentation,
I request Ajit Kumar and where is Dr. Mohanan? PP Mohanan? Okay, we'll go. Jayagopal, how many prizes are there? Only one. Oh. ഒരു പ്രൈസേ ഉള്ളോ ജയഗോപാൽ ഒരു പ്രൈസേ ഉള്ളോ okay okay I think we had the best paper competition and the award is known as the best investigator award. There was a very tight competition between among all the 6 presenters, but only one can be chosen as the best paper. So the panel of experts finally decided that the best paper award should go to Clinical Profile and Predictors of Poor Prognosis in Infective Endocarditis by Dr. Bijoy Elias from Kottayam Medical College. Is he here? Is Dr. Oh, we'll go on in the end.
The annual oration now. Over to you, sir. Dr. Kunyali, sir.
Good afternoon, ladies and gentlemen. Now we have the most important session of the day, the annual oration by my friend, Dr. Shivashankaran. I wish to congratulate him for selecting such an important topic, which is generally not given much importance. Now, I request Dr. Shashi Kumar to formally introduce Dr. Shivashankaran.
Good afternoon, ladies and friends. Now, to talk a few words about Dr. Shivashankaran. Dr. Shivashankaran graduated from Trivandrum Medical College in 1984 with an outstanding student and with 9 distinctions in various subjects. Subsequently, he did his MD and DM Cardiology from the same institute and joined the Sri Chitra Tirunal Institute of Medical Science in 1994. In 2002, he was selected for an Oxford award for study, for training in interventional pediatric cardiology. And subsequent to that, that became the pillar to conduct the development of interventional cardiology at Sri Chitra Tirunal. And 2004, he was instrumental in starting a open heart surgical center at a remote village at Malappuram. His basic interest is in pediatric cardiology and lifestyle changes. He has over 100 papers in various index journals, and of which about 30 of them got very many awards. He has also written about 15 chapters in various textbooks of cardiology. He was the president of the Cardiological Society of India, Kerala chapter in 2013, and also was awarded a achievement award from the Rotary. He is also a co-worker in an interventional investigation program from the Sri Chitra, from the Achyutamenon Institute of Cardiac Sciences. Cardiac Science. In addition to all these academic achievements, Dr. Shivashankaran is a down-to-earth, humane person with simplicity, compassion, and kindness. If you meet him once, you will realize the sweetness in him. In addition to all those, after the retirement from Sri Chitra in 2020, he joined the Department of Cardiology at Manipal Academy of Higher Education. And even after retirement, even after continuing his professional job, he is still busy in looking after his grandchildren and educating them about the physical activities and its importance. Now, with all this, I call upon Dr. Shivashankaran to give the oration.
Very good morning to you all. I am so thankful to the chairpersons for those pleasant words. And the evolutionary concept for a balanced diet is very interesting. Essentially because there is a great mismatch between our old genes and the processed foods which we provide. The genes provides the metabolic basis, and the human evolution was quite gradual. It took about 3 million years or 80,000 generations for these genes to express, and the difference from our common primate ancestor, the genes expressed, is only 1.4%. But the outcome was a brilliant brain. This brilliant brain engineered the agricultural and industrial revolution. And the industrial revolution was quite rapid. It took only 300 years or 8 generations to provide these processed foods. It is essentially sold only with the essence of profit. This something which is sold with the intention of profit is now widely implicated in the NCD epidemic which we are supposed to treat. And this balanced diet is an effort to minimize this mismatch between these old genes and the presently available foods. Genes in evolution generated the brilliant brain, and the foods generated the brain at birth are now at crossroads with our cardiovascular health. The next 30 minutes or so, I shall briefly summarize how nature nurtured the dietary evolution of our brain under 3 headings: the omega-3 magic, the insulin resistance, how glucose became our brain fuel, and the challenges due to aquatic to terrestrial transition. This just illustrates how the processed foods are at crossroads with cardiovascular health, and then this will give us a blueprint for a balanced diet for a healthy life. The magic of omega-3 is well illustrated by our brain, the most fatty organ in our body, contains 60% fat, and 20% of the fat is constituted by the omega-3 fatty acids, the docosahexaenoic acid. We actually owe all this thanks to Bang and Dyerberg's original discovery and publication in 1971, when they went to Greenland, analyzed their dietary patterns, and showed that the Eskimo paradox, they have a low cardiovascular mortality, and that is constituted by the increased consumption of omega-3 fatty acids. As present 52 years down the line, omega-3 fats are the 6th most published molecule in medical literature as of today. And we now also know that Eskimos have a genetic adaptation to tolerate this high omega-3 fat. Now the next question is, how did omega-3 fat accumulate in the brain to make it that intelligent? Obviously, it was the availability in nature. In addition, nature provided in a press-cooked form in the forest fire. And nature also gave us the new enzyme, the delta-6 desaturase, which allowed the brain to accumulate this omega-6 fat. And the source could have been either aquatic or the terrestrial source. So the more important is the essence of cooked food. The cooked food made the food easily digestible as well as easily absorbable. So that may be the reason. If you had just followed the evolutionary track, intestine would have been double as long and brain only 1/3 the size. But the presence of this easily digestible and absorbable food, which would have been more palatable, maybe more hygienic also, we don't know, made the intestine half the size and brain incomplete. And that's the energy distribution that happened at that stage. That is why the elephant which is wandering in the forest has to forage for 20 hours and could sleep only 4 hours. But we have to give our energetic brain a rest for 6 to 8 hours. In this context, we should have a look at the heat stability of the fats we consume. We all know about the 3 types of fat. The saturated fats does not have any double bonds, so it is chemically more stable. The monounsaturated fat, which has got a single double bond, and the polyunsaturated fats, which has multiple double bonds. But the nature gave, since the polyunsaturated fats are liberally available in nature, nature gave the animals the ability to desaturate only after the carbon atom. That is why the omega-3 and the omega-6 fats became essential. Next thing which burns our mind is, why did nature prefer these chemically active polyunsaturated fats in their membrane? It was essentially because of their simple physical property, their melting point. The omega-3 fats, the melting point is -30. The omega-6 fats is around -11. Saturated fats, it is around 14 degrees. That is why you go and buy coconut oil in a cold place like Kodaikanal to get it as a cake. In this context, if you are a phytoplankton surviving in the sub-zero temperatures in the Arctic, you cannot allow your cell membrane to freeze. The food substances will not pass through. That is where nature opted for the omega-3 fats as its antifreeze in the cell membrane. As a result, it was a trade-off between their existence and survival. This phytoplankton exists because this omega-3 fat is in their cell membrane. But the moment an ultraviolet ray passes nearby, the temperature is heated, this double bond gets oxidized, the phytoplankton is no more. It is a trade-off between the existence and survival. So the nature opted for the omega-3 fats. It was good for the phytoplanktons in the Arctic. The fishes which consume these phytoplanktons are rich in omega-3 fats. The nature upgraded itself to omega-6 fats in the temperate climates and to the saturated fats in the tropical climates. It is chemically more inert and gives centuries of longevity to our desert plants. When the nature defined the cell membrane for the animal kingdom, it had to be more precise. So to allow for the passage of certain ions, it had to form receptors for the various cytokines and hormones. It by itself had to generate the prostaglandin. So it had to be more precise, so that any free fat entering the cell turned out to be a metabolic challenge for all the cell membrane. As a result, nature is trying to pack this into a perilife in a protein membrane and try to store it in the cell. That's the time cells has got the new advantage of storing energy. And nature used the single adipogenetic hormone, insulin, to store energy. That is how the fat body evolved in the arthropods to give them good mobility. So this fat body in the arthropods was designed by the insulin, now evolved itself into an endocrine organ, because nature wanted to know how much fat I am storing. So that is why when your body fat exceeds 12 to 15%, your leptin signals the hypothalamus, I have enough fat to mother a baby, you can initiate menarche. That is how it involves. And this fat body evolved into the major metabolic factory, the liver, as well as the reticuloendothelial cells. Common substance of the story is very simple. Every tissue has an adipose storage threshold, beyond which it initiates lipotoxicity and lipophagy. That is why the most energetic organ, brain, cannot store any fat. It depends on the adipose tissue for its energy. And in your liver cells, the fat globules accumulate, the pathologist will stain it and then tell you have got fatty degeneration or fatty infiltration. So every tissue in the body has got a threshold for lipid storage. Fat is better stored in the adipose tissue to minimize the metabolic challenge and body to know how much fat you are storing. So that when fat storage threshold of the adipose tissue is exceeded, now the fat body knows how to down-regulate its insulin receptors. I cannot store anymore. It secretes more adipokines. And that's the time your body tries to achieve, you are eating more, body asks you to store, adipocyte to store more and secretes hyperinsulinemia. That is the hyperinsulinemia of the metabolic syndrome which we see and is best measured by measuring your waist size. So your balance between your existence and survival is a very thin membrane, that is your membrane bilayers. If your cell has got a very active omega-3 membrane like the neurons, you need 30 times more antioxidants in that cell. Every axonal ending has more vitamin C and vitamin E. And the prostaglandins liberated are less thrombogenic and less inflammatory. The omega-6 fatty acids generate prostaglandins that are more inflammatory and more thrombogenic. And if you are consuming N3, N6 fats, keep them below the 10% of your calorie requirements. Preferably the ratio should be 1. And if you are using it for eating or frying, you will have to add a lot of antioxidant to keep them safe. If you are using saturated fats, keep them below 30% of your dietary calorie requirements. The presence of excess saturated fats leads to dietary dyslipidemia as well as metabolic syndrome. In fact, now we know that the trans fat even decides your outcome in sudden cardiac death. So we know that Asians consume more than twice the recommended dose of fish intake, and people living in Maldives use about 20 times more fish than what is recommended. And many of us who have worked in Maldives know that heart disease is very rampant there. The X-ray of a 55-year-old man at Maldives, we can see the femoral artery calcification. So now the studies in Maldives and Kerala has shown that fish consumption is not as protective as expected. And why fish is not protective is a big question. Could be because of the salt we add or the preservative we use, or maybe because of the accumulated toxins or too much of frying which we use to make the fish more tasty. In fact, WHO has released a recommendation saying that pregnant mothers better avoid the fatty fish because of the increased bioconcentration of mercury. Essence, the fat you use gets reflected in the lipid membranes of your body, and the RBC membrane is an excellent source to know what fat you consume the last 3 months. That is how the study from Costa Rica in 2005 categorically shown that excess palm oil consumption is associated with increased coronary events. So from the dietary fat, called this brilliant organ, the brain, as well as the excellent storage form, the adipose organ as a battery for our brain. Now the brain became more selfish. It asked the adipose tissues to release the excess energy using the adipolytic hormones, starting with thyroxine, epinephrine, cortisol, growth hormone, and glucagon. And this adipolytic hormone released the ketone bodies. The liver converts them to glucose. And this is what is physiologic resistance. The resistance to the action of insulin by the 5 anti-insulin hormone is the physiologic fasting insulin resistance. And the receptors are fine, insulin level is low. And this ensures that glucose is stored as fat only when the brain necessity is categorically met. In fact, the entire bird phyla evolved on this insulin resistance driven by the glucagon. So the ruminants, they eat the grass and hay. The bacteria in the ruminant pouch generate the ketone bodies. That is what perfused the brain. That was enough for them to act. But the brain became more energetic. The body asked for more ketone levels, but that was not possible because a blood level more than 0.3 millimoles turns out to be acidotic. It is in that context the brain evolved as the main glucose, main brain fuel, because it is less like eating proteins, and its blood sugar can be maintained at 20 times more, 3 to 7 millimoles per liter. It does not produce any pH or not much of osmotic challenge in that range. And in the avian physiology, they can tolerate a blood sugar level double. As I told you, they evolved on insulin resistance. And brain switched its energy source from ketones to glucose and developed specific receptors and mechanisms for its absorption. That is why Luke, who is suffering from type 1 diabetes, he takes insulin. He goes about playing and forgets his meal. The Labrador accompanying him recognizes that he is going into hypoglycemia and warns his relative it is time to feed him. And that is the importance of glucose for the brain. Simultaneously, like the omega-3 fats, carbohydrates had an equally important role in our brain evolution. Possibly the carbohydrate sources like cereal, millet and tubers got cooked in the forest fire and were served from the brain. As a result, the nature started duplicating our amylase enzyme both in the saliva as well as the intestine. The nature also provides carbohydrates in the form of glucose, fructose as well as sucrose, and from the animal sources as lactose. I will briefly touch all the importance of all the three sugars. And I said, nature duplicated our amylase enzyme both in the saliva as well as the intestine. That resulted in our craving for sugar, and that makes us different from our carnivorous friends who do not have the receptors for glucose like us. Like omega-3 fat, there is a genetic adaptation to the brain for its glucose as its fuel, as evidenced by the multiple amylase enzyme duplication. The complex carbohydrates rich in dietary fiber is the dietary source, and glucose being the brain food. Nature adapted the best mechanism to assimilate. That is why glucose has the best glycemic index. That is why to diagnose diabetes, you do the glucose tolerance. Glucose has a high glycemic index compared to other glucoses. You can compare the sucrose, it's only 2/3 of glucose, whereas you come to fructose, it is only 1/4, and lactose, it is less than 50% of glucose. So when the glycemic load is intense, body has to give an insulin surge to make the glucose level normal. At times even dips into a hypoglycemic. So this is the concept of glucose glycemic load and the glycemic index. And consuming large amount of glucose does not increase the glucose level further, but it maintains or sustains the glucose level. That is why we give 75 and 100 groups of glucose and see how long does the glycemic peak persist. Cannot increase it further because there is a saturation for our ability to absorb. So that gives us an opportunity to reduce the glycemic load by reducing the quantity as well as adding more dietary fiber will reduce its absorption. That is the most important part of understanding the glycemic load. So the dietary fiber can reduce the sugar peak of high glycemic index food. So glycemic index is the ability of the sugar moiety to rise the blood pressure, whereas glycemic load is the ability of the individual food substance to elevate the blood sugar, which is modulated by the dietary fiber content. And most fruits have a low glycemic load, but fruit juice will have a high glycemic load. So in a given serving, if the dietary fiber is more, the glycemic load is going to be less. Similarly, the fiber further prevents the glucose from being absorbed fast, keeping the glycemic load low. And the type of carbohydrate which you should consume should have a low glycemic index below 50 and a glycemic load less than 20. And that is what nature provides as the fruits, cereals and pulses. Whereas the food which we provide now as the cornflakes and the white rice has the both high glycemic index as well as glycemic. There are some substances like popcorn and watermelon which has got high glycemic index but low glycemic load. But the problem is that watermelon, one serving has only 30 calories, but popcorn has got 170 calories. Never supersize this popcorn. Similarly, when you are giving this sugar sweetened beverages, it is very, very pertinent to warn. It contains free sugars, which leads to obesity, diabetes, and tooth decay. That is how it is sold in California. So high fructose corn syrup and fructose in evolution is extremely important thing we should know because fructose has a low glycemic index. There is no need for insulin for transport. The keto sugar is 10 times more soluble in water. It gets metabolized in the first pass into the liver, gets converted into glucose, glycogen and fat, and essentially it mediates fatty. So consuming a lot of dietary fiber to reduce this metabolic insult is extremely important when you consume a fruit. That is why fruits are to be consumed as such. Making them in fruit and high fructose corn syrup is totally non-physiological. In fact, during two periods in ice age, because of the food scarcity, body had to adopt glucose as a source as its energy. Similarly, coming to lactose, milk is a secretion from a gland, the mammary gland, meant for lactation for mammals. And the ability to digest lactose, the lactase enzyme is supposed to disappear at the end of weaning. But we reintroduce the enzyme by repeatedly re-exposing ourselves to dairy products. But that also turned out to be a good thing because a new family of bacteria evolved, lactose fermenters. They colonize the intestine and they give you a lot of chemicals which make you most of the time maintain our sanity. So then we now know that there has been a lot of evolutionary adaptations, both fat as well as glucose. And it is this contest which yesterday we had a good look at this keto diet. We heard more about it in the talk yesterday morning. The keto diet minimizes only the initial glycemic load at the expense of the fat threshold as well as the crossing the limits of the protein consumption. Proteins generate a lot of non-volatile acids. It has to be excreted by the kidney, hence the body cannot tolerate a high protein consumption more than 2 grams per kilogram body weight. And the protein adapted animals, they have commonest problem undergo renal failure. And if you go into US, 700 cats undergo renal transplants every year. So there are good examples of metabolic syndrome in nature. One is the dolphin, which is now considered as an animal model for diabetes, as well as the polar bear. It's almost like Eskimos, it has got a genetic adaptation for the omega-3 fatty acids which consumes. So now we need to look back a little more back in evolution. The aquatic to terrestrial transition was a major achievement for animal physiology. As per the biogenetic law, we repeat the same during our birth. The ontogeny repeats phylogeny. We move out of the amniotic fluid to the terrestrial world. So when this happens, there are 3 important stress that happens. One is the gravitational stress. Now the blood has to pump, heart has to pump the blood against the gravity to the brain. And second is that the continuous placental parenteral nutrition getting replaced by intermittent enteral nutrition so that it has to have a more mechanism for storage. And third stress we undergo is the oxidative stress. Omega-3 fatty acids gives an oxidative stress, and by moving from the aquatic to terrestrial life, we have the second oxidative stress for our body. The oxygen content of water is only 0.5%, but the oxygen content of atmosphere is 18 to 20. You know that. It's a 36 times more stress. And all animals developed a variety of antioxidants starting from the water-soluble vitamin C and water-soluble vitamin E and so on. That is so they survived on the land. And when the primates evolved, the simultaneous evolution of color vision and the colored fruits provided a lot of antioxidants, and nature switched away our ability to synthesize vitamin C. That is why we are heavily dependent on naturally available fruits and vegetables for our antioxidants. That is how possibly the first human trial that would have happened in 1800s was by Dr. James Ling, who used to travel with the sailors around the world. They used to travel for a year or so, 1,400 of them used to die. He did the randomized trial. Those sailors who consumed the citrus fruits, they survived. And those who refused to take citrus died. And if the statisticians were there, that would have been the diet trial with the best p-value you could see. That is why when you balance your diet plate, half the plate should be colored fruits and vegetables. It should be sprouted grains, and the fiber-rich fruit should form the half the plate. And if you're using the calorie-rich fruits, make them as cereal substitute. So the second important stress the body faced was the need to store whatever you eat, because you eat only intermittently. So for that, nature developed the ingredient system. For the same amount of glucose you give parenterally and orally, oral glucose elicits 6 times more insulin, essentially asking the body, adipose tissue, to store it. So there started the initiation of chylomicrons and the liver producing VLDL to transport the triglycerides in the size. That is transported to the rest of the body, comes back to the liver, gets transformed into LDL. And that LDL, that is the reason for elevation of LDL in circulation. At birth, HDL level is 40 milligram per deciliter. The LDL level is only 60 milligram per deciliter. Once the enteric functions takes over, the LDL goes above 100 milligram per deciliter. and elevation of LDL by HDL ratio more than 2 is an important sign that the enteron liver in the gastrointestinal system has taken over as the enteral nutrition. So the summary of the aquatic to terrestrial transitions are 3 important points. The LDL to HDL ratio more than 2 becomes a marker of the enteric nutrition. The enteric nutrition gets exaggerates the insulin response by the incretin system, and there is a heavy dependence on the antioxidants that are naturally available. And it is in this context hypertension and deep frying turns out to be counterproductive. The heating and deep frying of foods destroys the antioxidants. We know that the ghee is a good source of only cholesterol oxides which your body cannot metabolize. The best example of hypertension causing damage is the coarctation of aorta. There is narrowing of the aorta. Below the narrowing, the blood pressure is low. Above, the blood pressure is high. For the same lipid level circulating in the body, atherosclerosis is intense before the coarctation, where the blood pressure is high, whereas the vessel below is clean. That is how the blood pressure and the way we cook modulates our disease process. So the aquatic to terrestrial transition sets the stage for the blood vessel disease, the atherosclerosis. The LDL is produced by the liver, has to be removed by the liver. And the atherosclerosis is precipitated by the oxidative stress and blood pressure because of our terrestrial living. So that is why in 2000, when Davis delivered the lecture, he argued that atherosclerosis is a liver disease of the heart. That is why all the anti-atherosclerotic or treatments which we use actually ask the liver to remove the LDL molecules and excrete the excess cholesterol. So the cardiovascular health is at crossroads with our brain evolution. Brain evolution facilitated the rapid urbanization, industrialization, and the sale of the processed food where we refine the food, we try to preserve the food, we fry and deep fry and sell it as bakery products, reheat and supersize, and we add the so much colors and preservatives. The worst thing was the trans fats, the technology that failed mankind. I said that the omega-3 fats are extremely important for the brain. They have a double bond. The hydrogen bond is on the same side. You can see that the cis transplant, which gives a C-shaped bend for the molecule. This is extremely useful because it doesn't pack the molecules and make them into a solid. If you twist the molecules, the hydrogen action on the other opposite side, the molecule becomes straight. You can make the molecule easily packed. That is how dalda and vanaspati is generated, and that is a favorite for the industry because no microorganisms can grow in it. And it is very tasty, but it creates havoc in the cell membrane, totally deranges the metabolism, and even it increases the chance for sudden cardiac death. As I said earlier, the RBC membrane gives you the type of fat which you consumed over the last 3 months. It is in this context we went on arguing which is the culprit. All of them has contributed. It's not only the sugar and fat, but also the carbohydrate, cholesterol, the sugar, the salt, the trans fats, and the fat we consume. After the Second World War, there has been a steady increase in the cardiovascular epidemic. The age-adjusted cardiovascular mortality has steadily increased all over the world. And the study in 1967 categorically showed that those countries which use more sugar and fat have the highest cardiovascular mortality, and the countries which use the lowest carbohydrate, sugar and fat has the least cardiovascular mortality, published as early as 1967. But people joined case and went for the bandwagon, the fat is the culprit, and those across the Atlantic joined Yudkin and thought that carbohydrate will be the culprit. But it was Jacobson in 1972 who categorically coined the term junk food, the food to which our biology is not evolved. The food rich in salt, sugar, oils and calories that is generated by industry are the junk foods. Because nature never expected our system to extract sugar from the sugar cane or refined atta from the cereals, salt from the sea, oil from the oil seeds, or fruit from fruit juices, or planning to ferment the alcohol. So essentially, the junk foods are in conflict with our old genes. 3 billion years of evolution, we evolved from our ancient primate to a brilliant man. But 300 years of industrial revolution, we transformed ourselves back to the ape size. And that one single generation, 30 years of our screen time, we transformed the Keralites into this shape. So the blueprint for a balanced diet is very simple as per the evolutionary concept. The protein content should be less than 2 grams per kilogram body weight. The omega fatty acid should be less than our 10% of our calorie requirements. The saturated fat should be 20% of their calorie requirement, and complex carbohydrates should be less than 50% of our calorie requirement, should be with a low glycemic index of less than 50 and low glycemic index less than 20%. And fiber root fruits and vegetables should form more than half the plate. So when you go to the diet plate in the afternoon, take a handful of fruits and vegetables. And if you're taking cereals and pulses which are rich in calories, take only a wristful. And if you're going for the more energy-rich product, egg, meat or milk or whatever, coconut and whatever it is, take only a palmful. And all the marketed products, take only a pinch. So in the last 30 minutes, I have just tried to summarize what happened in your evolution. It's essentially possibly a paleogenomic or archaeologic evidences which are putting together. The first thing that happened was our brain expansion because of the omega-6 desaturase gene and the increase in our energy requirement as provided by the amylase, lactase and the food cooked in the forest fires. I took back in history when our gluconolactone oxide enzyme disappeared, making us dependent on vitamin C, as well as uric acid enzyme disappearance, again making us dependent on fructose for our metabolism. And that brain generated the agricultural as well as the industrial revolution, making the obesity the commonest man-made problem. But there is one more interesting gene, the CMAH gene, which affected our glycoproteins in our body. This of this enzyme took away half of our glycoprotein synthesis. That essentially made us escape from the bovine plasmodium. But then this plasmodium again adapted, became the falsifier, and only affects the human being. So all the three things were important for our evolution. And the last 30 minutes, I just summarized our brain evolution has come to crossroads with our cardiovascular health. And thank you so much for your patient listening.
Professor Dr. Sivashankaran continues to amaze me for years and years. ഞങ്ങൾ പഠിക്കുന്ന കാലത്ത് ഞാൻ കോട്ടയത്താണ് പഠിച്ചത്, ഒന്നിച്ച് പഠിച്ചതല്ല എങ്കിലും അന്നറിയാൻ കേട്ടിട്ടുണ്ട് ഡിസ്റ്റിങ്ഷൻ സ്വാമിയെ പറ്റി. The amazing number of awards he was and the distinctions he was getting. പിന്നെ ഒന്നിച്ച് വർക്ക് ചെയ്തപ്പോൾ ഇത് ഫ്രണ്ട്ഷിപ്പ് he amazed me. പറഞ്ഞല്ലോ 8 ജനറേഷൻ ആയുള്ളൂ നമ്മുടെ അഗ്രഗേറിയിൽ നിന്ന് മാറിയത്. ശിവശങ്കരൻ്റെ 4 ജനറേഷൻ എനിക്കറിയാം. ഇവിടെ മരുമകൻ ഭാർഗവ് ഇവിടെ ഇരിപ്പുണ്ട്, ഉഷ ഇവിടെ ഇരിപ്പുണ്ട്. സോ the friendship he has kept with many of us is it's an amazing thing. Anytime a resource person to look at. And even though he has been in the interventional cardiology and all, his passion for preventive cardiology and going to the masses with more than maybe 5,000 to 500, more than 500 lectures given to the common man without any support from any of the institutions. By his own motive is again amazing. ഇപ്പോഴേ എനിക്കൊന്നും മനസ്സിലാകാത്ത കുറേ കാര്യങ്ങൾ താത്വികമായിട്ട് പറഞ്ഞിട്ട് എന്നെ ഇപ്പോഴും അമേസ് ചെയ്തുകൊണ്ടിരിക്കുന്നു. ഇതിൻ്റെ അകത്ത് സന്ദേശം എന്ന സിനിമയിൽ ഉത്തമൻ കോട്ടപ്പള്ളിയോട് ചോദിക്കുന്നൊരു ചോദ്യമുണ്ട്. ഇന്ന് ഈ CME വന്നിട്ട് ഇന്ന് ഉച്ചയ്ക്ക് എനിക്ക് എന്തെങ്കിലും കഴിക്കാൻ പറ്റുമോ, കഴിക്കാവുന്ന എന്തെങ്കിലും ഉണ്ടോ? അവിടെ നാഷണൽ ലെവലിൽ WHO ആൽക്കഹോൾ CME അവോയ്ഡ് ചെയ്യണമെന്ന് പറഞ്ഞിട്ടുണ്ട്. ശിവശങ്കരൻ ഇതും കൂടെ പറയുമ്പോൾ ഞങ്ങൾക്ക് എന്തെങ്കിലും കഴിക്കാവുന്നതുണ്ടോ? Questions as a customary questions ഇല്ലാന്ന് തോന്നുന്നല്ലേ? Thank you Shivshankaran. Thank you my co-chairs, everyone. Thank you for the excellent lecture you had. We had a wonderful time.
Thank you to our esteemed chairpersons. Thank you, Shivashankaran sir, for that 30 minutes of unadulterated information. We move on to our next session now, the expert corner. May I please invite the chairpersons for this session, Dr. Bijulal, Dr. Jayaprakash, Dr. Krishnamurthy, Dr. Saji Kutkulam, Dr. Suresh Kumar, and Dr. Shafiq Mattumal, please. Once again, may I remind the presenters and the chairpersons, we are running late by more than half an hour. So kindly stick to your stipulated time. And with the proceedings now to our esteemed chairpersons.
Without losing time, KK, I'll invite you straight away to start the session as we are running behind schedule. Dr. Krishnakumar does not require introduction to this crowd. He will straight away go to the topic of demystifying TAPVC. Over to Krishnakumar.
So I'll just, this can be misspelled also. It's not just demystifying, but demythifying. And there are lots of myths that need to be dispelled as much as the mystique of this illness. But the key messages will be just 5. It's often missed and mislabeled by all of us. All of us are guilty. The pediatrician, actually the least guilty. They can suspect it, but they may miss it, but they cannot be held guilty for it. Cardiologists are the most likely to commit the error because they will label it as persistent pulmonary hypertension because there is a certain nuance to imaging it. And even I, as a pediatric cardiologist, in one instance, have missed this diagnosis, and I will share that with you because that's also a pitfall that we have to be conscious about. The vast majority of infants, even in unobstructed total veins, are likely to have pulmonary hypertension. I will show you with some good data on that. The obstruction at atrial septum is commoner than believed, and I'll explain why. Mortality is very high. Don't get fooled by the survivors that you see. This disease kills. For every survivor that you see, there are many who have died. So it's a very, very fatal disease and it needs to be respected. And contemporary surgical results are excellent. So it's well worth investing in saving these babies because they can lead normal life. These are the key messages I will be giving through examples. I'll start with the first one, the most important one, because I think that's the message that needs to go out today. This is a 13-day-old child who presented to us, birth weight 1.65 kilos, admitted to a NICU in view of low birth weight, but developed respiratory distress in a few hours of life, required CPAP within 8 hours of life, and the X-ray was like this. I wouldn't blame the neonatologist who thought that this is a RDS and started surfactant because of suspected lung immaturity, even though the child was term, wasn't preterm, but it is appropriate in their thinking because that's far commoner. But then the child didn't improve. In fact, went off but had to be reintubated. Worsening distress, increasing oxygen requirement. This is where the cardiologist did the echo was guilty of having missed because they found severe PAH. Now it's important that in this context, when you see severe PAH, you should seriously look for TAPVC and made the statement that the pulmonary venous drainage is normal. The child was sent with the diagnosis of PFO, severe PAH, and possibly PPHN. The child then went to another center, one NICU to another. And now things got worse. Mechanical ventilation, high ventilatory setting, HFO, and all the neonatal complications, suspicion of NEC, intracranial bleed, seizures, got a whole potpourri of medications. Child was worsening, sepsis thought of, but then somebody had the sense to get a repeat echo that showed that there was a suspicion of TAPVC because they saw the common chamber and referred to Amrita. They came to us, child was received on a ventilator, wasn't too bad, the blood gas was reasonable on arrival, but then there was all these non-cardiac issues that we were worried about, sepsis, intracranial bleed, because there was a long ICU stay prior to this. Nonetheless, the child was received, we did an echo and that showed this exclusive right to left shunt across the PFO. That got us very concerned, and of course we found this common chamber in the vertical vein that you can see. I don't have the moving images because this was from some time ago. And then the important thing is that this drainage via the persistent ductus venosus, seen in infracardiac TAPVC. Now this combination that you look for in the liver is clearly suggestive of infracardiac TAPVC. The patient then was, unfortunately we couldn't move quickly to surgery because there was this background of sepsis, seizures, all kinds of things, so we needed 5 days to stabilize. And finally, we operated. The timeline is like this. The child came with distress, spent some time in one institution, moved to another institution, had 15 days of mechanical ventilation prior to surgery, and finally got operated in our center on day 13. So, day 17. 15 days of mechanical ventilation, 11 days of mechanical ventilation prior to surgery. On surgery, wasn't great anatomy. Our surgeon found that this was indeed infracardiac TAPVC, but it was very small common chamber. So they did what is known as a sutureless repair. The sutureless repair, if you can see in this right hand side, stitches are not taken at the edge of the incision that is made on the common chamber, but on the surrounding pericardium to prevent restenosis at this junction. But it is taken on the edge of the left atrium. So through this new technique, one is able to avoid restenosis, which is particularly likely in this category. The story of this child obviously was very difficult after surgery because the child was quite ill, quite small, and spent too much time on the ventilator prior to surgery, so had lots of issues, edema, sternum had to be reopened, had to be closed, and spent a long time in the ICU and eventually got extubated on post-op day 17 and eventually went home, but went through a rather difficult and challenging post-operative course entirely because the disease was missed the initial phase. So that is the lesson really, that the price that you pay for missing the diagnosis is either death or a lot of disability and morbidity. So the clues to TAPVC is that, one, if the echo report does not match the clinical picture. Corollary is, when you do echo divorced from the clinical setting, you're likely to make the error. So you should have an explanation for the clinical findings. Why is the child cyanotic? Does the X-ray picture match my description? When I say, okay, this is not TAPVC, have I looked at the X-ray? Make sure it's not the case. So that needs to be integrated, very important. And then exclusive right to left flow across the PFO is a very strong indicator that you could be dealing with a TAPVC. Because this is a situation where it's physiologically impossible for the PFO to shunt in any other direction. Then of course you can see the common chamber, you can see the drainage. Important thing is you use neonatal transducers. Higher the frequency, the better it is, because those structures are so thin you may not see it in adult transducer. Important. High frame rates, because these babies need 60 to 100 frame rate. Make your image biggest possible in the screen, zoom up on a small area of interest, and you will get high frame rates. Once you get high frame rates, you are likely to make less errors. Use color, use narrow sectors. Of course, you can demonstrate the drainage. So here are some examples that I'll show you. Here is an example of where you can see there is an exclusive right to left flow across the PFO. The subxiphoid view, this is the right atrium, this is the eustachian valve, the atrial septum, and this is the right to left flow across the PFO. You can see some vigorous flow in the SVC, but this is the clue to suggesting it is likely to be a TAPVC. You can of course see the common chamber, the pulmonary veins coming together and then going upwards in this particular instance. And you will see this typical picture that you see in supracardiac TAPVC, or if it is infracardiac or any other place, this common chamber will find a drainage from another source. So these are typical pictures that you will see in very classic cases, but it can be very subtle. Now this is a case that I initially missed in an infant who was disproportionately ill from a diagnosis of an ASD. The saturation for some reason was 95%. This child wasn't significantly desaturated, but the child was extremely ill. So I fortunately called the child again and re-echoed and realized that this is an atrial septal malalignment, and very hard to pick up the blue across the septum when there is so much red from the pulmonary vein. So very important that we pay attention to all this. Second very important message is that the vast majority of infants, even with unobstructed TAPVC, you can have significant PA. In our own data, even in, we had 88% of patients who had severe PA, included a number of patients with unobstructed TAPVC. So here is why you can get obstruction in the TAPVC. It's much commoner than that is believed, because the septum primum deviates towards the lateral and posterior wall, and if you have a dilated coronary sinus from coronary sinus TAPVC, you can have an obstruction at that level and you won't pick it up. It is not at the level of the atrial septum. So because of the deviation of the septum completely going down there, you can get an obstruction, and that's why you have PAH in many of those circumstances. If you don't operate on TAPVC, it kills. You see the data from the 70s when people used to look at natural history, 90% of babies born with TAPVC died. So the corollary is never send a baby with obstructed TAPVC home without doing surgery. That's a crime. If you have a baby infant with obstructed TAPVC, if you can't operate, send it to another center but can't go home. That would be very dangerous. Even if it is unobstructed and there is PAH, you got to be very careful, and it's preferable to operate. Very, very important. In today's era, you can ensure very good results. That's what we find. This is a paper that we published. We just published our 10-year data. 316 patients, consecutive patients. Most of them are infants. Almost all of them are infants and many newborns. And we had a very large proportion of obstructed TAPVC in this particular study. And in-hospital mortality, we had out of 316 patients, only 3 deaths. 0.9% was the mortality. Unbelievable how many babies you can save, this particular subset. We had some morbidity, but overall these babies are doing superbly in the long term. So the contemporary surgical results are outstanding with TAPVC. If you look at the Kerala data, this is a study that is sponsored by Kerala CSI, the chronic registry that Deepa has shared with me. We had babies who had TAPVC, unobstructed TAPVC and obstructed TAPVC, 34 and 4 patients, and we found that the mortality in these patients was extremely low, 4.8%. It's outstanding across the institutions in Kerala. You need to be aware of that. Our TAPVC results are amongst the best in the country, and our own institution results are amongst the best in the world. So it's highly salvageable patients. You can't just send them home. They can be operated and they'll do superbly well in today's times, especially newborns. The key messages, once again, so one should not miss it because one should have a high index of suspicion. If there is PAH, the vast majority, the reason to respect this lesion. Obstruction is commoner, so you need to look at for subtle signs of obstruction. Mortality is very high. Don't send them home without surgery, especially if they're obstructed or they have PAH. And results are excellent. And so surgery has to be offered at the earliest, very much feasible at multiple institutions in Kerala. Thank you.
Thank you, KK. I think it's a very important point that you stressed, that neonatal echo should never be divorced from the clinical setting. And that will be the one single most important thing by which you will ensure that you don't miss this eminently salvageable condition with such excellent surgical results in our state. And I think one point, now that pulse oximetry is mandatory, in Kerala, in every baby which is delivered in a delivery point, the government has made it mandatory that pulse oximetry be documented and the results are being monitored by government organization. This has remarkably improved the pickup rate, where a neonatologist...
92% in the chronic registry, pickup of...
That is the point. So any questions from the audience to
Yeah,
Dr. Krishna?
I have a question. In what percentage of TAPVC newborns will there be TR? So that if we see a TR, we can go ahead and relook at it. So how do you...
TR is not the only reason you relook at it.
Yeah.
You may or may not have TR. TR is something which is just results from RV dilatation. There are other signs of pulmonary hypertension. You shouldn't entirely depend on TR.
Right to left shunt.
I
Right
can't
to
give
left
you
shunt.
numbers.
Right to left shunt.
No, it's the septal configuration, the right-sided dilatation and systolic septal configuration that tells you that the patient has pulmonary hypertension.
Because see, normally the right ventricle will be bigger. That's why I'm asking, because
In TAPVC, it's strikingly bigger.
strikingly big.
The other point that KK had mentioned, if you find that the PFO is shunting right to left, never take it for granted that PFO is shunting left to right. Look at it critically, especially in the clinical context. If it is shunting right to left, there is a very high chance of TAPVC. Otherwise, you need to explain why it is shunting so.
Can you explain a little bit more how we see infracardiac TAPVC? I have diagnosed newborn supracardiac, but not infracardiac
So
till now.
you see a chamber between the aorta and the heart. You'll see a big chamber that comes into the liver, and you can actually follow it, and it's usually showing you very obvious red flows. And then you can track it to the ductus venosus. If it is ductus venosus, usually you see lot of turbulence in the ductus venosus. If it is patent, if it's closed, the child is usually very sick, but you can find it.
Thank you, Krishna Kumar, for the wonderful work and wonderful job. Now we'll move on to the next talk. May I invite Professor Dr. Bahulain, Intermediate Lesion Assessment Beyond Physiology.
Thank you, chairpersons and the CSI organizers for giving me this opportunity. Now, intermediate lesion, when I say it is 40 to 90% angiographically stenosed, that is intermediate lesion. Let us start with a simple case which you see. This is a patient with inferior wall MI, RCA primary angioplasty, but LED prox shows a intermediate lesion, which is slightly complex in the angiography. Naturally, when we see and address the question of non-corporeal lesion, we do functional assessment, and the FFR is 0.83. That means the lesion is not functionally significant, no flow limiting lesion. But should we stop at that level? Today, you listened from Professor Chadda that we should do the imaging. The imaging shows what all things. It is actually a lipid-rich plaque. More than 180-degree arc is constituted by the lipid, because the plaque characteristics can be made out very well. It has got a plaque rupture, it has cholesterol crystals, it has macrophages and healed plaque. These are all characteristics to say that the plaque is a vulnerable plaque. So FFR or functional assessment doesn't reveal that. You are not doing an angioplasty for this patient, but you are leaving the patient with a high degree of residual risk for a future event. Now that is evident from one of the largest trial you must have read on, the Sweetheart trial. 5 years data have come. When they deferred patients on the basis of FFR of 0.80 and IFR of 0.89, they found that 5 years event rate is 19%. So we are missing out something there when we leave the lesions without doing PCA on the basis of functional assessment. Now from 2011 onwards, this issue of plaque characteristics has been addressed in Prospect First study. In about 700 patients with ACS, they found that over a period of follow-up of 3 years, roughly 20% of patients have got MACE rate. Out of this 20%, 50% were due to angiographically non-culpable lesions, which you think they are innocuous, which it is not correct. And when they assessed these lesions by intravascular ultrasound, they detected that a large plaque burden of more than 70% and a small luminal area of less than 4 millimeters square, and a thin cap fibroathyroma defined as less than 65 microns, which covers the plaque. There are 3 important parameters which predicted the outcome of these lesions. And further, after about 10 years, the same group Prospect 2 trial, they looked at the natural history of these plaques. The thin cap fibroathyroma identification by IVUS was difficult, so they used what Dr. Chadda showed, that this was the NIRS, that is near infrared spectroscopy imaging, that is what is used on the side, wherein you can find out the
lipid core, you can see that yellow plaque, which is the axial distribution as well as the circumferential distribution can be made out of that yellow plaque. Quantitatively, you can find out the maximum lipid core burden index over a period of 4 millimeter of the lesion. And that in this study was cut off as 324 and odd, and they included plaque burden and mid-luminal area and assessed the natural history. They found that when the lesion which is non-flow limiting has got two aspects of plaque burden more than 70 and a the lipid core of higher nature, they found that event rate was higher over a period of 4 years. So they could predict lesion-specific as well as patient-specific event potential. So therefore, you can identify vulnerable plaque, vulnerable patient if you are looking closely at these aspects. Similar time itself, Waxman has published a lipid-rich plaque study using, again, nurse study, but here US LRP of more than 250, and found that when the plaque is having lot of lipid pool, patient level as well as lesion level, the predictivity for future events were higher. Now that is the story of IVUS. OCT has come, you found that it has got more granularity, more resolution. So they looked at this particular study from Italy, showed that 4 characteristics that they have taken: minimal luminal area, thin cap fibroaderoma, lipid arc and macrophage. And when the lesion, that lower lesion, you find that LAD has got an intermission lesion in 2014. But that lesion OCT showed 4 features satisfied and found that within a year, that lesion has progressed to severe nature with a potential of events. Whereas the upper panel shows the lesion intermediate has got only 2 plaque characteristics, and over a period of 1 year, there was no progress. So the more number of high-risk plaque is being harbored by a non-culprit lesion, which is non-flow limiting, it has got the potential of producing important event. Recent study of combined OCT FFR, Elvin Khedi has published this trial. He did a study on OCT and FFR in intermediate lesions in diabetic patients. And they found that less than 0.80 FFR, it is significant straight away angioplasty. More than 0.80, that is non-flow limiting lesions, put into 2 groups after OCT. Thin cap fibroaderoma positive lesions, thin cap fibroaderoma negative lesions. And you look at the left side panel, thin cap fibroaderoma positive cases have got higher event rate during around more than 500 days of follow-up than thin cap fibroaderoma negative. So it's important to identify this sort of plaque characteristics. Recently, latest 2023, he has analyzed that thin cap fibroaderoma group again for more plaque characteristics and found that there are 3 important other aspects apart from thin cap fibroaderoma contributes to the high potential. One is the upper one, small minimal luminal area of 1.80, and FFR itself is towards 0.80, like 0.85. The potential is more. So also he found that prevalence of healed plaque was higher in those patients who have got MACE. And they found that thin cap fibroaderoma more appeared in proximity to the lesion area with lowest minimal luminal area. So I think you can go more and more into analysis of this and find out which lesion is to be tackled. Look at this case. This patient came, I think Dr. Srivas must be remembering, a few weeks ago to us with angina. This patient had got high-risk features, hypertension, diabetes. She had an earlier treadmill positivity. LAD shows, you will find that there is a borderline lesion in the mid-LAD. There was debate whether we should send or not. At that particular stage, I didn't do a functional assessment. I just went away into OCT, and you will find that the characteristics, plenty of high-risk factors, lipid-rich plaques, spotty calcium, thin cap fibroaderoma, which is less than 65 microns, plaque rupture, healed plaque, macrophages, and cholesterol cultures. I said, no, we have to do stenting for this patient and stabilize that patient stenting. Stenting done by OCT guided stenting. It should be called as a perfect stenting. Because you should not say that unnecessary stent invites more problem. But if you perfectly do with image guidance, the problems of stent is less. Now, do we have evidence to say that such treatment for identified high-risk plaque is there? Well, we have FORSAT trial. This is a single-center trial from Spain, but it is a study between FFR and OCT, and they found that when the OCT characteristics are taken For decision of PCI, they found OCT-guided PCI has been superior to the FFR-guided PCI, but it's a costly way of doing PCI. The prospect trial also had an interventional arm. They also identified non-corporal lesions, but they found when those non-corporal lesions with high-risk plaque characters are treated with Absorb versus guideline medical therapy, they found that those treated with Absorb stent, when they analyzed 25 months downstream, down the line, MLA assessment at the site of minimal luminal area at the time of treatment inclusion, they found after 25 months, the MLA has really increased in the BVS group. Although it was not, intended for looking at the clinical details, we found that the treated Hoover has lesser MACE. So there are some signals strong enough to say that we should have larger studies to address this issue of finding out whether recognizing these high-risk plaque characters are really to be treated with mechanical ways of stenting or only giving to large doses of cholesterol-lowering agents like PCSK9. I think we are having two important studies addressing this issue. One is combined intervene trial design. Again, the Alvin Katie's group. Here, he has got larger number of patients. He has included the plaque characteristics with minimal luminal area of 2.5 millimeter less and plaque burden and try to look at whether angioplasty is useful in this case. Another study is vulnerable trial. In STEMI patients, more than 50% we have non-corporal lesions. And many of them may look like a non-functionally significant by angiography. But imaging will show that they harbor a lot of culprit plaques. And such cases, in this case, the ThinCa fibroaderoma is utilized to randomize into PCI versus medical treatment. So I think when these results come, the things will become clear whether recognition of these plaque characteristics by imaging is it important, and to make a decision on treating it based on that is important. I would conclude by saying that MACE and angina is common even after IFR, FFR usage and deferring cases on the basis of that. In the beginning, 10 years ago, when we started using functional assessment, I was very happy that if you leave a lesion on FFR 0.8 above or IFR 0.89 above, you are doing the best thing, which is probably not correct. We have to have imaging done, and characteristics of the plaque also is important, because the functional assessment only shows about the ischemia. It doesn't give you the predictive value of events. That is what we are seeing now. It is becoming clearer to us. As a clinician, we are impressed by that. So IVUS, OCT, or NIRS, near-infrared spectroscopy, can detect these high-risk characteristics of these no-flow limiting lesions. You should have the mentality to do it in the cath lab. So it is time to combine physiology with intracoronary imaging in assessing intermediate coronary lesions. I am repeating the conclusion made by Chadha in his talk. So thank you very much for your patient listening. Thank you.
Thank you, sir, for the new information and very detailed talk. I just have a question. Then what is the future of FFR going to be? Because even if the patient is FFR negative, in the two lesions which you have shown, the first one is actually an irregular, angiographically itself it is irregular and unstable, and the second one is a smooth plaque. Both the patients showed a high-risk characteristic like TCFA and high plaque volume. And then what is the role of then FFR for the future? Because even if the value is 0.86 or 0.87, we still have to do it and follow up with an imaging, especially with an OCT, and then go ahead or not. It's actually the OCT is the decider, not FFR value. Is it going to be a disruptor for FFR?
Yeah, I think Saji, very important question. I think you are very right. Second case, I decided that OCT is going to be the deciding factor. The first case, I did the FFR 0.83 and left it. But imaging showed the characteristics. That is evolution of our practice in accordance with the evolution of information and confirmation of what we have observed. And I think it will change. That's what I'm saying. I'm told
Sir, can I also answer that question?
No, please. Let me finish that answer, and then I can come.
We'll wait. Let sir answer first.
Yeah. The point is that in our own practice, that changes happens. And the second question, my belief is that FFR is not dead, only because of that. It has got definitely its value. Only thing is that FFR is also growing. When FFR started, it was only a number to decide on the lesion is to be treated or not. It has grown from there a lot. from, making pullback. Today, pullback is the standard of it. And you find out where to treat, where to make the stent, where stenting is quite correct or not, lesions left out or not. So I think it has grown a lot in the interventional practice. So FFR is going to stay on. And the third thing is that when multivessel disease comes in, I do FFR. If the FFR is, is negative, do the treatment. Positive, do the treatment. Negative, only this sort of issues comes. So when you have severe lesions 90 above, treat it. 40 to 90. Earlier it was 40 to 80. Now today is 40 to 90. Because between 80 and 90 also you have that small percentage which could be positive. Yes.
Sir, in
Dr. Nini, yeah, please.
Sir, in the middle of the talk, sir has forgotten what he does the best. FFR will be used for bifurcation lesion.
Yes. Yes. FFR makes the lesion, FFR as well as imaging, makes the lesion less complex and your procedure less complex. That's good for the patient. If you have a bifurcation and the side branch is totally negative, probably you can think of, doing a single stent provisional.
Sir, excellent information, excellent talk regarding the new things coming. I would like to ask two doubts. One, FFR negative. It's a multivessel disease with a culprit vessel, non-culprit lesion after a primary angioplasty, which sir has shown. FFR is negative, and the imaging OCT shows, or IVS shows a good MLA. MLA is good, but the other characters of the plaque burden is high, and there are features of TCFA. With the available data, would you proceed at the same sitting to do it or not?
Yeah, I think that again is with us, which was an idea which we were holding on. If you have poor plaque characters like a plaque rupture, and if the MLA is quite good, we used to leave it, right? Now that is why it is not only the plaque characteristics, the metrics are also being included into the decision making. Like MLA, most of the studies put MLA, OCT 2.5 less, IVUS 3 less. So I think the MLA also is coming into that. Similarly, the FFR value is a range. If you have a 0.89 value, you are more safe. If it is close to 0.85, you try to balance the case.
Sir, if the MLA is good, MLA is reasonably, MLA is good about
MLA is
0.5,
good. MLA is really good.
no plaque rupture also, but there are features of TCFA. Other
MLA
features
is?
of TCFA.
MLA?
MLA is 3. And plaque characteristics are of a TCFA. There is no plaque rupture as such.
Yeah.
Will you do it or not?
That's why one study which is using only thin cap fibroathyroma, not all the features. The last study which I mentioned in STEMI, the non-corporal lesions, FFR negative non-corporal lesions are classified into two. Thin cap fibroathyroma positive, thin cap fibroathyroma negative. And thin cap fibroathyroma is taken into PCI arm. So I think we are waiting for the results of that study, the last one which I showed.
One more thing, will you do IFR first and then go for FFR in a borderline values, or you
Today, either one of them. Either one of them. Because you have to believe one or the other. Unless you have some strong reason that the values are entirely very different, then you go do a FFR. Otherwise, mostly a non-hyperemic pressure ratio or a hyperemic pressure ratio.
Sir, which patient with negative FFR and intermediate lesion, you will go for imaging? You have an intermediate lesion.
That's what we've shown, that if you have a lesion which is intermediate and if the functional assessment is showing that it is FFR negative, right? And that patient's FFR negative lesions, you can do an imaging, and the imaging is showing all the plaque characteristics, then you can treat it.
Thank you, sir.
FFR negative case.
Anything? Thank you, sir. Thank you, sir, for the wonderful talk.
So one question can I ask? Yes. So with your vast experience, can you give me a prediction? Can you tell me a prediction? 10 years down the line, where will all these three investigations be? FFR, IVUS, and OCT. Will they stand the test of time? Which all will be there 10 years down the line? Do you think CT will come up in a very good way?
I'm not clear, yeah.
Do you think CT will come up in a very good way? 10 years down the line, can you tell me a prediction? Which all these investigations will be still relevant? Will everything will be replaced by CT?
Yeah.
What is your prediction?
Prediction would be the heart flow will come to stay on. Heart flow, which is using on the CT-based functional assessment, as well as the lesion morphology assessment. Both are being worked out. Initial works have come up that it is going to be useful, and maybe 10 years down the line, cases will have the report from the CT lab of all these aspects. You will go to the lab only which lesion is to be tackled, what length of the stent should be placed, and from where to where it should be placed. So with a lot of information, the interventions goes to the cath lab.
Thank you, sir.
Thank you.
Thank you, sir, for giving us a wonderful lecture.